After this minute of silence, every day we thank to our defenders, especially who are on the front line, for this opportunity to have this meeting, that we have another meeting here in Odessa in spring on our Fілатовські readings. From our organizational committee, on my behalf, I want to greet you, my dear colleagues, our guests who join us with the opening of our International Scientific and Practical Conference, Філатовські readings. Today, it's not another one conference. We have an anniversary, 150 years from the date of birth of academic Filatov. His name was listed and inscribed with golden letters in the history of both local and world ophthalmology. He developed new methodology of treatment of eye disease. He launched the school of talented students who followed him. So I hope that today's our Філатовські reading will be a bright event in our professional life. And today, tomorrow, we will have a lot of events, plenary sessions, reports, workshops, exhibition, all these in order for you to be entertained and to get new knowledge. We wish one another good and fruitful days of this cooperation, successful cooperation, discussions, interesting discussions, new meetings, new impressions. Let's wish one another health and health to our patients, which we want to support. Let's God bless you as the opening of our conference.
найважливіший досягнень медицини ХХ століття.
Cornea transplantation is one of the best investigation and opening of 20th century, and our scientists spent a lot of years in order to improve this surgery. One of the beginners and pioneers are Carl Gienel, Franz Resengier, Edward Konrad Zine, Anton Lenzschmiger, and Alexander Szymanski. Their investigations were the fundamental of corneal transplantation, but the main place and special place is of Volodymyr Filatov. He dedicated his life to resolve this issue.
Як писав сам Філатов,
As to his own words, his investigations are the brilliant pages of scientists among all scientific words. His way began in 1920. He was the head of departure, and it was his first surgery on cornea transplantation. This case was presented on March 13, 1920, on the meeting of Odessa Association of Ophthalmologists. Then we have another historical data. Volodymyr Filatov performed first penetrating transplantation using his own developed instruments developed with Marcinkovsky engineer FM3, FM4, and they provide new level of security during surgery. Except of scientific and technical interventions, he provides a lot of science where to perform this surgery and new antiseptics. Then he launched new material and he expanded the grafts of cornea. And here you can see the donor material presented by Volodymyr Filatov. In 1936, Ukrainian Institute of Experimental Ophthalmology was launched, and Volodymyr Filatov was his director. It consisted of two departments. It was Department of General Pathology and of cornea transplantation. And here there were two laboratories launched in Ukraine on conservation and preparation of tissue, and it reached the world to the new investigation and openings in the treatment of eye diseases. Thank you. And now we give the floor to Ms. Halina Drozhina. Dear colleagues, we are happy to greet Jose Guel from Barcelona, Spain. His specialization on transplantation of cornea, refraction and reconstructive surgery of anterior chamber of anterior part of eye. He is an associated professor of Barcelona University, and he managed the Institute of Microsurgery in Barcelona. He was the president of ICRS and Eurocorner, and now he's a director in both companies. He also moderates and modulates both segments. So we give you the floor to present your lecture. Visco-Dalk, the best approach to keratoplasty when endothelium is healthy.
Well, good morning.
Morning.
Could you hear me?
Yes, we hear you well.
Okay. So good morning from Barcelona. First of all, I would just like to thank the Ukrainian Society for the invitation. It is an honor, obviously, to present a Filatov lecture, being he, as you have nicely explained, probably one of the most important pioneers in corneal surgery in the world, but particularly in Europe. I would also like, as a trustee of the ESCRS Society, as the European Society of Cataract and Refractive Surgeons, which used to have a strong connection with the Ukrainian Society. I just wanted to let you know that we will definitely continue supporting as much as we can, and this is one of the goals of the ESCRS that we recently met in Copenhagen, and we decided as trustees of the society to continue with this cooperation. So again, many thanks for your invitation, and I will focus my lecture as a corneal surgeon in viscobubble DALK. These are my financial disclosures, but none of them is related with this talk. Well, first of all, and to situate what I'm going to talk about, DALK has obvious advantages in front of full thickness keratoplasty in any eye with a healthy endothelium. First of all, the perioperatory risk is much lower, so expulsive hemorrhage is almost impossible, and you have the anterior chamber stable during the surgery compared with a full thickness transplantation. Visual acuity and optical quality results are quite similar, but graft survival, again, logically, is much better for DALK in front of PKP because having not transplanted the endothelial layer, the rejection episodes are extremely rare, and the progressive endothelial cell loss that we classically observe after a full thickness transplantation or after any endothelial kind of transplantation, it is not observed after DALK. And also, in case of re-intervention, which might be relatively common, for example, in some stromal dystrophies, because they are recurrent, the reintervention safety is much higher than the reintervention in full thickness keratoplasty. So it is obvious, or I think most surgeons in the world, that DALK is an advantage in front of full thickness when we have a healthy endothelium. And we as corneal surgeons should be pushed to use this technique instead of full thickness. So this is not something that we know recently. We are aware of these advantages since about 10 years ago, as it was clearly stated in, for example, the not the last, but the pre-last edition of the cornea book in 2017. So the problem with DALK and the main limitation for its use in front of full thickness is its surgical difficulty. In order to reach the most posterior layers, when we try to do deep anterior lamellar keratoplasty, there has been different surgical strategies suggested since the late 90s, using water, using viscoelastic, but in fact, it was when Ambar, a very elegant Egyptian ophthalmology, but working in the Middle East, described the technique of the big bubble. He described the technique using air and a needle, and it was the first technique where it was basically focused to directly dissect at the level of descemet, which obviously from a visual point of view has a significant advantage in front of any other deep dissections that are not reaching decimal level. After him, several other surgeons, including San Nicola from Italy, Tan from Singapore, Fogla from India, many others have described different variations of Ambar original technique. And I am going to focus on a technique where we described, also Shimura described in Japan, using either a cannula or a needle, but using directly viscoelastic to reach the dissection. The technique, as you can see in these two vignettes, short vignettes, it's basically once we have removed the 2/3 anterior thickness of the cornea, then use a needle to inject directly viscoelastic and create this big bubble. We will then decompress the anterior chamber because the dissection maneuvers will be much safer. And we can open this bubble without any fear of having a rupture because this bubble is, as I mentioned, plenty of viscoelastic. Then with the eye in soft conditions, constantly in soft conditions, we dissect these layers and we remove all the stroma, trying to reach the vertical cut because as cleaner this peripheral cut, the easier the adaptation of the donor lenticle, and so the better wound behavior and the better future astigmatism control. Obviously, not always we might have this big bubble dissection. Sometimes we have this, as you can see on the right hand video, a small bubble dissection with the visco, and then we should continue from this small bubble with manual dissection, a little bit slower, the dissection, but anyway, because with the small bubble we reached the posterior descemet duas layer, we can continue a little bit slower with the dissection. In 70% of the cases using this technique, the bubble, either large or small, is obtained. So in 70% of the cases, we reach this decimet level. As you can see in these videos, to reach these levels of is, I will put all them at the same time in order to save time. But basically the technique, independently of the problem of the case, is to remove these 2/3, these two anterior thirds of the cornea, which obviously are different if you're dealing with a keratoconus, or you're dealing with a corneal scar, or you're dealing with a dystrophy. So you should measure this preoperatively with your OCT, and then you will calculate how much are these 2/3. But as I mentioned, in 70% of the cases, as you have seen in the upper right video now, and you will see in the lower, and you will see in this other video, as I tried to mention in this slide, to reach the bubble is not always at the first attempt. So look at this, I have obtained the bubble in my third injection. But as I mentioned, you can have this large, big bubble dissection in 70% of the cases. And again, I repeat, constantly leaving the eye with low pressure, so decompressing through your paracentesis. You should continue with these dissecting maneuvers, and you will have a very nice posterior layer. And then from the donor, you will remove the endothelium and will continue with the surgery. sometimes when you move from a small to a large bubble, you might have, and that means that when you have a let's say local dissection on the pre-decimate layer, what is called the duas layer, and also a focal dissection at decimate level, then you have two bubbles. This is type 1 and type 2 bubble. And sometimes in the with the movement, as you will see here, that you are injecting viscoelastic, these two bubbles will interconnect. And it might look like a rupture, but this is not a rupture of the posterior layer, but a rupture now, boom. This boom that you have observed is because the initial dissection was above duas layer, and the secondary dissection was a decimate layer. You can see that the dissection is in the center, so you can continue with your dissection without any fear, because there has been no posterior rupture, but just a rupture between the two bubbles. This is quite infrequent using viscoelastic, but this is relatively frequent using air. But as I mentioned, I think that there are many advantages using visco in front of air. In 25% of the cases, we don't get the bubble, and then we will need to continue with layer by layer dissection, as you will see in these videos. I leave to running all of them, but basically what you will see, these are again different cases. There are the keratoconus on the upper right is a secondary scar following infectious keratitis. The lower left video is a stromal dystrophy, and as well as it is another stromal dystrophy, the lower right video. So the technique, as I mentioned, is always the same. Calculate 2/3 of the stroma, which we removed with our lamellar knife, and then we try to reach the bubble. But in 1/4 of the cases, despite of consecutive injections, this bubble does not appear. And then in those cases, so we will inject, as you will see here, we will repeat the injection, and we will repeat the injection, and we will repeat the injection. But finally, we have not reached, we have the stroma, plenty of viscoelastic, but no bubble. So the viscoelastic, as it also happens sometimes with the air, has not reached the posterior layers. In those cases, then you should continue the lamellar dissection plane by plane, but using a manual dissection. And with this, again, the advantages of having the stroma plenty of viscoelastic is that your visualization is quite better than if you have multiple micro bubbles of air. Visualization is better. You have increased corneal thickness, and you have softened the stroma. So this manual dissection is obviously longer, but is quite easy. You need, as I mentioned in the beginning, to continue with this manual layer by layer dissection, always keeping the eye soft, because this dissection maneuvers with the eye soft does not put in tension the posterior layer of the cornea. Of course, if you have in your microscope an OCT, this has a couple of advantages. It's not mandatory to have it, but if you have it, it is easier to find the correct plane for the visco injection, and also is much easier to control during the dissection the remaining thickness of the posterior layers. So it is not a need, but is quite useful to have it in your operating room. Today, for an experienced corneal surgeon, I'd say usually working with DALC, micro or macro perforations do not mean at all that you need to transform from DALC to full thickness. So there are almost any kind of perforation that oblige you to move towards a full thickness. It will obviously make your case again a little bit longer, but you will see, for example, in this left side case, I will run it quicker. This is a keratoconus case. You will see that now, when we have our visco dissection, because this area is very thin, you will see that, boom, you can see that we have an anterior perforation, but then we start from this anterior perforation, the lamellar dissection, but with these maneuvers, now in the dissection, you will observe a rupture, boom, in fact, a explosion. Okay, that does not mean that you need to move to full thickness. You should continue slowly and obviously carefully with the eyes soft, as I mentioned, with your dissection. Continue your dissection, forgetting the area of the perforation, but leaving the remaining decimet in place. And at the end of the procedure, once you have sutured your lenticle, what you should do is do a inferior peripheral iridectomy and leave air or SF6 20% as you do in your DEMEC or your DESIAC cases in order to have it attached. And the same for a large perforation. You will see here, this was a small, the left side one. But look at this, and let's go quickly. And you will see that here, in this manual dissection, at the end, now, we will have an explosion. You will see the explosion. Now, boom. And now, the cut is going from here to here. It's not a small hole. It's an absolute section of decimet. But anyway, you can still finish your dissection, position both flaps of decimet, and suture your lenticle, and again, leaving air after performing an inferior iridectomy. And it will take longer. Sometimes, as in this case, you will need a couple of SF6 reinjection in the following weeks after the surgery. But at the end, as you can see here, you will have a very nice, clear cornea. Obviously, you will always see this line where decimet was broken. So, I'm sorry. This is not moving. Now, this is exactly, this is what I mentioned. Well, obviously, the end result after 6 months, it is independent. If you have had a decimet dissection, like in this case, or you have a predecimetic dissection with some remaining stroma, look at 6 months. In fact, this is at 3 months, the appearance both at the slit lamp and an OCT, or if you have a predecimetic dissection with some posterior stroma remaining at 3-4 months on the OCT, you will see a very nice and homogeneous posterior layer. So as I mentioned, re-DALC is a relatively easy procedure. One of the advantages of DALC in front of this is a recurrent corneal dystrophy. So we remove the previous lenticle where the dystrophy has recurred, and we proceed with another transplantation. and this is a similar case where we have some remaining too much posterior stroma. We elevate this lenticle, we inject air, and we will remove this excess of posterior stroma that we have observed the day after the surgery, and we will put the same lenticle as we did in the original one. So re-operations are much simpler than after well, I'm sorry. So I have 5 minutes to go, or 10 minutes to go. So in those cases where you need to combine corneal surgery, doesn't matter if you're going to use DALC or full thickness, and you're going to do cataract surgery, there are different strategies with the goal of improving the refractive result. Obviously, if you do at the same time the corneal surgery, either full thickness or DALC, and cataract and IOL implantation, you should invent the theoretical postoperative case at the time of calculating the IOL. So that means a risk of significant ametropia postoperatively. So one of the strategies that I have been working with for many years in both full thickness and DALC is to, in the case that I need to do the surgery, so I need to do cataract surgery and deep anterior lamellar, is to do both things, but implant the lens in a secondary procedure. Because if not, the risk is the one that you can see in this surgery. So this is a case of an old lady with a woman of 73 years old. Well, as I am close to this age, I don't think that 73 is too old anyway, but we usually consider 73 as an old individual. So she has as you can see, a significant terrienne and a cataract. So we planned, because she is from Portugal, in order to avoid a secondary surgery. In this particular case, we decided to do both things at the same time. So we have removed these 2/3 of the anterior cornea in order to have a good visualization to proceed with the cataract surgery. We are going to do the cataract procedure. And in order, as I mentioned, to avoid too much flights from Portugal, we implant, in this case, so we proceed with the surgery, with the cataract surgery, and we implant an IOL, trying to assume that post-op case we're going to be our mean post-op case, and we then at the end finish our lamellar dissection once the lens is in place, and we proceed with the suturing the anterior lamellae. And the surgery, as you can see on the right top, was very nice. Everything was fine, but the ametropia was +18. And this is one example just to show you that these pre-op calculations may fail. So what we needed to do in this case is at the end asking this patient to come back, and we proceed with an IOL exchange. So in order to avoid this possible complication, as I mentioned, my standard strategy is proceed, as you can see with this video, we proceed with the surgery and 3 with the cataract. So we have 2 strategies: to do the lamellar surgery first, and then some months later, with the actual case, do a complete cataract procedure. Or we can also do what, as I mentioned, I have been doing also in full thickness, not only as here in deep anterior lamellar, is to do at the time of the DALC to do the DALC and the cataract surgery, and then 3 months later, come back and with viscoelastic dissect the back and implant the IOL. This is especially useful in full thickness because the viscodissection and the implantation of the IOL as a single procedure has a much lower trauma component than a complete cataract surgery. So in those cases where you have done a full thickness transplantation, this strategy of implanting the IOL as a solo procedure months later is a much logical approach. And the probability of significant ametropia is much lower than when we do a triple procedure. Of course, you can combine DALC with SLED, as you can see in this patient with unilateral limbal deficiency. We are taking a small biopsy of the healthy eye, and we will put this biopsy in the other eye, and also we will do a deep anterior lamellar. So deep anterior lamellar obviously can be combined with any other procedure, as also here, in order to correct the residual significant ametropia in a young patient after DALC, we can use, and this is my favorite phakic lens, a artiflex, in this case, a toric artiflex, to correct the residual ametropia after DALC. So, in summary, descemetic or pre-descemetic DALC is our preferred technique when keratoplasty is indicated and the endothelium is healthy. Best corrected visual acuity and quality are similar than after full thickness, but obviously graft survival is much longer. There are rare limitations. Obviously, there are some situations, for example, in some herpetic cases, where we are unsecure of how good is the endothelial health, or in those cases where we have had a previously perforated cornea. This might have some limitations for DALC. And as I mentioned, I think that viscobubble dissection, this technique, is less aggressive. We have a slower and more controlled dissection, and the steps, the surgical steps, are safer with a much better visualization than using air. And just obviously, the use of an intraoperative OCT is useful as long as you can have. So thanks very much for your kind attention, and I am obviously open if there are any questions, if there is time for that.
Якщо є запитання, то запитуйте. Чи є запитання? Є. Будь ласка.
Are there any questions? Yes, there is some question. Please, Nadia Fedorivna.
Thank you very much for so nice and interesting presentation. And some questions. Do you remove the remnants of viscoelastic from the surface of the cement membrane when you put the lamellar graft?
Well, not remember because I have not probably mentioned it, but you need to use if is a cohesive standard density viscoelastic, and so with flushing water over the ocular surface is quite easy to be removed. I do not recommend at all to use dispersive viscoelastic because dispersive, first of all, has not the same capacity for dissection, and secondly, it is much more difficult to be removed, as you know, in intraocular surgery. So the answer is yes, you should take some minutes flushing water to remove any remaining viscoelastic from the surface.
Thank you, understandable. And what is the risk to perforate the cement membrane using your technique with whisker or air bubble?
I'd say that the risk of perforation is exactly the same. So I don't think, I mean, during the
Would you like to ask?
Як то кажуть, in advance.
So,
Combination of keratoplasty and cataract. Перепрошую? Ну ось, кажуть, що він вже з'являється.
I can hear you. I can hear you perfectly well.
Okay. Thank you first of all, thank you very much for great lecture. I have two questions regarding the combination of cataract surgery and keratoplasty. First, you advised to remove cataract and leave a phakic eye and then to visca dissect capsule. What's your opinion? Is it beneficial to use CTR, capsular tension ring, to implant in the capsule, and then it may facilitate us visca dissection? And the second question is, have you ever tried to combine cataract, keratoplasty, and aura? To do keratoplastic, then to do online refraction, and after on the transplanted corner, and then to calculate and to implant the lens. Thank you.
These are very, very good questions, in fact. And thanks very much for your comments. Well, the first one, yes, in fact, when 25 years ago, I started combining cataract surgery and full thickness keratoplasty and not implanting the IOL, what I was doing originally is implanting a zero-powered IOL at the time of the combined surgery in order to do not have any scar or any, let's say, connection between the anterior and the posterior capsule. And so when I implanted 3-4 months later the final IOL, the proper one with good case calculation. So what I did is let's say, an IOL exchange. I removed the zero powered and I inject the other one. This is what I did. So the idea of using a intrasaccular ring may have a relevance, but with the ring, what you will not be able to avoid is let's say, the connection between the rhexis and the posterior capsule. So you still will need to dissect this area. But anyway, it's a good idea. So yes, I think that this might be an option. And your secondary question, of course, that this should be the way to go. I have not tested this option to use the aura, so to use any, because there are new instruments to do that, not only the aura. So to use ray tracing to calculate, once you have left the eye aphakic, to calculate the proper power of the implant. But that's what we will do in the next few years, presumably in all cases. So I think that what you are just mentioning is what will happen in these cases that we have been talking about, of course, because these are the more risky cases. But I think that we will use this technology in every case. And because, as you know, ophthalmic surgery is rapidly changing, and we will probably not need it anymore in the near future, because machines will do our work. But in the transition period, machines will give us the opportunity to be safer and to be more precise. And I definitely think that any calculation during the surgery to properly align the lens and select the power will be in the near future the way to go.
Yeah. Thank you very much for great answers. And the only small comment, I hope that a machine will not substitute neither us nor our kids. Maybe our grandkids could be substituted by machines, and not fully. Thank you very much.
Okay. Well, I think that you should tell her. I think that doctors will be there, but I thought that it was going to be for a problem for our grandkids, but I think it will be a problem for our kids. Anyway, let's see.
Шановний доктор Гуель,
Dear Dr. Guel, as to our tradition, every year scientists of our institution award honored doctor ophthalmologists that have significant researches and advantages in keratoplasty. So, for your research in keratoplasty and corneal grafting, we want to award you this year. We are very honored to present you this medal on behalf of Vladimir Filatov for your significant research in ophthalmology in the field of cornea transplantation and for your fruitful and informative lecture. Thank you very much.
цю нагороду ми зможемо
This award we will pass you on Eurocornea in Prague that will take place in Czech Republic in Prague.
you.
It has been an honor, and it will be an honor to receive it in Prague. Thanks very much.
Ну, дякую, Галина Іванівна.
Thank you very much, Halina Ivanivna, very well. So let's move on. Keratoplasty cornea pathologies of the surface. So please, our first report. Halina Ivanivna. Workshop. So we are here. We are waiting for you. I didn't see. Sorry, some technical issues. Some technical issues, and hope we provide in next lectures. So the first report, Halina Ivanivna Droshina. First report is dedicated Filatov Keratoplasty School. Yesterday, today, tomorrow. Reporter, head of the Department of Cornea Pathology, Professor Halina Ivanivna Droshina. Dear colleagues, for many years I have told you for the opportunity to substitute opaque cornea with a transparent one. This event was 130 years ago. Due to the impact of honorable ophthalmologists, but the main successes are of Vladimir Filatov. He was a student of a Moscow university when he began to study this question, and when he was asked in what field he wanted to be successful, his answer was transplantation of cornea, and when he managed the department of cornea, it was his field of operation. His first total transplantation was presented in 1923, and the results were presented during the meeting of association. And in 1928 was the first penetrating transplantation of cornea. And then 5 patients with a successful transplantation were presented in the institution of capital, and they wanted to see the results because it was the first unprecedented case of such a surgery, and it was the first successful result as far as I mentioned. It is necessary to mention that at that time the technique was performed by Tripel, and it was very complicated with a lot of complications. One of them is the trauma of lens and trauma of sclera, and then they launch FM3, FM4 in order to secure this surgery. He performed in detail the stages of these operators and make better the technique. Then he expand manifestations and recommendations to do this surgery. His technique was used for many years. The main obstacle to use this surgery was the absence of eyes with transparent cornea that were the donors. Due to the reason not connected to the impairment of cornea, and as a specialist, he decided that there is no doubt eyes of people who died from another diseases don't differ from eyes of healthy people, eyes of healthy and alive donors. So that problem of searching and preserving of dead material for keratoplasty was the problem and issue how to preserve those eyes. And in 1934 he published his notices on transplantation of cornea from dead eyes. The conditions of preservation were +2, +4, and the results was that that material was not worse than material from alive donors. In such a way, this issue was resolved, issue of donor cornea, and also manifestation, indications and counter-indications for excluding dead eyes for transplantation of cornea. He proved that dead eyes may be used for transplantation. It was his opening. And cornea was the first tissue where there was possibility to attach it and to transfer from one body part to another body part. So it was a really significant event. In 1936, by the decree of popular commissars, there was an institution of experimental ophthalmology launched, and Filatov was the director of it. And the laboratory on conservation of tissues was open. And up to the 1934, they performed 538 surgeries on cornea transplantation. And 336 of them were from dead eyes donors. Small number of people paid attention now that his contribution to the development of keratoplasty was not only his achievement, but to the transplantation in general, because the law on transplantation was adopted due to his help and assistance. Because it was a decree that the dead bodies are the ownership of state, and they can use them. It was the first law that allowed it to use dead body for medicine. In such a way, grafting was transferred from experimental method to the all-included and widely used method. Under his management, a lot of researches were made under his management. Post-operative period was described in details. That fistulas may have not only treatment but preventional effect. Then classifications of cataract and the prognosis in every other issue. The results were unified by partial and penetrating keratoplasty. Drying of cornea didn't affect on its life term, and we have to moist it in order to continue its term. So all these methods, how to preserve tissues, what morphological changes took place, all these things were opened and approved by Vladimir Filatov. Further research showed us that conservation helped to preserve this transplantation tissue. Vladimir Filatov made a conclusion that conservation in low temperatures allows to increase regenerative processes in graft and cataract of the host. Vladimir Petrovich tried to incise the upper layers of cataract and to make a partial transplantation. It was a great method and it had its positive impact. It was published in 1923. Government assessed his researches studies, and in March 1941 he was awarded with the Stalin Premium, Stalin Award of the first stage. His colleagues, bright students and followers, such as Nadia Alexandrovna Puchkovska, made a great contribution to the further development of keratoplasty. Due to her works, our domestic school opened a subtotal keratoplasty together with ectotic cataracts, and Nadia Alexandrovna provided optical lamellar keratoplasty. He provided anterior lamellar keratoplasty when we tried to treat severe cases of cornea. And you know that all these scientists that are listed by me took part in the further researches. There was an immune response of reactiveness and response of our body for graft survival, and they also research different techniques of transplantation and then secondary glaucoma with a cataract, and the results of the penetrating keratoplasty with a donor cornea. A lot of these reports had a significant meaning, and for now we used this data in our everyday practice. On this slide you can see familiar faces. These are lounges of our domestic school of keratoplasty and their followers, Susanna Alexandrovna Barhash, and all familiar faces, Tavrat Hargeladze, Ivan Halhai, and a lot of another people whose contribution was really significant to the transplantation of cornea in our institution. The name of Filatov is enlisted with the golden letters in the world history of transplantation because his achievement and opening was that we can use dead people for transplantation, and for now cornea of dead people is the best material for transplantation. His cold conservation was really significant in the history of ophthalmology. Cold conservation is being used even now in tissue banks of Europe. In 2014, American Association of Cataract and Refraction Surgeries enlisted his name to the members of Glory Hall for his contribution to the development of world ophthalmology.
Є пріоритет.
For today, transplantation of cornea is a priority direction of our work. We have up to date already performed 2,000 keratoplastics, 42 of them with use of keratoxena implantations. At present, I can say that we are having really complicated eyes for keratoplasty. That's why the percentage of layer by layer keratoplasty has lowered, because the complications with which the patients come to us do not allow for layer by layer keratoplasty, but require simultaneous surgeries, penetrative ones. So this is the dynamics of lesion processes, necrotic processes. Since 2019, this percentage has been growing constantly and reached 84% in 2024. Here are some patients' cases for which penetrative keratoplasty is the only opportunity to restore vision and to avoid inflammations, to remove inflammations from the eyes. For today, we are performing different types of both layer by layer and penetrative keratoplasty. We perform combined keratoplasty with blepharoplasty, with a vitrectomy, and for today, our patients, many of our patients have terrible results of mind blast traumas, patients with opaque cornea which require simultaneous surgeries in the posterior chamber of the eyes. So different departments of our institutions are cooperating in the operation theater. So these combined surgeries with use of keratoplasty allow to save visual functions. In a number of cases, we also are able to restore vision. The Institute uses modern methods of diagnostics of corneal diseases, having modern equipment, keratotopography, OCT, and a lot of others, which allow us to obtain additional data required to prognose the prospect of the surgery. Our scientific explorations we perform cooperated with different other institutions, Institution of Cell Therapy in Kiev City, Institute of Eye Clinics in Köln, Germany, university clinics in Münster, as well as in university clinics of other cities. Thanks to this cooperative research, we were first in Ukraine in 2001 to implement genetic research in Ukraine. We researched hereditary dystrophies of cornea. We researched mutations with certain types of dystrophies. We were the first to describe clinical form of deep dystrophy of cornea. We identified a new type of mutation associated with that dystrophy. A great number of research was held studying layer by layer and penetrative keratoplasty, and we found that layer by layer one was more sparing in both postoperative and still period. We were the first to study acute keratoconus and develop the methods of its treatment. Since 2016, we have implemented a modern method of treatment of primary stages of progressing keratoconus, which is cross-linking of collagen of cornea, performed on equipment UVX 2000, and we reach the maximal effect, decreasing the time of the surgery and effectiveness of which is high enough. We conducted a large number of research of auto serum of blood in treatment of neurotrophic keratopathy, of post-infective etiology. We identified some criteria of corneal regeneration which influence the prognosis, and we are studying how to prognose the reaction, the response of the immune system. For many years, we have been paying large attention to donor cornea, and in 2016 we elaborated a method allowing to transplant grafts of medium size and other types of grafts with different diameter of donor cornea. And we have almost constantly been using these methods and these types of grafts. Also, we have a department of experimental clinical research where we work with new methods of research of cryoconserved amniotic membrane. We have obtained the permit to use it in our clinics, and other ophthalmologists of Ukraine got high quality amniotic membrane for surgery of neurotrophic, post-infectious and other surgical procedures where it was required. We have improved the technique of transplantation of amniotic membrane, correcting the defect of stroma, lowering the number of sutures, lowering the risk of inflammatory reaction, and speeding up the epithelialization of the surface of the eye. In 2024, we were the first in Ukraine to transplant Boston keratoprosthetics of first type after severe mind blast trauma. You see the examples of this case in the pictures. His visual acuity was 0.1, and the patient is so happy, as well as we are. Speaking about the future, we have purchased laser system, modern laser system, Elkan Wave Life laser FS200, which allows us to dissect in the shape of mushroom or cylinder or other shapes, which is practically impossible to do manually. And this provides for better healing of wounds, less loss of endothelial cells, allows earlier terms for removal of sutures, and we hope that by the end of the year we will be able to operate with it. Concluding, I would like to say the quotation by academician Filatov. The surgery of cornea does not get older, and among the transplantators there arise more and more techniques, methods, and more ophthalmologists work on this problem. Thank you very much for your attention. Are there any questions or wishes for such report? Then let's switch to the next one. The name of this next report is Pediatric Keratoplastic of the Filatov School from Past to Present. So Bobrova, Professor Bobrova is going to give this presentation.
Dear colleagues, let me present you pediatric keratoplasty of Filatov School from our present time. I have no financial interest. I won't mention all the problems of keratoplasty because they were highlighted. I want to tell you that he is an author of non-specific tissue therapy, of round stem, and another innovations. He also was interested in pediatric blindness. In 1946, when he was an experienced ophthalmologist, he was 76. He opened pediatric ophthalmology department in order to prove that penetrating keratoplasty is possible in pediatric age as well, because this complicated surgery was forbidden by all ophthalmologists. And Filatov, Professor and Barhaj, first managers of our department, they ruin this. They ruin this thought, and they made their first surgery. And our professor Susanna Alexandrovna was the leader in performing of penetrating keratoplasty in children. On this photo, it's very rare photo. You can see the anniversary of Volodymyr Filatov. He was 80 years ago with the oldest and the youngest his patients. But of course, time changes and we have new challenges during our modern life. And now we have scarring central cataract, and they go together with different impairments of cornea, and we have to make a transplantation and reconstruction both of cornea and iris. You can see such a scar on this slide, and you can see the zone of transparent cornea if we would use the classical methodology provided by Filatov. So that's why we provided our new penetrating keratoplasty, and you can see now the pathway of our surgery. We made a big trepanation of cornea and transmit substitute opaque center with a transparent one, and to restore the peripheral zone of cornea. On the central slide you can see big scars, but we are able to incise them and to transmit, to substitute the tissue. In order to perform this surgery, we make really a lot of surgeries and researches in order to understand how to do it and where is the most transparent part of cornea. Now I want to show you a small video of the process of this transplantation. Here you can see rough scar after the trepanation, and you can see here that the iris is really very thin, and we try to incise it and to separate very accurately. Then we put away cornea, extract the cataract, and implant the flexible lens in this capsular bag. Then we have no obstacles for performing iridoplastics to restore our pupil. And you can see the same procedure but with a small turn, and the central scar removed to the periphery. It became lateral. Here you can see this girl, she is 5 years old. We can see both medical and cosmetical effects. Of course, it was our achievement, and it helps us to prevent scarring in future, because there is no contact of injured cornea with iris, and it helps us to make it survival and to leave it transparent. And then we will tell you about closing of fistula of cornea. You can see that iris wants to close this hole in cornea. We graft implant, it helps us to close this fistula and to substitute all the layers of cornea together with membrane, and we preserve the transparent part of cornea, and visual acuity was really high. And there are also different anomalies that children have when they were born. Here you can see the connected tissue at the corner of cornea. You can see also the restoration of sight and the transparent cornea. We performed iridoplastics as well. Then substitutional layer keratoplastics. I want to show you also a small video. You see that these children have this cataract big demoids of the third stage. You can see it on our video. You can see the process of removal, and there is a small additional demoid lateral. We remove this lipodemoid tissue. It is bleeding because it consists of a lot of vessels. We remove it from the surface of cornea and sclera, and then remove all the opaque layers of cornea. And after the grafting of scleral flat, on the right slide, I want to show you the rare case. A 9-month-old girl with demoid of cornea, and after the removal of this demoid and performing keratoplasty, the full restoration of vision. Also, I want to tell you about oncology. We have a lot of cases now in children. We use barrier keratosclera plastics. You see the neoplasms of sclera of cornea. It's a really very rare tumor, and after the removal of this tumor and restoration of cornea layers, we don't cover all the cornea with graft. We make a barrier in order for conjunctiva not to penetrate into cornea, and to restore the construction of eye. And then you can see the process of restoration, and scleral part is on its place. And unfortunately, we have malignant tumors. You can see malignant neos. It's malignant formation neoplasm of cornea. 11 years old child. We also made this barrier in order to prevent the conjunctive process of cornea. And you can see as well this part disappears and scleral part is on its place. We also have to take into consideration pathogenesis, and there are of course some complications with vitreal bodies, and then no dilation of iris, and all these diseases should be fixed with the sutures, and of course we don't know the behavior of children after the operation, because it is very difficult to be in touch with the children and to conduct their behavior. Of course, we have to take into consideration peculiarities of their body and of their health. They have increased reactivity, functional immaturity of all organs, then functional immaturity of all systems, weakening of their bodies due to their previously contagious infections. What are our conclusions? Different ophthalmological pathologies of pediatric age provoke and allows ophthalmologists to improve and to provide different practices in order to resolve all these issues, in order for all children to see sun, as Volodymyr Filatov said to us. Thank you very much for your attention. Nadia Fedorivna, thank you very much for such a very fruitful report, and it is wonderful that you have such an opportunity and you propose us to use the pediatric cornea to restore this flap and to substitute a lateral part with a central part. But I have such a question. Will it increase the level of astigmatism? Yes, it's a good question. Yes, of course, because we have irregular astigmatism before surgery, and of course after the surgery we have an astigmatism in children. And there is another one peculiarity. And there are different thickness of cornea in the center and on lateral sides. So there may be a small barrier during performing this surgery, but pediatric eyes are very plastic. And so all these problems will be resolved by their own body in future. And we have our own graft, of course, and we can use contact lens additionally if we have such a necessity. And another one question, not about your report, but this topic is highly discussed. What is your opinion about keratoconus in pediatric age? And what is your methodology, cross-linking or early transplantation? As to the words of Professor Serduk, I have no answer to this question because keratoconus is searched in teenage age in the department of cornea transplantation, so it's the question to Halina Ivanivna. Our approach is conservative and we use modern methods and they are effective, you know them. I want to add, what about keratoconus? If in early age we see keratoconus, we don't wait for it to progress. We have to perform cross-linking at once because early keratoconus progresses very quickly, and we have to prevent keratoplasty because keratoplasty is exclusive, unique case when we have keratoconus in early age. We also have cases of acute keratoconus in pediatric age, and we also don't perform keratoplasty. We make a surgery to prevent glaucoma in order to decrease the pressure and to treat this child.
Наступна доп.
So the first report is going to be by Sereda Katerina Vitalyevna, treatment tactics for fungal keratitis, the role of penetrating keratoplasty, the Department of Cornea Pathology of our institute. Good day, dear colleagues. Let me present my report on treatment tactics for fungal keratitis. Fungal keratitis is an urgent, dangerous infection of the eye, mostly widespread in tropic and countries, developing countries, and it makes up 67% of all cases of infectious keratitis. Fungal keratitis is mostly suffered by men who work in open air, and it was first described in Germany by Leber in a 54-year-old farmer. This infection has to be considered as an urgent need that requires increased familiarization of an ophthalmologist for correct clinical diagnosis and urgent treatment, because really often, even after early diagnostics, loss of vision is inevitable. Besides, antifungal treatment are of high toxicity and low effectiveness somehow. The morphology and classification of fungi is different, but the most widespread type of fungi are unicellular yeast. Filamenous fungi are spread into several sections, several types. There are also yeast fungi, which form cream-like colonia on the surface of cultures or environments. There are also dimorphic fungi, which have the properties of yeast. Risk factors of fungal keratitis from the eye are wearing contact lenses, chronic diseases of the surface of the eye, immune suppression, too much use of anesthetics, previous operations of cornea, cornea trauma by ground or organics. There are also systemic factors which contribute into the risk. Speaking about epidemiology, we have to say that Aspergillus is the most spread organism in the whole world. Its morbidity is varying geographically. In the north of the USA, there's Candida and Aspergillus. In the south, there's Fusariosis. The pathogenesis is the defect of epithelium of cornea. It causes inflammation and necrosis of stroma, and then penetration takes place through undamaged descimate membrane into the anterior chamber. Clinical manifestations of fungal keratitis are feeling of foreign body, increasing pain, decrease of vision. There might be specific and non-specific symptoms like feathered mushrooms, raised edges, epithelium defect, fixed hypopion, yellow demarcation line, immune ring of Wesley formation. Keratitis fusarium has severe course of fusariosis. There might occur perforation within 2 or 3 weeks. Other clinical peculiarities are white, yellow or gray lesion, raised edges, satellite lesions. Among laboratory studies, we can perform scraping of cornea. We can also turn to laboratory diagnostics, direct microscopy or confocal microscopy, PCR. Treatment of fungal keratitis is generally problematic. There are no commonly accepted recommendations for this. Usually one or several antifungal preparations locally are combined with intravenous administration or per os. Mostly amphotericin or natamycin are prescribed. The most spread polyyns are amphotericin B and natamycin. The first one does not penetrate into the intact epithelium, has low or moderate activity against Fusarium and Aspergillus. Natamycin is highly active against the majority of Fusariosis and Aspergillus. It can be intravenously or intracamerally administered. It cannot be intravenously or intracamerally administered. The most spread solutions are voriconazole 1%, fluconazole 0.2%, which provides for good penetration into the eyes. You may see the solutions percentage in this slide. Intraconazole, for example, is often used for long-term and support treatment of chronic fungal keratitis. There is also povidone iodine and the latest generation of preparations, allylamines, echinocandins, are also used these days. Indications to systemic antifungal treatment are large ulcers of cornea, scleritis, endophthalmitis. Per os, ketoconazole is mostly used, dosage 600 milligrams per day. Each 2 weeks, liver tests has to be done, and systemic therapy should last from 6 to 8 weeks. The algorithm of therapeutic treatment has to include testing, diagnostics, and then choice of different types of treatment depending on the response from the organism. If the therapy provides for nice effect, then it lasts from 6 to 12 months. If the response is bad, then we are speaking about systemic treatment, intrastromal, intracameral administration of preparations. Surgical treatment of fungal keratitis includes transplantation of amniotic membrane, which decreases pain, inflammation, and neovascularization, stimulates epithelialization, decreases scarring. Also, we use conjunctival flap, thinning of cornea with threat of perforation ulcer resistant to treatment. Intrastromal injections are also possible in 4 or 5 zones around the abscess, or infiltration, intracameral injection when preparation is administered with help of needle to facilitate intrusion of exudates or hypopyon. Cross-linking is also possible. It destroys the DNA and RNA of the minor microorganisms, but for now, its effectiveness is questionable. The key moments for therapeutic treatment keratoplastics are trepanations for 1.5 millimeters from the damaged area, from the damaged area. We always use sutures. We interrupted sutures. We irrigate the anterior chamber with antifungal preparations. We remove the damaged intraocular structures. We recommend systemic antifungal treatment. We use steroids in such patients, but this is questionable. Let me also show you a couple of clinical cases. We had a patient, 53 years old, wearing contact lenses 2 weeks ago. She noticed redness in the eye and some discomfort. So her questionable diagnosis was herpetic keratitis, and she was treated with antibacterial and anti-inflammatory preparations. She had almost penetrating infiltration of the stroma to almost up to the limbus. She had hypopyon. We performed confocal microscopy, which showed numerous foci of fungi. So her treatment included chlorhexidine, fluconazole, voriconazole. She had intravenous infections of some preparations. Because of the abscess and different risks, we performed penetrative tectonic keratoplasty with basal iridectomy. We found fungi resistant to all the spectrum of the preparations available in the laboratory. The patient continued getting fluconazole. On the 7th day, post-operatively, we found formation of infiltrative screen behind the transplant. So after 2 weeks after keratoplasty, we performed another surgery. On the first day, the infiltration was absent and the patient was discharged after 12 days. She was followed up. The surface of the graft was stably epithelialized, and in a month, in the follow-up, the condition of the graft was stable, so there was no recurrence. Our second clinical case is a patient of 70 years old who was traumatized by a plant during working in the field. She was treated by steroids. We found deep infiltration, we found stroma in biomicroscopy. We also performed confocal microscopy and found fungal etiology of abscess, and diagnosed her with this abscess of cornea of fungal etiology. We treated her with chlorhexidine, fluconazole. We performed combined treatment and decided to wash the anterior chamber to take biopsy, which showed us Aspergillus flavus resistant to many types of treatments. In connection with the prognosis of thinning of cornea, we performed penetrative treatment tectonic keratoplasty. On the 14th day after the surgery, the patient was discharged with stable condition. No recurrence was found. The graft was transparent and her visual acuity was 0.02. After a month, post-operatively, she was stable as well. No recurrence was found. Our third clinical case was a patient of 48 years who was traumatized during working in his garden. Again, he was treated by antibiotics locally and systemically. Then he was referred to inpatient treatment. Hypopion was found. His visual acuity decreased very much. There was the infiltration of stroma. We performed confocal microscopy, and our diagnosis was post-traumatic ulcer of cornea of fungal etiology. We used fluconazole, chlorhexidine, and other preparations combined with intravenous injections and per-os. We performed washing of the anterior chamber with sampling for microbiological research, which showed also Aspergillus flavus, sensitive to voriconazole. Because the patient's prognosis was for thinning of epithelium, we performed penetrative keratoplasty. Unfortunately, on the 9th day post-operatively, he had recurrent infiltration. So first of all, another washing of the anterior chamber was performed, and after a day, when hypopion was absent, we performed transplantation. The patient was discharged after 14 days after the secondary operation with visual acuity 0.05. 2 months post-operatively, the condition was stable. There was no opaqueness in the graft. So to conclude, we have to say that keratitis caused by filamentous fungi such as Aspergillus, in absence of proper and timely treatment, can gradually become endophthalmitis and threat the eye. Samples of cornea remain the golden standard of etiological diagnostics. Confocal microscopy helps to diagnose fungal keratitis at early stage, but in hard cases, in severe cases, there has to be penetrative therapeutic keratoplastics performed. Thank you for your attention. Thank you, Katerina Vitalyevna. Does anyone have questions? Good day, everyone. Thank you for your wonderful report. Please tell me, do you use povidone iodine? I haven't heard it in your report. No, we don't use it, but we use 1% voriconazole and fluconazole. Yes, these are antifungal preparations, but how about antiseptics like povidone iodine? No, we don't use it, but we use chlorhexidine in combination with voriconazole. Thank you. And the second question is, I often see combination of fungal infection in hepatic eyes, in hepatic ulcers. What do you do in these cases? These patients are treated with valacyclovir. And which preparations are used locally against the fungal infection? Yes, the same. Fluconazole, voriconazole, because based on our experience, these are the most effective preparations. Some of preparations are just inaccessible these days, but if there is stromal process, for example, some preparations are inaccessible. Can I ask a question too? Thank you for your wonderful report. Please tell me, in your practice, have you ever compared different antiseptics like miramestin, olcomestin, povidone iodine, or chlorhexidine? Have you ever compared them? Statistical studies were not performed by us, but speaking about clinical effectiveness, which we see in infectious keratitis, chlorhexidine is more effective than miramestin. Thank you very much for your answer. I also have a question. How is it critical to determine the type of fungi? Does it change the tactics of treatment? And how can you perform your research, because the data is really limited? So the data from our presentation are coming from the world experience. So Candida fungi has clinically specific properties, and we can sometimes suspect it. Also, Candida has more specific amphotericin. Other fungi are more sensitive to fluconazole, but when we suspect fungi keratitis, the first choice preparations are the ones that I mentioned from what is accessible by us. What happens if there is a combined flora? Which flora do you see in combination with fungal one? We see Streptococcus. Thank you. And I have a question. Yeah, I would like to add to Oksana Sergeyevna's question that, speaking about the clinics, fungal keratitis are factors which develop a little slower in Candida case than in mold case. Mold cases progress more severely and faster. So this factor also shows us indirectly what type of fungus we are dealing with. I have a question. When we diagnose fungi, we see it in confocal microscopy, but our patient has epithelialized surface of cornea. Do you recommend to perform scarification because if the zone is limited, or should we just treat the patients even in cases so when the treatment doesn't help for months? So if there is a focal effect, then we don't perform epithelialization at once. But if we see absence of effect of treatment, we take more serious measures. Is it scarification or is it intrastromal injection? First of all, it's scarification. Thank you very much. Speaking about povidone iodine, you mentioned it in your presentation. So the percentage which you specified, how can we get this percentage? How do you dissolve it? So this chlorhexidine from the pharmacy is dissolved in the natrium chlorine. We have pharmacological solutions already, so that's why they are widely used. Thank you very much, Katerina Vitalyevna. We are switching to the next report.
Because of course we are out of time, and we invite Saldan Yulia Yosipovna with a report papillomavirus from pilot to practice. Vinnytsia National Medical University, named after Pirogov. Good day, my colleagues. I want to thank for the beautiful, brilliant organization of this event. and to thank personally to the Department of Konya, because nevertheless all the specialists are sent, all the severe patients are sent to you, and you have the biggest experience. What about my today's report? I chose the topic papillomavirus, human papillomavirus in ophthalmological practice, because there are a lot of discussions about whether it is necessary to be vaccinated or no. So let's talk about it. I have no financial interest. So let's start. A virus of papilloma are caused by a specific virus, and the human being is a carrier, and it is a sexually transmitted virus. It can infect eye surface. So it is transmitted with the hands on conjunctiva and on cornea. It's a chain virus without and there are several stages for its development. It's epithelial-tropical virus, and in fact epithelial cells, basal membranes, and implement in the DNA of the host. It has also oncoproteins. It changes the development of normal epithelial cells. It's the suppression of host cells and inhibition of telomerase, and it decreases the cycle and chromosome instability. But during a long period of time, it wasn't typing, and it wasn't attacked by immune system of our body. And there are more than 100 types of these virus. 14 of them are highly oncogenic. Clinical signs of papilloma. It is developed during the first decade of life. It looks like nodules with vessels, so that's why they are pink. Children may be also infected and during the delivery. For these papillomas, spontaneous regressus is a very characteristic sign. Nuclear pyknosis and transparency of cytoplasma are the main signs. As to the character of growth, they can be exophytes. They are also divided for one with a leg and without leg. Clinical signs of papilloma presented on this slide are characterized by the widespread for conjunctiva, stems 6 and 11 that are non-malignant, and 11th and 18th that are malignant. As you can see, they are subdivided for ones with legs and without legs. Those with legs, they are non-malignant. Without leg, they are malignant. And non-malignant are usual for children and teenagers, and malignant are normal, widespread for adults. And here you can see for the derivation of eye impairment and division into malignant and non-malignant. And of course, there is the cases of recurrence. It's 5-11%. Here you can see different diseases, keratosis, cysts, malignant impairment of surface epithelium, different neoplasms of conjunctiva, and flat cell cancer, papilloma granuloma that is produced near the sutures and several types of hemangiomas, non-pigmented melanomas, and different secondary tumors. In any case, to establish diagnosis, you should perform a biopsy. Options for treatment: it's surgical removal, cryotherapy, and laser as well. Despite of the modern methods of treatment and surgical treatment, all papilloma can be recurrent. These recurrence cases can be in from 6 to 27% of cases. I want to show you first clinical case. Patient who addressed us. She is 52 years old. Her diagnosis is Hodgkin lymphoma, and this papilloma has two surfaces. It is very interesting fact. The surface was covered with the skin, inflamed skin, and opposite cover, it's the cover of papilloma. So it grows on margin edge, on affected edge. After the surgery, we investigated this neoplasm, and it was fibropapilloma. It developed very quickly, and usually we have such cases in immune-incompetent patients. The second clinical case, as far as I mentioned, during the long time, papilloma are unpainful, and it's only a cosmetic defect, but if we injure such neoplasms, we have an immune response. It's the second clinical case. Patient 62 years old. It's an urgent case. He was gardening, and there was a foreign body in his eyes. His eye was injured by a stick. There was an inflammation of eye, and we saw neoplasm on limb. There were also purulent discharges. We prescribe anti-purulent therapy and decided to perform a surgery. We investigated this neoplasm. We made a barrier on cornea, and during the investigation, we find out that it was papilloma with signs of frozen of covering. Of course, we have to perform a treatment against malignant tumors. For today, we have 3 types of vaccines to prevent papilloma virus. In Ukraine, this vaccination is not for free, but next year the first dose of any vaccine will be for free for girls beginning with a 9 year. Why we choose this age? Because it causes oncological changes of uterus. It's the first and main cause, and we should assess all the changes and the impact of this vaccine in conjunctive cavity. Also, we have to mention the signs of malignant tumors, because when we plan a surgery, we should understand the image. It's atypical cells, and these tumors are very big. There are metastases, ulcers, and these tumors influence the whole organism. Conclusions. The most effective way to prevent is vaccination. When you have neoplasm, it is necessary to take into consideration signs of manifestation, and then to perform cryocoagulation of healthy tissues. All tumors should be examined even if you are sure that this process is not malignant. Thank you very much for your attention. Thank you very much for very interesting report. Do you have questions? So please, Nadia Fedorovna. It's very relevant and a wonderful report, but now we are in such a period when this oncology has a lot of morphological changes, and you don't know when you have a surgery on removal of tumor, and you don't know whether it is malignant or non-malignant. Taking into consideration this practice, I don't perform biopsy. If there is a proper size, proper location, I try to remove the whole tumor, taking into consideration safe edges and all the necessary precautions, and then I am waiting for the results of examination. And how often do you use biopsy? And tell please about its relevance. Thank you very much for your question. Of course, we can see different morphological changes and signs in one removal fragments. It can be inflammation, papilloma, and signs of malignant process. We perform biopsy if we have a big formation, a big neoplasm, and we should plan, we should schedule our next steps, because we are not able all the time to remove a big tumor on our eyelids, for example. That's why it is relevant to make biopsy, and after biopsy we take a decision about further removal and to understand what we need, substitute tissues or some other measures. Very briefly, because we are out of time. The thing is that when you use cryodestruction, it doesn't kill virus. Only laser coagulation helps us to kill the viral DNA. How do you take decision what type of treatment you should use? There are a lot of publications on cryodestruction. I don't use it because for now we don't have it, and it's irrelevant method. So for us now it's only coagulation. Thank you very much, Julia Osipovna. The next report, complex treatment of neurotropic keratopathy.
Please, Людмила Федорівна.
Побічні прояви та особливості лікування реакції трансплантат проти хазяїна.
We have had the mistakes, and now we are going to have a different topic of lecture. Eye manifestations and peculiarities of treatment of transplant against recipient disease. I don't have any financial interest in the report. So autologic and allogenic transplantation of hematopoietic cells is an important variation of treatment of various malignant tumors, including leukemia and lymphoma. In the US, annually there are over 20,000 procedures. In Ukraine, the transplantation is taking place in 11 centers. Despite the fact that immunosuppressive therapy has been advanced and better typing of leukocytal antigen of human HLA, the disease transplant or graft against the recipient remains a widespread complication, which is seen in 30–70% patients. We observe acute or chronic reaction. So acute reaction includes the most crucial clinical consequences which associate with skin, liver, and eyes. Chronic manifestations, they include destruction of skin, fibrosis of derma, severe recurrent infections on the background of the basical lowering of organisms' immune system. Eye manifestations occur in 40–60% of patients, and they include dry keratoconjunctivitis, scarring conjunctivitis, dry eye disease, corneal ulcers, cataract, non-infectious uveitis, as well as central serous chorioretinitis. There are 4 stages in lesion of conjunctiva. 75% are at 3rd stage, and over 75% of the surface is considered to be the 4th stage. Sometimes it leads to fibrosis, sometimes it is inevitable to have the dry eye syndrome. The cornea has formation of upper limbus keratoconjunctivitis, neovascularization of cornea, ulcers, cataract formation. It's widespread in the cases of this disease, graft against recipient. The posterior chamber of the eye has to be diagnosed and researched. General examination of patients with manifestations of this disease include general ophthalmic examination. We look at the anamnesis, we photoregister the eye, we perform Schirmer's test, Noon's tests, OCT of both anterior and posterior chambers, phosphine, and other methods of examination. There is also a different system of examination of patients where we grade the stages from 0 to 3. You can see these gradings in the table here. According to the scores, where this most severe case with dry eye symptoms is significantly affecting ADL, the special eyewear to relieve pain, or unable to work because of ocular symptoms or loss of vision due to KCS. Speaking about the principles of patient management and treatment those with ophthalmological manifestations, we have to follow the basic principles of systemic and local treatment. The systemic one is prescribed simultaneously with local one and sometimes includes steroids, the degrees of drainage, the humidification should be performed with hyaluronic acid, with dexapantanol, ointments. We also have to decrease the inflammation of the eyes by use of local steroids, controlling the intraocular pressure at the same time. We have to use topical cyclosporine, decreasing the immune response on the surface of the eye, and taking vitamins, providing for healing of the surface of the cornea. Also, hygiene of the eyelids has to be followed. Sometimes warm compresses, doxycycline, combined with other listed here preparations has to be performed. The patients has to feel the improvement of the surface of the eye and protect it. Surgical treatment of eye complications of the disease include focal occlusion, tarsorrhaphy, transplantation of amniotic membrane, which may be used for treatment of severe dryness of the eye, degeneration of cornea, with or without perforation. And the last method of surgical treatment is deep anterior layer by layer keratoplasty or penetrative keratoplasty, which may be used in extremely severe cases. This table shows the scheme of patient management with ocular manifestations of GVHD. In the most severe cases, this is the use of tarsorrhaphy, prochera, or amniotic membrane transplantation. Retrospectively, up to 2023, we had 3 patients, all women, 52, 32, and 26 years old. The patients had both eye lesions. All patients were systemically treated. The clinical manifestations included light sensitivity, stable pain syndrome, OSDI was increased up to 100 scores in 2 cases. The cornea was painted. Schimmer's test showed 1 millimeter, 5 and 2 millimeters respectively in our patients. Main clinical examples of treatment of these patients included focal keratopathy and ulcer of the cornea. We used antiseptics without conservants. We used artificial tears The percentage of solutions are shown here on this slide. We used eye drops with the otological serums. We used ointments with vitamin A combined with hygiene of eyelids. As a result of long-term complex therapy, all the patient's condition improved. OSDI lowered to 75, 62, and 78 scores. The pain, the coloring of the cornea with fluorescein did not was not over 2 scores. The formation of tears also increased. Positive changes was followed with increase of visual acuity. We also performed amnioplastics with blepharophy. It did not show significant results, so lamellar keratoplasty was performed in the end, and only then the clinical effect was stable and successful. Thus, this disease, graft against the recipient, is still a really widespread complication after transplantation of hemopoietic cells, which occurs in 30 or 70% cases. Long-term use of systemic anti-inflammatory and immune suppressive therapy combined with local antiseptic and anti-inflammatory artificial tear therapy leads to successful results. Thank you very much for your presentation. Unfortunately, we don't have any time for questions.
Сучасний погляд.
The next report, a modern perspective on parainflammation in dry eye disease. It's an institution of eye diseases. You're welcome. Good day, dear colleagues. Today, my report will be dedicated. Sorry, some technical issues. My topic will be the issues of parainflammations. These are new mechanisms that I studied by ophthalmologists all over the world that include in pathology of eye. I have no financial interest. So let's talk about parainflammation. During the last 2 decades, we understand the origin of eye dry disease and we changed our vision and understanding of pathogenesis and another science. But this pathology is connected to tear cover and eye inflammation. Then you know that there were DIAS-2 sessions and this disease was connected to chronic inflammation. In 2023, Michael Stern and Stefan Barabino made a theory that acute inflammation is associated with tears. It increases the level of cells producing their cells and influence on the surface of cornea. The density of cells of course are affected, and of course diaplasms of conjunctiva and decrease in cornea sensitivity. Changes of conjunctiva epithelial cells What about history? In 1994, Gabriel presented the concept of perinflammation. These are forms of inflammation with a moderate but stable immune response without signs of inflammation. And in 1208, it was an intermediate state between homeostasis and inflammation caused by stress, change of environment, so stable signs and systemic changes in organism. And perinflammation is the support or recovery of homeostasis, so it's a key for treatment. Very briefly, I want to tell you the diagnosis between types of inflammation: perinflammation, subclinical inflammation, and chronic inflammation. Perinflammation is adaptive response of our body. It's a local response without inflammation, with a low level of cytokines and active inflammation of cells. Subclinical inflammation is inflammation without clinical signs, but we have biomarkers in tears and in eye tissues. There are biomarkers of inflammation that can be revealed by tests. Chronic inflammation, it's a long-term inflammation process with step-by-step impairment of tissues. We have cell infiltration, macrophages, and lymphophage. Then clinical inflammation, it's inflammation with rushing, with tearing, pain, and we have a very bright and active clinical picture. What do we know for today? In 2023, there was a European meeting of experts on dry eye disease, and they discussed the evidence of pathogenesis and mechanisms of perinflammation and inflammation, changes of lipid mucin, perinflammation and inflammation. And cortisol, our hormone cortisol, is paid much attention to. It's a disbalance between impairment and protective mechanisms. So it's a functional response of our body. Immune response during the eye dry disease, it's not only one type of immune response. We are talking about adaptive and born immunity. What about born immunity? It's a first response of epithelium of our eye cells. We have TLR4, TLI9, and then infiltration by macrophages, neutrophil, and activates the cell ptosis, and then it's reveal of IL-6, IL-alpha and beta, and then we include adaptive immune response. What about our activation of adaptive response? We reveal IL-17, and they can provoke autoimmune response. It is very important when a patient has Sjogren disease. And then impairment of control may cause the reaction of adaptive immune response because normal inflammation reaction makes indifferent makes impossible impairment of tissues, and it helps us to prevent from born immune response to adaptive response. So our born immune response is crucial when we are talking about eye dry disease. It helps to decrease it and to treat. because when our tear cover is impaired, our bone immune has to help to overcome this state. Then, when bone immune response is high, we can prevent this disease to be chronic and to use target therapy. Our modulation of bone response is a prospective way for development. Therapy can influence both on bone and adaptive immune response. There are new approaches for personalized treatment. For today, what strategies we have for control of parainflammation or inflammation? There were a lot of researches, and there is no one conclusion on specific ways of treatment in order to decrease parainflammation of eye, but local steroids are the most effective anti-inflammation medical products. For today, the biggest role play the substitutes of tears and modulators of eye surface. They should be used on a constant basis in order to reduce this burden with the immune cells that were activated during the bone immune response activation. Then we studied this disease caused by diabetes mellitus group 2. We have subclinical parainflammation types of inflammation. The systemic immune response influence on our systemic immune response and on our tear cover. This treatment help us to ruin these cells, so that's why parainflammation is a very acute and relevant topic when we are talking about diabetes mellitus. The influence of diabetes to this disease is covered by the Association of Diabetes Mellitus. There can be hyposmolation of tear, decrease of density, and in other signs. So there is direct connection of diabetes mellitus and dry eye disease. Decrease of mucin level and activation of bone chain of immune response. Immunocytology of patient with diabetes mellitus group 2, 80% with diabetes mellitus have flat cell metaplasia, and the stage is irreversible. And there was interest in the inflammation by macrophages and neutrophils. In 28% of patients, and there was also an expression of CD15, activation of neutrophils in 65% of our cases. So it's a specific biomarker of parainflammation and inflammation processes in patients with diabetes mellitus. What about tear liquid in patients with diabetes mellitus? As to our researchers, the amount of general mucin, the decrease was by 30% compared to patients without diabetes. And then we have oxidated glutathione and non-oxidated glutathione, and we can see also the decrease. Strategy of treatment of such patients: it's a compensation of diabetes mellitus, normalization of blood glucose, normalization of lipidogram, then therapeutic hygiene of eyelids, tear substitute therapy with a mild effect that will influence on the bone immune response. And taking into consideration the impairment ethiol status, antioxidant therapy should be included. Of course, it should be without conservatives. Results of our researches, as together with our therapy, increase of the density of cells and the decrease of infiltration in 67%. Markers of eye impairment that can show you inflammation or parainflammation. TNF, MMP, MAC-C, expression of CD15 on epithelial cells, and of course increase of T osmolarity, decrease of density of cells, and impairment of antioxidant system. So parainflammation is our protection immune response. By its activation cause chronic process in our body. It's a central chain in eye dry disease pathogenesis, and its influence on the dysfunction of our eye. Modern therapy should be oriented on moisturing and control of this process. It can increase the effectiveness of treatment and quality of life of our patients. The last slide, I want to cite one of the specialists. He compares parainflammation with the equilibrist. You see this man. You see this man on this image, and he tries to keep the balance. But we won't be able to keep balance all the time. So our main task is to control parainflammation. Thank you very much, Tatiana Mikhailivna, for this fundamental and interesting report.
This is Averyanova Oksana Sergeyevna with co-authors, new cross-linking protocols for subthreshold thickness. Kyiv, ILAS Medical Center. Today we see that keratoconus is more often observed, and it becomes younger and younger, manifests in younger and younger patients, probably due to change in ecology, due to increase of number autoimmune diseases. In our practice, we follow the global consensus made and published in 2015, and our specialists who worked on it made several conclusions which we use. We understand that it is commonly accepted that cross-linking is the first line, first choice treatment. Why is that so? Because there is a very small percentage of complications, up to 3%, and the effectiveness is high enough. Only 6% cases have progressing keratoconus. We know that cross-linking takes place in over 83% cases, and it allows for the Fuchs dystrophy becoming on the first place among all cases of keratoconus. Unfortunately, today there is no upper or lower age limit for cross-linking. Our youngest patient was 9 years old, and the oldest was 64 years old with proven effectiveness. There is no consensus as to the procedure because of absence of progressions, but we treat pregnant women, we treat children with it. Sometimes people who have triggers like thyroid gland diseases or autoimmune diseases, they are the patients within the risk group, but in this case we offer keratoconus treatment to them, and this is their choice if they agree to cross-linking or not. Usually they agree because there are really few complications possible. Speaking about correction of visual acuity, after such treatment, any type of correction can be used, chosen by either physician or by the patient. Speaking about the term and demarcation depth, we know that the depth depends on epithelialization and infiltrations on account of the fact that the procedure takes place faster, and we can decrease the time for the procedure and remain within the dosage which has to cause thickening, higher increase of density of the cornea. We use our knowledge of where demarcation line is located depending on the age of the patient. We know that we can perform it with epithelium or without it, removing the epithelium. But when we leave the epithelium, we see that the recurrency or further development of keratoconus is higher. So physical limitations, age limitations, they play certain role in the process. We take patients with different systemic diseases, like children with Down syndrome. We also work, we sometimes want to perform cross-linking and not transplant the cornea. So we would like to preserve our patients' visual acuity, but we don't want the cornea to thin. That's why we can use hypotomic solutions to thicken cornea. For a certain time we used soft contact lenses without UV filter in order to perform cross-linking, but today there are nomograms of shortened cross-linking when we thicken the energy flow and decrease the impact period in order to reach certain demarcation line and use the dosage which is proper for us. Surely we can do it with children with developed keratoconus, with the thin cornea, but we would like to postpone transplantation of cornea. We also wish to perform it in patients who are satisfied with their visual acuity. The procedure lasts 30 minutes. In cases if the thickness of cornea without epithelium makes up 3 micrometers. So the demarcation line, demarcation limit has to stay within the safe threshold. We have performed the following research of 165 eyes with thin cornea, and we have three criteria, three factors when we can say that the procedure was safe. So first of all, it's confocal microscopy, then it's progression keratoconus protocols, when we follow if the keratoconus is progressing or not. In this table, you can see assessment of dynamics with help of progression protocol. You may see that the demarcation line is where it was calculated to be. Follow-up of this person takes place within a year post-operatively, and you may see that this protocol does function and the progression of keratoconus stops. What are the results of our job? First of all, it's safety, because in none of the cases we saw complications. There was no damage of endothelium, and we obtained demarcation line where it was theoretically calculated, meaning that we did not cross the demarcation line. And we have a second result, which is effectiveness. However, we have a couple of cases which are, I would say, tragic. We had a patient, 14 years old, with keratoconus for 3 years, third, fourth stage. You can see that we performed accelerated cross-linking for 10 minutes because the thickness was too low. And you can see the epithelium effect, where the epithelium was 301 micron. We chose the protocol for 300 microns, calculating the time for our patient's thickness. So here you may see that everything is in its place. With the scleral lens, the visual acuity is 0.65. Another patient was 24 years old with keratoconus of fourth stage. The visual acuity in one eye was a little better than that on the other. You can see here her dimensions, her thickness, only 107 microns for stroma, and all the rest was for the epithelium thickness. So we made OCT to make sure that there is no effect on the epithelium. We chose her protocol for 9 minutes, expecting demarcation for 250 microns. And the result was as we had calculated. Here are the images of microscopy with thickening of the corneal layers. Everything went well as we had planned. And another patient of 18 years old from Kyiv city had decrease of visual acuity for 1.5 years. He complained to his parents, but his parents did not pay attention to it until they referred to us with keratoconus of fourth stage. Unfortunately, he came so late with such dramatic decrease of visual acuity. We made topogram, we made OCT, and saw his thickness 264 in the right eye. So we chose his protocol for 283 microns demarcation. You can see that there is still some thickening, there is still some collagen linking In 260, the stroma was normal as well as the epithelium. After the operation, we found customized lens for him, expecting follow-up and expecting transplantation of cornea in this case. Among our conclusions, we can say that use of nomograms, thin cornea for cross-linking is safe and effective. OCT and confocal microscopy are reliable methods for diagnostics of thickness of cornea and demarcation line and endothelium stage condition. Thank you very much for your attention. Thank you, Oksana Sergeyevna, for your interesting report on such severe cases.
The next report is impairment of cornea and eye surface damage when there are skin diseases. Please reduce if you can. Good day, dear colleagues. Today I want to present to you a report on impairment of corneal and eye surface at the dermatological diseases. As ophthalmologists in our practice, we have dermatological diseases that cause eye inflammations and vice versa. Most often, the reasons are rosacea, acne, dermatitis, psoriasis, and in other clinical case, patient 36 years old, decrease of visual acuity, redness, and fear of light. We know that he has a low sight from childhood. He didn't wear spectacles or lenses, and no compliance from other sides, no other compliance. Objective picture, we have OD, mucus and purulent discharge from conjunctiva, and in external layers of stroma, a big veil, and neovascularization of limb. OS is proper light projection, and also mucopurulent discharge, vascularization of cornea, and lymph vascularization, and vision is 0.03. Pressure is normal, and in other indications as well. But we pay attention that he have a lot of pustulas on his beard and on his hair. So this stage he has had for several years, but he hasn't paid attention to it. Photos are illustrative because he didn't give a consent for his photos illustration. So we perform additional examination of urologist and another specialist. Remo tests are within normal change. Then bacterial scrap was within normal range. Dermatologist consultation. Diagnosis: psychosis. It was caused by staphylococcus, and it impairs men of 30-40 years in the areas of mustaches, beard, and hair. It is characterized by forming of follicles and forming foci. The diagnosis was established. So OD, subtotal vascularized opaque of cornea, OC, fluctinolosal keratitis. And what about treatments? Hyaluronic acid, oxytocin, streptocin ointment, dexamethasone, non-steroid medicines, tetrazolene, amoxicillin, intravenous calcium gluconate, ascorbic acid, dimedrol, dexamethasone. Here you can see the prescription and the state of patient in a month. You can see that surface was epithelialized and the vessels reduced. There were some focal opaques, vision OD 0.03, vision OC 0.14. Conclusions. We want to highlight that it is necessary to see the connection between dermatological diseases and eye diseases, because we will have good result. And we have another one report of Hurdal.
Psych, DSEC or DMEC for Fuchs endothelial dystrophy results from randomized study. This report is recorded and we are going to listen to it at the last international section. That is why, if you wish to have discussion, we could have it now about the first session. I would like to thank everyone who took part in listening and reporting, and this is not accidentally that the pathology of cornea has opened our congress, because as far as I am concerned, this pathology is more and more topical and it's becoming more and more severe. So that is why there were so many questions. Also, I would thank the Institute of Filatov, because of course we know everything, we treat everything, but whenever something fails, then our patients are referred to you, usually with the most severe pathologies. Yes, I would like also to thank the speakers who made important and interesting reports. We are going to have 10 minutes break now and then the next satellite.
Вже більш ніж на 75 країн світу. Комерційний оборот ТЕА становить більш ніж 865 мільйонів євро. Компанія ТЕА має далекий горизонт стратегічного бачення. Для неї властиве швидке реагування та надійні системи незалежних лабораторій, що займаються виключно вивченням питань офтальмології. Засновники та директори компанії Анрі та Жан-Фредерік Шибре належать до генерації засновників цієї галузі. ТЕА щільно пов'язана із десятками тисяч спеціалістів-офтальмологів з різних країн, які довіряють нам та яких ми підтримуємо протягом довгого часу, особливо в сферах удосконалення та обміну знаннями. ТЕА має значний експертний досвід у багатьох галузях, а саме в розробці інноваційних продуктів різних класів, а також досягає успіхів у лікуванні глаукоми, алергії, інфекційних уражень, запалення, хвороби сухого ока. За допомогою ТЕА було створено нові концепції та нові ринки для продуктів, що не містять консервантів, продуктів для підтримки зору, для гігієни повік, антибіотиків для внутрішньокамерного введення та мідріатиків. Основою вибору найкращих виробників для кожної фармацевтичної форми є зберігання компанією певних стратегічних технологій. Маркетингові технології компанії створено в комбінації з однією з найбільших систем медичних та фармацевтичних контактів у сфері офтальмології. Відділ розробки має визнаний експертний досвід у створенні фармацевтичних форм, розробці продуктів та проведенні як доклінічних, так і клінічних досліджень, а також у сферах реєстрації продуктів та виводу їх на ринок. TEA Open Innovation – споріднена організація компанії TEA, що займається створенням партнерств та підтриманням стартапів, співпрацює з компаніями з розробки медичних та біологічних технологій та з університетами з різних країн світу для створення інноваційних технологій та методів лікування майбутнього. TEA – унікальний партнер у сфері офтальмології.
У світі, де науковий прогрес змінює наші можливості кожного дня, компанія TEA допомагає спеціалістам-офтальмологам, як тим, що тільки починають навчання, так і досвідченим фахівцям, що потребують регулярних тренувань для підтримання професійних навичок. TEA супроводжує спеціалістів-офтальмологів до їх майбутнього за допомогою Академії TEA, що централізує різноманітні активності, присвячені молодим фахівцям. Для підтримки ініціатив, що їх було створено молодими спеціалістами задля молодих спеціалістах, у рамках конференцій EMYO та окремих сесій, що проводилися під час конгресів за участю ведучих офтальмологічних спілок. Для хірургів, що тільки починають практику, чи тих, що хочуть вдосконалити свою техніку, є можливість працювати на симуляторах Dry Lab та Wet Lab або на хірургічних симуляторах. Ми запрошуємо резидентів та лідерів клінічної галузі для участі у Трофі, нашому міжнародному змаганню із презентацією клінічних випадків, що надає лауреатам можливість презентувати свій клінічний досвід у рамках відомих конгресів. Більш ніж 1000 учасників вже спробували свою вдачу. Також ми надаємо інституційну допомогу Європейському комітету з офтальмології, що надає молодим практикам можливість працювати у Європі. Динаміка обміну знаннями та їх розповсюдження не обмежується колом молодих спеціалістів, але стосується усіх практикуючих фахівців, як тих, що тільки починають працювати, так і визнаних спеціалістів. Глобальна ініціатива безперервного навчання відображується у проведенні численних заходів, що їх присвячено різним видам патології. TEA підтримує престижні заходи, наприклад, міжнародний симпозіум з глаукоми Мурфілд, що надає унікальну та рідкісну можливість вдосконалення, тому що цей симпозіум відвідують найкращі фахівці в галузі, що діляться своїм досвідом та обговорюють нові засоби у сфері лікування глаукоми. Кожного року тисячі спеціалістів-офтальмологів зустрічаються у рамках численних конференцій, що проводяться за підтримки TEA у різних країнах світу. До них відносяться навчальна конференція Retina, мастер-клас з питань поверхні ока, Європейський клуб спеціалістів з захворювань поверхні ока та глаукоми та коледж експертів з питань захворювань поверхні ока та глаукоми, хірургічна конференція TEA, а також тур TEA Vision, у рамках якого підкреслюється важливість застосування продуктів, що не містять консервантів. Календар міжнародних подій супроводжується редакторською підтримкою, що є частиною ініціативи ТЕА з комплектування медичної бібліотеки, яка присвячена різноманітним темам та типам патології, до якої залучено видатних спеціалістів з офтальмології з різних країн, що є ведучими експертами у своїх галузях. Протягом року ТЕА супроводжує молодих спеціалістів на їх шляху до успіху, а також підтримує визнаних фахівців.
Satellite Symposium by Thea Company. Let's Open Our Eyes is its name. And within the framework of this satellite, we are going to have 3 reports. The first one is presented by Dr. Professor Druzhina Halina Ivanivna, Head of Department of Cornea Pathology. The topic is modern approaches to treatment of neurokeratitis. So, please, Galina Ivanivna, the floor is yours. Dear colleagues, according to modern definition of the President of European Association of Corneal Diseases and Diseases of the Surface of the Eye, the diseases are conditioned by changes of nerves of the cornea, which leads to disorder of sensoric and trophic functions with further impairments of health and integrity of the membranes. If we look at epidemiology, we will see that it's from 5 to 11 cases for 10,000 population, 6% of all herpetic keratitis, a little more herpes zoster keratitis. But if we look at this list of diseases which might cause development of neurotrophic keratopathy, this is hereditary diseases, systemic diseases, impact of systemic preparations which patients take because of other pathology. This is central neural system lesions, Alzheimer's disease, Parkinson's disease, a number of local eye reasons. First of all, viral infections, influence on the surface of the eye of side effect of medications used by patients wearing contact lenses, burns, and practically, if you look, almost all operative surgeries, cataract surgery, keratoplastics, laser procedures, surgery of retina and orbit, which may cause the development of neurotrophic keratopathy. That is why I consider that this disease is determined more often. For today, it is well known that the mutual impact of nerves in cornea and epithelium itself is very important to preserve the integrity of the surface of cornea, because terminal nerves they emanate neuropeptides, and epithelium impacts the growth factors of neural tissue, neural epidermic factor, growth factor. That is why the basic branches of the pathogenesis of neurotrophic keratopathy are impairment of sensitivity and trophic innervation of cornea, decrease of production of tears, decrease of supply of trophic factors, decrease of regenerative potential, and persistent defects of epithelium with threat of perforation. The same authors also offered a new classification of severity level of the neurotrophic keratopathy. It is classified as changes of epithelium without defect of epithelium. So we can clinically see the picture of dry eye, but the patient will have lowered sensitivity of cornea. The medium stage is epithelium defect without defect of stroma, as well as decrease of sensitivity, anesthesia of cornea. The severe stage also concerns stroma, and all patients are diagnosed with neurotrophic keratopathy, because we know that the impact on stroma can really fast cause perforation. Our clinical examples of neurotrophic keratopathy of different etiology may be seen in these photos. Some of the patients have general systemic diseases. What must we know today about diagnostics of this condition? As always, thorough collection of anamnesis, paying attention to any processes inside the skull, like tumors, aneurysms, hemorrhages, somatic diseases, infectious diseases of the anterior chamber of the eye. It is necessary to ask the patient about addictions like alcoholism, drugs, which also decrease the sensitivity of cornea. This includes taking medications, both systemic and local, surgical treatments performed on the eye, and central neural system, as well as determination of third, sixth, and eighth pair nerve, pairs of nerves. We also have to always keep in mind the neurotrophic keratopathy and measure the level of sensitivity. So the algorithm of diagnostics include, first of all, the suspect of the disease. Then we try to measure the sensitivity. If it is normal, then this condition, neurotrophic keratopathy, is not probable. If the sensitivity is pathological, then we have to evaluate the stage of the condition. Speaking about diagnostics and sensitivity estimation, it can be quantitative or qualitative. For example, we take a cotton stick and start checking the sensitivity from the healthy eye, and then proceed with the eye, with the diseased eye. We perform differential diagnostics using different equipment. We try to exclude immune diseases as well as infectious diseases. If we look at the process of treatment of neurotrophic keratopathy, we see that mostly we use preparations like artificial tears, anti-inflammatory, immune-correcting, symptomatic preparations helping to regenerate the cornea. We use surgical methods as well, aiming always to prevent the destruction of stroma. We concentrate on the treatment at once and really thoroughly follow up, supervise the development of destruction of stroma. The treatment takes place stage by stage. We use installations, we cancel all the drops that contain conservants or phosphates. We use artificial tears, we use non-steroid anti-inflammatory drops, and necessarily any diseases of eyelids are treated together with neurotrophic keropathy. Basic preparations used to treat this condition are artificial tears. The first choice preparation is Telos Duo that contains 3% trigalosa and hyaluronic acid, and actually it impacts all the aspects of the dry eye. It has a really safe risk buffer, which in complex with the bioprotector trigalosa increases the metabolic activity in the epithelium. The second stage is use of soft contact lens, water serum of blood, doxycycline per os. Also, lateral blethroscopy may be used temporarily or long term. We can also perform transplantation of amniotic membrane. The third stage should be treated with 90% blepharophy, transplantation of amniotic membrane, covering of conjunctiva in threatening situations, as a rule in combination with blepharophy. At all the stages, we use artificial tears and choose trigalosa with hyaluronic acid because it is more significantly providing thickening of the tear coverage even in dry eye disease of moderate stage on the surface of the eye over 4 hours. As it is an inflammatory disease of the surface of the eye on the cornea, it is really important to us that this preparation is not only moisturizing and providing for biological protection, but also it decreases the concentration of inflammatory cytokines and lowering the inflammatory markers, contributing to regeneration of cells. This preparation is practically always used by us in complex treatment of our patients, treated conservatively and surgically after keratoplasty. And what is also highly important is that trigalosa with hyaluronic acid provide for faster restoration of epithelium and neural tissues in cornea. We have conducted some experiments which showed that this combination of these substances equals in effectiveness in some cases to installations of water serum of blood. What else is used in our complex treatment? Probably you all have heard about RHNGF, which is already in the clinics. It's Oxervate or Senagermin. It can be purchased in Europe already, but it is indeed expensive. Besides, we used installations of insulin used since the beginning of 1990s, initiated by vitreoretinal surgery and platelet-rich plasma containing a number of growth factors and bioactive proteins, providing for regeneration of tissues. Speaking about insulin in treatment of neurotrophic keropathy, For the recent 2 or 3 decades, we have observed increase of interest to its use, and there has been a number of papers published about it. It was partially conditioned to the number of diabetes surgeries with vitrectomy that could cause keratopathy in cornea. So some receptors were discovered which are similar to growth factors of different types, and it was shown that these receptors are of key importance to keep the integrity of cornea. The clinical practice has literature, scientific data of use of insulin in different concentration from 0.5 to 100 international units. So the majority of authors prefer from 25 to 100 international units per milliliter. In the human insulin is used in our practice as well. Surgical measures, which I have not mentioned yet, it's partial or full blepharopathy, coverage of conjunctiva, keratoplasty, tectonic or penetrative or layer by layer one, neurotization of cornea, aiming at provision of re-innovation of cornea. This direction has been developing since 2009. It was used in combination of lesions of facial nerves. There are different methodologies of it used by neurosurgeons, and for today there have been several experimental research aiming at improvement of integrity of cornea. When neural tissues already appeared after 6 months and grew significantly by 12 months post-operatively. Transplantation of amniotic membrane is a really important method used by us since 2014. Annually, we perform over 50 transplantations, 76% of which are due to neurotrophic keratopathy of different etiology. We have neuropathic ulcers, and in this case combined complex treatment is used. Blepharopathy together with keratoplasty is usually combined in order to increase the life quality of patients. Here are 2 untypical clinical cases. These are patients who obtained pretty many surgical treatments. A patient of 40 years old who was referred to our department with such neurotrophic persisting defect of epithelium of the transplant. From his anamnesis, we understood that he had piercing trauma with the loss of membranes during his garden works, and at his location, residence location, he had primary surgical treatment, but he was referred to us with secondary detachment of retina, where he got transciliary keratomy with prosthetic in our post-trauma department. He got installation with antiseptic, antioxidants 6 times per day, insulin 6 times per day, dexpanthenol streptocid eye ointment, Azarga. All the list of preparations might be seen on the slide. 3 weeks post-operatively, the defect of the epithelium of transplant decreased. The edema in stroma persisted though, so the patient continued having hyaluronic acid. 2 months after the surgery, his surface was epithelialized. Vascularization was moderate, but there was residual edema of stroma transplant. His visual acuity was 0.02. He got recommendations, which might be seen in the slide. Another patient of 65 years old with opaque cornea, idiopathic panuveitis and secondary glaucoma in condition after endotrabeculectomy, closed vitrectomy, and you can see almost 4 years since 2019 the number of surgeries which were performed because of his basic condition. For the recent 2 years, he had persisting epithelium defect, not healing, irritation of the surface, light sensitivity, injection of conjunctiva. The patient was consulted in our department of inflammatory diseases of the eye. You can see the analysis, the tests which were performed. The diagnosis was medium uveitis, autoimmune, cyst, edema, steroid, secondary glaucoma, condition after vitrectomy, neurotrophic keropathy. He was also prescribed with antiseptic, antioxidants, solutions, 5% natrium chlorine, trigalosa with hyaluronic acid, and systemic treatment as prescribed for the general condition of the main disease of the retina. 2 weeks postoperatively, his condition was improved, the injection was lowered, the defect of the epithelium was decreased. Azarga was substituted with another preparation. 2 months post-operatively, the patient had improvement in cornea. The patient did not wear contact lenses. He took the prescribed preparations and he is still getting systemic therapy and local complex of trigalosa with hyaluronic acid, dexpantanol. For 1 more month, he got installations with insulin, and we are really satisfied that the edema decreased and visual acuity in the left eye increased up to 0.1. Why do we like this preparation so much? Tialose Duo, not only because it has high level of safety, almost never we found complaints of allergic reactions or discomfort, but also this preparation may be used while wearing contact lenses since childhood. It can be used by women in pregnancy and lactation periods. What I would like to add is that when our patient overcame many surgeries in their eyes, like you saw from my example, which I showed you in the beginning of the lecture. Each surgery can be a factor for neurotrophic keropathy, so you never should forget about this risk. And you have to check for light sensitivity in any way you can. And you should always keep in mind the use of artificial tears preparations, like this preparation which is preferred by us. Trigalosa with hyaluronic acid. Thank you for your attention.
Thank you very much. It was very interesting report. We have now time for discussion. Let's present our next speaker, Professor Ulyanova Nadia Anatolievna, with a report, cataract analysis of rare clinical cases. Good day, dear colleagues. Taking into consideration our time, we will move further. Of course, cataract is out of norms, and it's the most performed surgery in every ophthalmological hospital. But of course, sometimes you can be in the situation with this boat. You won't know the outcome. Of course, you can see the water flow and the fire burning and the professional performance of cataract. And because cataract surgery is developing very quickly, when surgeon has no obstacles, capsular access without any stops or fragments are removed without problems. Cortical masses lens is implanted, is grafted, and all are happy. But unfortunately, we have different scenarios. Why do we have difficulties? These difficulties uh, can be divided into foreseen and unforeseen, and sometimes they can change their places and they can cause complications. What are the pitfalls of surgeons? Opaque cornea caused by keratitis and together with neurotropic keratitis, previously performed surgeries, then injuries. Then, even if cornea is transparent, lack of mydriasis is also a pitfall for surgery. Then the weakness of ligaments and other. What difficulties can we have? The rupture of posterior capsule, practically 50% if we have the rupture of this capsule. Even if it is not expanded and it is localized, we should remember that vitreal body prolapse will increase the development of vitreolitis, and it will increase the risk of retina detachment. Another one pitfall is floppy iris syndrome of non-strong iris. Then we will study it step by step. Lack of visualization. How can we help to ourselves during the surgery? In this case, in our trauma department, we use the epithelialization of cornea is the easiest way. We peel epithelium and cover with viscoelastics, and then under the lens we increase highlight these red reflex. So this lightening of lens, posterior cavity, we can have better visualization. We can use it targetedly and on the lateral side. We can see the patient with keratitis, vascularization, and after the lightening behind the lens, there was no necessary visualization. So you can use the target lightening, and it will increase the possibility to see the capsular axis. Once again, cornea can be the pitfall for phacosurgeon, but its absence also doesn't help. Very often we have cases when we have to extract cataract, and the surgery on the with the open chamber is a challenge. We may have problems with the capsular axis, so we should begin it centralized and then move laterally. There is also a risk of hematology. We should be prepared thoroughly and be prepared for possible complications. And in order to move this nuclear, when our space is open, we should remember about the power of cornea and their dimensions. We see all the dimensions are bigger. IFIS syndrome, so-called, it is easily diagnosed intraoperatively when you penetrate by phaco or nail phaco eagle to the iris, and when you have edema and when you have a heel, it's the sign of IFIS. There is a great risk of iris prolapse, not only in form of tunnel but paracensis. And the most unpleasant moment during the operations that pupil is narrowed very quickly. Risk groups are patients with a systematic treatment of blockade medications, patients with prostatitis diseases. So when you have a previous consultation, when you make a pre-examination, it is necessary to ask about the systemic therapy. And also pseudocapsular syndrome is one of the peculiarities of this surgery. What should be the strategy? There are several strategies here. Of course, here you can see the combination of subtenon, lidocaine, and in other prescribed medicines is highly used. We used iris retractors, but there is a technique of microsphincterotomia. It is also usable, but the philosophy of our surgeons won't allow our surgeon to injure iris more. Super strong cataracts are always unnormal because previously our professors, our scientists, they made big incisions and then they began to use small incisions and they use scleral incisions. But for the surgeons of new generation who work with a closed closed camera, closed chamber. It is a challenge to perform this intercapsular penetration. In this clinical case, I can say that the nucleus of this patient was underestimated, but we tried. We began as phaco emulsification, but taking into consideration maximal parameters, we will damage the cornea. We take a decision to mechanically put away the nuclear. You can see this corneoscleral incision. It's our floppy iris, you can see it. And after the removal of nuclear and cortical masses, you can see posterior chamber without damages, and we used three-component lens with a fixation. And then you can see we repair the iris and finish our surgery. Also about difficulties of cataract surgery. For example, if phaco surgeon has to do primary capsulorhexis, it is necessary to be ready for it, especially when we have posterior polar cataracts. They are inborn cataracts, and these opaques are intensive. And despite the polarization, you can see that they are opaque. There is a shadow. And this challenge issue can be resolved in postoperative period with the help of laser, but in this case we took a decision after the grafting of IOL to install viscoelastics between posterior chamber and IOL and to perform posterior capsulorhexis. You can see that this flap is removed easily, and we have transparent posterior capsule. There are some changes to make to put our eye in a proper location. And when we are sure that there is no prolapse, so we may perform hydroadaptation. When we have intervention of iris into cornea, we perform transallar approach, and here you can see all the process. We implant the lenses fixed to sclera on 3 and 9 hours standard technique. Take it into consideration that this report is within satellite symposium of their company. I want to highlight several medicines, namely eye drops that are used for correction of eye surface condition, well-known preparation, artificial tear, that due to all relevant recommendations is used in patients for correction of dry eye disease. And the company that holds satellite right now have all necessary preparation medications in his disposal, and there are facial tissues, hygienic tissues, and antibiotics for short courses with a high efficacy. Patients with a preoperative dry eye disease using Telos Duo make better their conditions for grafting IOL. There were studies that patients with eye dry disease have increasement if we are talking about toric lenses with the use of Telos Duo and without Telos Duo. if a patient use Hielos Duo, the time of tear film detachment and disruption reduces. And of course, it will be the change in our studies. And patients with blepharitis, we are talking about patients with cataracts, diabetes mellitus. It is necessary to eradicate pathogenic microflora because these microflora of eyelids can cause difficulties and complications of the main diseases. We have the results, proven results, that this infection was simple, but it caused very serious difficulties and complications. Their preparations are highly described and you can use it. So there is a scheme azithromycin, 1 drop once in 3 days. It helps to prevent the development of gram-positive and gram-negative microorganisms, and it is without conservatives. I want to add that in comparative study in patients that use artificial tears without trigalosis, their results were worse than patients that use artificial tear with trigalosis because it also influences on epithelialization of nerve fibrosis of cornea. Tylosis Duo decrease the manifestations of postoperative inflammation, and of course it's a great advantage of this preparation. That's why we prescribe it in our postoperative scheme. I don't want to repeat one more time, but complex approach together with the surgery and treatment, adequate conservative treatment is the way to reach success. In conclusion, I want to tell you that abnormal cataract needs non-standard decisions. You can see here the fall of nuclear, and after the implantation of IOL, we have here aphakic eyes, artiphagic eyes. This lens was installed in its natural place in the capsule, and there were opportunities to do it. We performed ultrasound phakification, and these joint techniques of several fields help us to reach the best result. Thank you for your attention. Thank you very much.
The next report, Umanets Mykola Mykolaievich, Professor, Doctor of Medical Sciences, diabetic retinopathy. Is there a light in the end of the tunnel? Good day, dear colleagues. First of all, I'm glad to greet everyone here, dear Presidium, dear friends, our satellite symposium, and my report is about opportunities, about proliferative diabetic retinopathy. I will not talk too much about topicality of the topic because we're amidst pandemic. But the numbers are impressive. 500,000 of newly registered patients have been in 2022, and about the same we've had in 2023. The problem is that half of these patients are living without diagnosed diabetes, and many of these patients have lower hemoglobin, and they are decompensated by the moment when they are diagnosed. They have neuropathy in 26% cases, retinopathy in 17% cases, nephropathy in 7% cases, and so on. So we are looking at the fundus in a very thorough way. To diagnose diabetic retinopathy, which threatens with neovascularization, with formation of films and formation of tractions, which cause detachment of retina, and in some cases we cannot help even with surgery. So about this picture is what we saw 20 years ago. Many surgeons would just give up and not be able to help. But for today, for the present, the situation has changed a lot. By use of modern treatment methods, we easily resolve such complicated problem, which you can see in the video. This happened due to equipment of tools, equipment. We are using bimanual technique. We are using peeling of the internal border membrane. We are using panretinal coagulation. We also prescribe vitamin antioxidant complexes, which aids us. But anyway, there's still the problem of hemostasis, despite our steps forward. What are we doing now in order to decrease the number of hemorrhage in the operating theater and outside it? One of my colleagues mentioned that aflibercept administration 3 or 5 days before vitrectomy allows to decrease the risk 3 or 5 times. Some systems of control of the pressure also helps us, and we use electric diathermal coagulation. Despite all our achievements, 75% of risk of hemorrhage is still there. One of our questionable methods is temporary tamponade, which can affect the number of hemorrhagic complications. This has been proven by Dmitro Vasilyevich Murik, medical doctor who published his work on this topic. How do PEV2 organic solutions work? They are indeed transparent, they are chemically and metabolically inert, they have low viscosity. A little about the history. First attempts of use of these medications were made in the 60s in 1960s. First of all, they were used as plasma substitutes, and in 1982 Haidt with his co-authors reported about their experience of intravitreal administration of the substance. Pevton octan and pevtodecalin, which is a little heavier than the first one, are used. So the goal is to assess the effectiveness of vitrectomy with the use of the substances. We had 12 patients with 12 eyes of first or second type of diabetes. We had 5 eyes with detachment of retina and partial hemophthalm. We used anti-VEGF preparations 3 or 5 days before surgeries. We used Perf-Torm organic substance tamponade, which was temporary. We made revision and used silicone or gas tamponades. This table shows the data on our patients. 2 months post-operatively, we also evaluated functional results, anatomical results, and residual manifestations. Every case allowed us to remove the membrane in full, in 100%. We also had 3 cases of hemorrhage. We used Perft or Octan in one case. The longitude of temporary tamponade was 5 days. And speaking about peculiarities, we had periretinal hemorrhage in one eye, we had ophthalmic hypertension in 3 eyes, we had full attachment of retina in 11 eyes. In one case, we had partial detachment of retina, which lasted. Also, have a look at the picture. These are the cells of epithelium, as we think seen in the posterior part of the lens, and this will be the question for the discussion because we haven't managed to explain their origin. This table also shows the data on our patients, the data of usage of various tamponades, the visual acuity in patients. A couple of clinical cases will be demonstrated here. Here's the tractional detachment of retina. We are removing the film. It is being removed without complications or tears. We notice significant hemorrhage and significant deformation of retina. We administer Decalin, and 5 days after there's revision, we are removing the residual periretinal hemorrhage and finish it with silicone oil tamponade. Another case was total detachment of retina, diabetes. The case is really severe. We managed to remove the film, and we are working by probe because modern constructions of vitrectomes allow us to remove a considerable amount of tissues by one tool. In this case, there was inflammatory effect provided. So here you can see these coin changes in the posterior area of the lens, which will have to be explained later. Additional laser and silicone oil tamponade. This is the dynamics. 1 week post-operatively, the retina looks normally, and petechial hemorrhages were formed, but they were non-significant. 3 months post-operatively, the condition was stabilized. And the last case was one eye, a girl, first type diabetes. We are performing the operation as the last resort because as a rule we refused from such kind of treatment surely. After removing of the film very quickly, like the surgery lasted about an hour, which is quite long for diabetic retinopathy. So now the retina looks like retina should. Unfortunately, we could not do anything with the blood circulation. What can I say about post-operative period is that use of preparations with the IA formula is effective. How can this formula of AREDS help? It contains vitamin D3, acids. A very special attention of these preparations should be paid for treatment of patients with the anti-VEGF effect. Besides, resveratrol in long-term use can contribute to treatment of the condition and avoid proliferative conditions. Besides, an interesting research was performed by Thea company about patients with anti-VEGF therapy, and it was proven that patients who took Risvega had better anatomical thickness of retina, and this group required fewer intravitreal injections. So Risvega in complex with anti-VEGF therapy in patients with macular edema shows good effect. Here you can see the advantages of this molecule helping in the post-operative period. Low dosage Risvega provides for better microcirculation and prevents neovascularization, supporting hematoretinal barrier. To conclude, our temporary tamponade of Perftor organic substances supports us in quite severe cases. As our research showed, we had less problems with these substances, with these medications. In all the cases that we researched, tractional deformation of retina was removed. So the usage of Perftor can only take place in the inpatient treatment. By no means one should use it at home. So the physician has to focus on this point. In post-operative period, the use of Nutrof and Risvega are able to help us and support our patients. Thank you very much for your attention. Thank you, Mykola Mykolaievich. We are finishing the satellite symposium. We would like to say thank you to all the speakers, Mykola Mykolaievich, Nadia Anatolievna, Galina Ivanivna. Also, we would express gratitude to Thea company for their support. So please come to us, join us. We would like to present you a small certificate of gratitude. Thank you for your friendship for many years. We are doing it together. Thank you.
ТЕА – це незалежна європейська група номер 1 у галузі офтальмології. Це глобальна група, що має розгалужену структуру, яка постійно поширюється та становить вже більше 35 філій. Комерціалізація продуктів групи поширюється вже більш ніж на 75 країн світу. Комерційний оборот ТЕА становить більш ніж 865 мільйонів євро. Компанія ТЕА має далекий горизонт стратегічного бачення. Для неї властиве швидке реагування та надійні системи незалежних лабораторій, що займаються виключно вивченням питань офтальмології. Засновники та директори компанії Анрі та Жан-Фредерік Шибре належать до генерації засновників цієї галузі. ТЕА щільно пов'язана із десятками тисяч спеціалістів-офтальмологів з різних країн, які довіряють нам та яких ми підтримуємо протягом довгого часу, особливо в сферах удосконалення та обміну знаннями. ТЕА має значний експертний досвід у багатьох галузях, а саме в розробці інноваційних продуктів різних класів, а також досягає успіхів у лікуванні глаукоми, алергії, інфекційних уражень, запалення, хвороби сухого ока. За допомогою ТЕА було створено нові концепції та нові ринки для продуктів, що не містять консервантів, продуктів для підтримки зору, для гігієни повік, антибіотиків для внутрішньокамерного введення та мідріатиків. Основою вибору найкращих виробників для кожної фармацевтичної форми є зберігання компанією певних стратегічних технологій. Маркетингові технології компанії створено в комбінації з однією з найбільших систем медичних та фармацевтичних контактів у сфері офтальмології. Відділ розробки має визнаний експертний досвід у створенні фармацевтичних форм, розробці продуктів та проведенні як доклінічних, так і клінічних досліджень, а також у сферах реєстрації продуктів та виводу їх на ринок. TEA Open Innovation – споріднена організація компанії TEA, що займається створенням партнерств та підтриманням стартапів, співпрацює з компаніями з розробки медичних та біологічних технологій та з університетами з різних країн світу для створення інноваційних технологій та методів лікування майбутнього. TEA – унікальний партнер у сфері офтальмології.
У світі, де науковий прогрес змінює наші можливості кожного дня, компанія TEA допомагає спеціалістам-офтальмологам, як тим, що тільки починають навчання, так і досвідченим фахівцям, що потребують регулярних тренувань для підтримання професійних навичок. TEA супроводжує спеціалістів-офтальмологів до їх майбутнього за допомогою Академії TEA, що централізує різноманітні активності, присвячені молодим фахівцям. Для підтримки ініціатив, що їх було створено молодими спеціалістами задля молодих спеціалістах, у рамках конференцій EMYO та окремих сесій, що проводилися під час конгресів за участю ведучих офтальмологічних спілок. Для хірургів, що тільки починають практику, чи тих, що хочуть вдосконалити свою техніку, є можливість працювати на симуляторах Dry Lab та Wet Lab або на хірургічних симуляторах. Ми запрошуємо резидентів та лідерів клінічної галузі для участі у Trophy, нашому міжнародному змаганню із презентацією клінічних випадків, що надає лауреатам можливість презентувати свій клінічний досвід у рамках відомих конгресів. Більш ніж 1000 учасників вже спробували свою вдачу. Також ми надаємо інституційну допомогу Європейському комітету з офтальмології, що надає молодим практикам можливість працювати у Європі. Динаміка обміну знаннями та їх розповсюдження не обмежується колом молодих спеціалістів, але стосується усіх практикуючих фахівців, як тих, що тільки починають працювати, так і визнаних спеціалістів. Глобальна ініціатива безперервного навчання відображується у проведенні численних заходів, що їх присвячено різним видам патології. ТЕА підтримує престижні заходи, наприклад, міжнародний симпозіум з глаукоми Мурфілд, що надає унікальну та рідкісну можливість вдосконалення, тому що цей симпозіум відвідують найкращі фахівці в галузі, що діляться своїм досвідом та обговорюють нові засоби у сфері лікування глаукоми. Кожного року тисячі спеціалістів-офтальмологів зустрічаються у рамках численних конференцій, що проводяться за підтримки ТЕА у різних країнах світу. До них відносяться навчальна конференція Рітіна, мастер-клас з питань поверхні ока, Європейський клуб спеціалістів з захворювань поверхні ока та глаукоми та коледж експертів з питань захворювань поверхні ока та глаукоми, хірургічна конференція ТЕА, а також тур ТЕА Vision, у рамках якого підкреслюється важливість застосування продуктів, що не містять консервантів. Календар міжнародних подій супроводжується редакторською підтримкою, що є частиною ініціативи ТЕА з комплектування медичної бібліотеки, яка присвячена різноманітним темам та типам патології, до якої залучено видатних спеціалістів з офтальмології з різних країн, що є ведучими експертами у своїх галузях. Протягом року ТЕА супроводжує молодих спеціалістів на їх шляху до успіху, а також підтримує визнаних фахівців.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини. Не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут – інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня створення. І ще перший завідуючий відділом професор Скрипніченко Зінаїда Михайлівна і послідуючі її послідовники виховують в усіх співробітниках непереможне стремління до досягнення найкращих результатів, навіть в самих безнадійних випадків.
Відділ запальних захворювань ока є унікальним відділом в інституті, який існує більше 50 років. Його історія розпочалася з дослідження туберкульозу очей, що було дуже актуальним в післявоєнні роки, після Другої світової війни, звичайно. Наразі ми продовжуємо роботу наших попередників і ми займаємось такою складною патологією, як увеїти. Це орфанні захворювання, які є однією з основних причин сліпоти у молодих людей, у дітей, яку неможливо вилікувати хірургічно.
Сьогодні інститут надає як консультативну, діагностичну і лікувальну допомогу нашим пацієнтам. Ми лікуємо абсолютно всі, без виключень, офтальмологічні захворювання. Інститут в своїй структурі нараховує 475 ліжко-місць. 9 хірургічних стаціонарних відділень, консультативну поліклініку, 10 наукових лабораторій, а також інші клінічні підрозділи.
Особисто я пишаюсь тим, що декілька методик, розроблених в нашому інституті, в Європі називають по прізвищам наших фахівців.
Одна з головних місій нашого інституту полягає в тому, щоб зробити доступною сьогодні високоспеціалізовану офтальмологічну допомогу для кожного українця.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини. Не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут – інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня створення. І ще перший завідуючий відділом професор Скрипніченко Зінаїда Михайлівна і послідуючі її послідовники виховують в усіх співробітниках непереможне стремління до досягнення найкращих результатів, навіть в самих безнадійних випадків.
Відділ запальних захворювань ока є унікальним відділом в інституті, який існує більше 50 років. Його історія розпочалася з дослідження туберкульозу очей, що було дуже актуально в післявоєнні роки, після Другої світової війни, звичайно. Наразі ми продовжуємо роботу наших попередників і ми займаємось такою складною патологією, як увеїти. Це орфанні захворювання, які є однією з основних причин сліпоти у молодих людей, у дітей, яку неможливо вилікувати хірургічно.
Сьогодні інститут надає як консультативну, діагностичну і лікувальну допомогу нашим пацієнтам. Ми лікуємо абсолютно всі, без виключень, офтальмологічні захворювання. Інститут в своїй структурі нараховує 475 ліжко-місць, 9 хірургічних стаціонарних відділень, консультативну поліклініку, 10 наукових лабораторій, а також інші клінічні підрозділи.
Особисто я пишаюсь тим, що декілька методик, розроблених в нашому інституті, в Європі називають по прізвищам наших фахівців.
Одна з головних місій нашого інституту полягає в тому, щоб зробити доступною сьогодні високоспеціалізовану офтальмологічну допомогу для кожного українця.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
ТЕА – це незалежна європейська група номер 1 у галузі офтальмології. Це глобальна група, що має розгалужену структуру, яка постійно поширюється та становить вже більше 35 філій. Комерціалізація продуктів групи поширюється вже більш ніж на 75 країн світу. Комерційний оборот ТЕА становить більш ніж 865 мільйонів євро. Компанія ТЕА має далекий горизонт стратегічного бачення. Для неї властиве швидке реагування та надійні системи незалежних лабораторій, що займаються виключно вивченням питань офтальмології. Засновники та директори компанії Анрі та Жан-Фредерік Шибре належать до генерації засновників цієї галузі. ТЕА щільно пов'язана із десятками тисяч спеціалістів-офтальмологів з різних країн, які довіряють нам та яких ми підтримуємо протягом довгого часу, особливо в сферах удосконалення та обміну знаннями. ТЕА має значний експертний досвід у багатьох галузях, а саме в розробці інноваційних продуктів різних класів, а також досягає успіхів у лікуванні глаукоми, алергії, інфекційних уражень, запалення, хвороби сухого ока. За допомогою ТЕА було створено нові концепції та нові ринки для продуктів, що не містять консервантів, продуктів для підтримки зору, для гігієни повік, антибіотиків для внутрішньокамерного введення та мідріатиків. Основою вибору найкращих виробників для кожної фармацевтичної форми є зберігання компанією певних стратегічних технологій. Маркетингові технології компанії створено в комбінації з однією з найбільших систем медичних та фармацевтичних контактів у сфері офтальмології. Відділ розробки має визнаний експертний досвід у створенні фармацевтичних форм, розробці продуктів та проведенні як доклінічних, так і клінічних досліджень, а також у сферах реєстрації продуктів та виводу їх на ринок. TEA Open Innovation – споріднена організація компанії TEA, що займається створенням партнерств та підтриманням стартапів, співпрацює з компаніями з розробки медичних та біологічних технологій та з університетами з різних країн світу для створення інноваційних технологій та методів лікування майбутнього. TEA – унікальний партнер у сфері офтальмології.
У світі, де науковий прогрес змінює наші можливості кожного дня, компанія TEA допомагає спеціалістам-офтальмологам, як тим, що тільки починають навчання, так і досвідченим фахівцям, що потребують регулярних тренувань для підтримання професійних навичок. TEA супроводжує спеціалістів-офтальмологів до їх майбутнього за допомогою Академії TEA, що централізує різноманітні активності, присвячені молодим фахівцям. Для підтримки ініціатив, що їх було створено молодими спеціалістами задля молодих спеціалістах, у рамках конференцій EMYO та окремих сесій, що проводилися під час конгресів за участю ведучих офтальмологічних спілок. Для хірургів, що тільки починають практику, чи тих, що хочуть вдосконалити свою техніку, є можливість працювати на симуляторах Dry Lab та Wet Lab або на хірургічних симуляторах. Ми запрошуємо резидентів та лідерів клінічної галузі для участі у Trophy, нашому міжнародному змаганню, із презентацією клінічних випадків, що надає лауреатам можливість презентувати свій клінічний досвід у рамках відомих конгресів. Більш ніж 1000 учасників вже спробували свою вдачу. Також ми надаємо інституційну допомогу Європейському комітету з офтальмології, що надає молодим практикам можливість працювати у Європі. Динаміка обміну знаннями та їх розповсюдження не обмежується колом молодих спеціалістів, але стосується усіх практикуючих фахівців, як тих, що тільки починають працювати, так і визнаних спеціалістів. Глобальна ініціатива безперервного навчання відображується у проведенні численних заходів, що їх присвячено різним видам патології. TEA підтримує престижні заходи, наприклад, міжнародний симпозіум з глаукоми Мурфілд, що надає унікальну та рідкісну можливість вдосконалення, тому що цей симпозіум відвідують найкращі фахівці в галузі, що діляться своїм досвідом та обговорюють нові засоби у сфері лікування глаукоми. Кожного року тисячі спеціалістів-офтальмологів зустрічаються у рамках численних конференцій, що проводяться за підтримки TEA у різних країнах світу. До них відносяться навчальна конференція Рітіна, мастер-клас з питань поверхні ока, Європейський клуб спеціалістів з захворювань поверхні ока та глаукоми та коледж експертів з питань захворювань поверхні ока та глаукоми, хірургічна конференція ТЕА, а також тур ТЕА Vision, у рамках якого підкреслюється важливість застосування продуктів, що не містять консервантів. Календар міжнародних подій супроводжується редакторською підтримкою, що є частиною ініціативи ТЕА з комплектування медичної бібліотеки, яка присвячена різноманітним темам та типам патології, до якої залучено видатних спеціалістів з офтальмології з різних країн, що є ведучими експертами у своїх галузях. Протягом року ТЕА супроводжує молодих спеціалістів на їх шляху до успіху, а також підтримує визнаних фахівців.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини. Не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут – інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня
Good day, dear colleagues. Please take your seats. It's our time to start our satellite symposium. Bosch and Lom. We invite all who want to take participation in it, and we are very glad to communicate on this platform. And as to our agency, as to our agenda, the first report will be presented by Doctor of Medical Sciences, Head of Department of Pediatric Diseases, Bobrova Nadia Fedorivna. Nadia Fedorivna, the floor is yours. Thank you. Thank you. Today I will have a report. Simultaneous implantation of IOL and is a crucial part of cataract surgery. When we are talking about the eye of newborn, they have hypermetropic refraction, but there are different complications to establish the refraction, and it varies from 1.8 to 3.6 diopters. Not only the refraction data, but previous posterior anterior size of eye are not enough. As to the different authors, IOL implantation in newborn children is a discussable issue, and we have to dispute and to take as a resolution. There is an opinion that pars plana will be more effective than IOL transplantation. But look, as to the lumbar and limb data, phakia correction in newborn child is associated with the loss of contact lenses, difficulties in their substitution, development of bacterial keratitis, and it is very expensive. Manifestations for surgeries, form and size of IOL are the main pitfalls, and there is no one unique decisions among ophthalmologists. There are also different complications, and then growing of eyes and restoration of vision. For now, it is bad started and bad learned issue, because there were no big studies on this issue. I want to present you our data. We investigated and performed such surgeries on 100 children. Age is up to 24 months. The average age is 9.9. 74% were binocular forms. And you can see that the blue part is the full cataract. What are we talking about? Full binocular cataract. These children are fully blind. 38.9 are atypical. These children are also blind, and only 25.6 were cataracts with a big diameter of nuclei who have light sensitivity. Monoocular cataracts, we have only 25.8%, but look, 75 and 6% atypical cataracts prevail among those type of cataracts, and these are the most complicated cataracts for surgeries. So look at the general pathology of those inborn children. 83 So those children are not healthy. You can see that 55% is the pathology of central nervous system. Of course, there was secondary pathology of eyes, impairment of vision, but 18% was microphthalmos. Let's imagine eyes are small and children are small, plus microphthalmos. Examination methodology. We use general anesthesia. I won't enlist those methodologies. I want to show you those photos of atypical cataracts. And there are also factors that provoke uncertainty in calculations of IOL power in children. We have difficulties in measurement of axis length, then difficulties during investigation and fixation, and also it is very difficult to lay children in order to perform investigation. Different biometric and anatomic differences of pediatric eyes from adult eyes. So at this slide you can see that right eye is not only is with a cataract, but it is also small compared to left eye. What are the average chorometry data? The smallest children from 0 to 3 months, 47.11 dioptries, and then we can see a decreasement due to the functioning of cornea. Average data of US biometry. Here you can see average data, and they also decrease with the age. So we understand that child are born with big eyes, and then there is organ genesis during 2 first years of life. In order to make a graftment into the sac, it is necessary into the capsule. It is necessary to understand where we can put this lens, because we use standard lenses for adults, and we began to measure diagonal measurement of capsular sac in our children, and you can see that in age from 1 to 3 months its dimensions were 6.5 millimeters. It is not enough for implantation, but in the age from 4 to 6 months is 6.8. We can try. A lens can be put there, and beginning with 7 months up to 24, the measurements of eye are increasing, and we are able to put IOL into this capsule. Here you can see all the data of pediatric eyes, and that gives us this possibility. We change the power of IOL, taking into consideration pediatric age. We decrease the dioptries. In the age from 0 to 12, we decrease from 5 to 16, and in the age from 12 to 24, from 8 to 12. Technique or surgery technique, it is classical, but what about pitfalls of our surgery in pediatric age? First of all, It's the first operation, first uninterrupted capsulorhexis. We know that this proper performance of this procedure gives us chances to gain success in future. That's why we try to measure eyeball, and we plan the measurement and dimension of insection. And even in older children, the anterior capsulorhexis is difficult to perform due to the increased elasticity of the anterior chamber of lens. And if we are talking about newborn children, this data was increased up to 11.8%. But despite these pitfalls, there were no rupture of posterior chamber. We can conclude that we can perform this surgery. Now I want to show you a small video. We color all the time. It's a typical cataract. You can see small central nuclei, and you can see that it goes to the periphery more than we planned, but we were succeeded in performing this surgery. Then hydrodissection, and then aspiration, very mild aspiration, because masses are soft as well as nuclear, but we have to make grafting here. But look, posterior capsule is opaque, and we insist it on the IOL. We use viscoelastics. It's our tactic in order not to impact, not to injure vitreous body. We performed it with the scissors. Why? Because there were different anomalies of lens development, and it was impossible to perform it in a classic way. Difficult in anterior capsulorhexis in newborn, and the next procedures were connected also to the pupil rigidity and in other factors, as you see on those slides. We used iris retractors in order to dilate iris. Hyperplasia causes the removal of iris into a postoperative wound, despite the small tunnel sizes. It is necessary to highlight that the surgery of inborn cataracts differs in problems from adults. It is difficult to perform surgeries when eye is small, and it is necessary to remember that it is still developing. Peculiarities of pediatric organisms should be taken into consideration. A big penetration of all barrier system, immaturity of all systems, increased insufficiency of immune response. So it can cause early and late oxidative response of eye to surgery. And now I want to tell you about corticosteroid therapy, because we know that any surgery can't be performed without inflammation and without usage of corticosteroids, especially with the children of pediatric age. Here you can see local corticosteroids. There were studies loteprenol etoposide, and data were published about efficacy and safety. These studies were conducted during 2 decades in combination with another medications and alone. So we proved the conception of molecular design that is safe, and it gives anti-inflammation and efficacy. LE is the basis for local therapy of wide spectrum of the different states after surgery. Why we see this picture? Because its inflammation efficacy is very high, then its lipophility is 10 times higher than dexamethasone, and its adjacent and possibility to connect by receptors and decrease the risk of complication development. Lotomax helps to restore endothelial cells to their normal exogen form in 74 hours after use, and it has anti-inflammation effect. Here you can see its form. It's a gel, 5% gel, for treatment of postoperative inflammation and pain syndrome. It has also a special gel matrix to continue the exposition of main agent on the surface of eye. I want to tell you that it is this medication can be used beginning with the very born, because when we prescribed earlier steroids, they were prescribed after the age of 3 years, and these can be used beginning with the born of child. Then low-TAP, combination of loteprenol and dexamethasone, in order to increase the treatment effect. It's loteprenol decapanate and lotepredsin 3 milligrams. And treatment form is drops. There were studies of administration, this combination lotepredol etoposide and tobramycin low-TAP. Low-TAP is more effective because it doesn't increase the IOP. Low-TAP also has a high anti-inflammation and antimicrobial effect. It is very effective during first years of life because there is a great big contact with the hands. Then it increased the safety profile in diseases of first chamber, anterior part of eye. And we can use it from 0 months. This formulation is not acceptable for me. So my conclusions, you can see on the upper right slide, very beautiful girl with 10 months old with inborn atypical cataract and her visual acuity is light sensitivity. You can see that the toy is big, and this girl doesn't respond to this toy. And you can see the result after the surgery. This photo was made in 3 days after the surgery. Visual acuity is not big, 0.03, but look at her behavior. She looks at the toy. And another one example, despite the conclusions, very severe problem, a boy 7 months old, full inborn cataract, so he was fully blind. Visual acuity, light sensitivity, how can we establish it? On the reaction response of pupil to light. Microcephaly is the secondary diagnosis, organic impairment of central nervous system, and there is no reaction of following. You can see a nurse is holding a boy and there is no response. And look at the lower slide, even the expression of his face changed. He's smiling. The result we got in 2 months after surgery. We performed IOL plus 25 dioptries. Visual acuity is very small, 0.012, but this child sees an influence on the development of his brain. Look at his behavior. He is thin, he is pale, but he wants to touch this toy and want to hold it. Thank you very much for your attention.
I think we will have the question session after the reports. So the next report is about pathogenesis and diagnostics of the disease. The Department of Eye and Lens Pathology, Dr. Ulyanova. Good day once again. I'm really happy that our hall is almost full. Today I offered to work about the issue of exfoliative or pseudo-exfoliative syndrome and its place on the way to state the diagnosis. For the first time, this pathology was described in 1917 by John Lindbergh. His scientific paper was dedicated to exfoliative syndrome, and he described it as often presence of grayish spots. What has changed during the recent years in our vision of exfoliative syndrome? So indeed, his description is the same as what we might see in biomicroscopy. And what concerns terminology, exfoliative syndrome is a chronic progressive disease which is followed by formation of fibrillar extracellular material in the tissues of the anterior segment of the eye. It is most often associated with age over 50, but during the recent decades it has been manifesting in younger patients. The pathogenesis base includes extracellular matrix functioning, violations, and it has some association with genetic determinants and environmental status. So if a patient has genetic or hereditary risk of this complication, it is in combination causes this pathology. A very skillful research GIVAS found one nucleotide polymorphisms in the gene LOXL. The fact that we have to differ exfoliative and pseudo-exfoliative syndromes, we can observe it starting from the first stages of both conditions, where exfoliative syndrome is a disease associated with glass production when the change in the anterior capsule of the lens occurs and the anterior chamber of the lens starts disattaching. This is called exfoliation or scales, but if we speak about pseudo-exfoliative syndrome, it's a completely different thing, but according to how they look like, they both look like scales covering the anterior chamber and on the iris. The changes of extracellular matrix and basal membranes of the internal organs are similar in all organs and systems, and truly today the pseudo-exfoliative syndrome is not only an ophthalmological pathology, it's a systemic one. There has been lots of scientific researches dedicated to pseudo-exfoliative syndrome. Scientists have studied the lungs affected by this syndrome. There has been no direct association with eye syndrome and systemic syndrome. But we have noticed from the research that those people who drink coffee are more often having these types of conditions. Besides, the condition is depends on the geographical location of patients. Clinical manifestations with pseudo-exfoliative syndrome are shown in iris, endothelium of cornea, especially if you do biomicroscopy layer by layer, you will find large increases the scales on endothelium. You will also notice these changes intraocular, but most often the lens capsule and ciliary body have these scales forming. So retroluminescence shows the weakest parts of the iris. But if we speak about pseudo-exfoliative syndrome, it includes presence of pseudo-exfoliations in the anterior chamber of the eye, but lack of changes, lack of increased intraocular pressure. If we see a patient with glaucoma changes in optical nerve disc and increased intraocular pressure with scales, this tells us that the diagnosis is pseudo-exfoliative glaucoma, which is a secondary form, most widespread, making up about 1/4 of all cases in the whole world. As compared to XFG, it is associated more with the intraocular pressure. Correction of intraocular pressure in this condition is less effective in case of usage of different medical preparations. It is considered that in cases of pseudoexfoliative glaucoma, there arises the flow of internal liquid and changes in the systemic nature, lesions of the vessels. And the optical nerve is not supplied in a normal way. Patients with this condition have the need of surgical treatment, and pseudoexfoliative glaucoma is often combined with cataract, and as a rule meaning complicated forms of cataract, because these patients have high risk of subluxation, they have tears of the posterior capsules, they have keratopathies, they have small size anterior chamber and deficit of endothelial cells. And in complex, all these conditions, they increase the risk of complications after surgery. So such combination of pathological conditions causes possible complications intraoperatively. What should one take into account making surgery in patients with XFS? So we have to apply all the measures to dilute the pupil. We have to use capsule hooks in order to hold the sac. We have to avoid small capsular access because, first of all, it would complicate manipulations with the nuclear, and chemosis formation may increase. That's why large capsular access is a means of prevention of this problem. Besides, we have to perform hydrodissection delicately. Sometimes we have to implant the capsule ring or fixator. If we implant the ring, we recommend to fix it with a fixator. Fixing the intraocular lens. If we face something unplanned, then we make intravitreal surgeries. We are going to demonstrate videos with some of our clinical cases with mydriasis intraoperatively. Before the operation, we tried to dilute the pupil, but we could not reach the highest level of dilution. We tried to avoid damage of sphincter. We were trying to use the different techniques recommended, for example, by Americans, the techniques of rhombus, when one of the hooks is located under the basic section. But personally for me, it was not comfortable enough, so I performed the cut underneath the iris retractor and attached we widened the pupil, but manipulations with the nucleus showed us that the capsule sac was unstable. That is why we fixed the sac with 2 capsule hooks to make it more stable and to perform vacuemulsification more safely. Here you can see cortical masses are extracted and internal intracapsular ring is placed. As to intracapsular rings, I would like to say that this is not a means of 100% success, but it helps for the sac to be placed more stably. In capsule, sometimes capsule rings do not help, and in that case one has to use fixation. Here in this video you can see that the patient had been already operated. The intracapsular ring was placed, but the complex tore off, and in this case we approached differentially without complete cyclodialysis. That is why we fixed the complex lens ring in the sac, fix it to the sclera by suture technique. You can see that the sac here is not bad, and partially the sac is holding, but anyway we were there already, so we fixed it on 3 and 9 hours. That's an important issue. How to prevent such tears? How to make sure that the whole complex is not misplaced? We sewed with help of Sergienko-Kondratenko fixator, which has been demonstrated at conferences multiple times. Implantation of capsule ring makes it harder to extract cortical masses, but a little more time helps us to succeed. So this dissector is pulling the sac into the required position. In the second clinical video, we saw that the complex ring and IOL were in the pupil, whereas in this case you see that it fell on the fundus. In this new case, taking into account that we had to lift up the fibrosed ring, we decided to remove this capsule ring. It is implanted pretty easily, but not so easily removed. So this kind of phimosis is able to be formed in case of small capsulorhexis. This is how the tissue's properties are changed in pseudo-exfoliative syndrome. We proceeded with the next stage, remove the phimosis, because phimosis was so thick, so dense, that it was pushing out. And as Professor Bobrova Nadia Fedorevna said, severe cases require adequate treatment. Speaking about pseudo-exfoliative glaucoma, we have to divide the treatment tactics to conservative and surgical one. We have to keep in mind that effectiveness of preparations is lower in primary glaucoma. The preparations of choice are those which decrease intraocular pressure by means of improvement of chamber moist removal. Also, conservative treatment means monotherapy as a rule is not enough. Surgical treatment includes laser, trabecular plastics, anti-glaucoma, surgical of both penetrating and non-penetrating type. Once again, commonly conservative therapy by preparations is not so effective in primary angular glaucoma. So please take a look at these examples of preparations with unique properties on account of metabolical properties of the molecule, which consists of latent prostone acid that improves the scleral passage for removal, and on account of work of these molecules, the use of these preparations for start therapy provides significant decrease of intraocular pressure, and patients with high level of intraocular pressure had it decreased to 40% level. We know that confirmation of success in glaucoma treatment is the opportunity to reach the aimed pressure in patients who used other hypertensive preparations first, but then switched to the new preparation therapy. 25% cases with Visalta treatment were successful and more effective. Indeed, use of these drops increases the volume of blood in the capillaries at the optical nerve, and has, as everybody knows, and as everybody probably prescribes to their patients, both preparations for control of intraocular pressure and preparations which support, let's say, functional condition of visual analyzer on account of citicoline, like cognizin, that's an important donator of citicoline, which provides the necessary components for patients with neurodegenerative pathology. That is why combination of cognizin with ABCD, vitamins and zinc can be used in all types of glaucoma, like pseudo, exfoliative, and others. This preparation contains antioxidants as well. It is really easy to use. It has a pretty nice taste. We have used it ourselves. The period of treatment can last about 12 weeks. To conclude, I have to say that pseudo-exfoliative syndrome is an age-related genetic determined system pathology based on formation and accumulation in tissues of various systems of organs loss of extracellular matrix, which is a result of elastomicrofibriopathy. Thank you very much.
Thank you, Nadia Anatolievna. And the next report, candidate of medical scientist, Dr. Petrecka Oksana Stepanivna, retinal detachment with the open and close eye trauma. So you are welcome. Good day, dear colleagues. I want to present you my report, retinal detachment in open and close eye trauma. It's a detachment of non-sensory layers from epithelium. There is no one identification, and diagnosis is based on the past history. Traumatic detachment is 40% of all detachments. The frequency is from 0.5 to 2 to 100,000 of population. It can be both with the open and closed eye trauma. When the trauma is open, it is more widespread. When we are talking about open trauma, there is 30%. And also can be associated with the traumas of orbit and sclerotica chorioretinitis. And when we are talking about this disease, the data are lower than presented here in my report. But our work, scientific work that was published in the scientific journal shows that retinal detachments are more widespread, and these are 54%. So development mechanism at the closed trauma looks like rhematogenic detachment. We are talking about eyeball contusion. It's a rupture of eyeball, and then the detachment of retina. We have different complications after the rupture, vitreoretinal traction, and different injuries of vitreous body. There is a liquid in subretinal cavity and retina detachment. As a result, what are the types of detachment? When we see traumatic retinal detachment, these are flap ruptures, giant ruptures, and small ruptures. When we are talking about trauma ruptures, there can be multifocal and single focal ruptures. Detachments is developed during first 24 hours after trauma in the 24% of patients, and up to 2 weeks after trauma in 62% of patients. When we are talking about open trauma of eye, the mechanism of development differs. Traction, rhematogenic traction prevails, and there are different traumas that can cause open trauma and provoke the retina detachment in 62%. When there is a penetrating wound with a sharp foreign body, 36%. And then when we are talking about foreign body, there is 16% and 36% in anterior and posterior parts of the eye, and then 2% of penetrating wounds. The video, please. Clinical case of penetrating wound of intraocular foreign body. You can see that foreign body is behind the eyeball, and here we can see retina rupture. And if vitreoretinal surgery performed timely, we can prevent retina detachment. So it's the most prominent case how to prevent retina detachment when to perform surgery in timely manner. Depending on the affected zone, 49% of detachment are due to the wounds of third zone, 31% when the second zone is injured. We are talking about the impairment of vitreous body because we have hemophthalmos and another complication, tractions, ruptures, and there is retina detachment. And unfortunately, when we have the injury of the first zone in 12%, we have the detachment of retina. Of course, when we have hemophthalmos in such a patients, practically 50% have retina detachment. The term of development are the next. 27-30% in the first 24 hours after the penetrating wound of eyeball, and during the first weeks in a half of cases, and around 72% it can develop during the first month after injury. And there are also long-term retina detachment when there were injuries of retina, vitreoretinal injuries, so it can be even in several years. There is a late rupture of retina, and it causes the retina detachment. Detachment can be local, subtotal, with the covering of macula and without covering of macula, and also total detachment. Symptoms and diagnostics. Of course, what we have, it's acute decrease in visual acuity, then there is opaque vision, and different impairments of visual acuity, loss of peripheral field of vision, and then central field of vision loss. We can dilate iris and see the retinal detachment. So when the trauma is closed, we recommend you to dilate a pupil and to investigate on the subject of rupture and pre-rupture of retina. Because we can prevent detachment with the help of laser. It can, if we don't perform surgery in timely manner, we will lose the sight of our patient. And the most used, widely used method is surgery with 22 Hertz. We can use UV diagnostics and we can see local primary detachment just after the trauma. In 9% of patients, we can't establish their diagnosis before surgery. So these are 9% of cases of intraoperative detachment. What are treatment? It depends on the location of ruptures, then presence of foreign bodies, IOP. We are talking about pneumatic retinopexy, injection of gas. When we have ruptures of upper sides of upper parts of retina and ruptures of upper parts of eyeball, and after the attachment of retina, we perform laser coagulation through the gas bulb. Now we use this procedure rarely because now we are involved in battlefield traumas, and we don't use such a technique, but this technique is very useful. Local and extracircular surgery we use when we have vitreoretinopathy, when we have a macular rupture. In our institution, this surgery is widely used, despite the fact that not all the surgeons in Ukraine and all over the world like this procedure, but we have a high experience in this field. That's why we use this technique very often. It is very active, effective for patients who has such a data that I have mentioned. And when we are talking about traumatic detachment of different etiologies with big hemorrhages, proliferation, foreign bodies, and big ruptures, we use macro-invasive 3D vitrectomy in combination with a phaco-IOL. We use nearly 76% of vitrectomy and combination of vitrectomy and focal sclera surgery. Clinical case you can see here. Local detachment of retina, and then you can see the trauma of lens. Also you can see local detachment on periphery and on the very edge of periphery. You can see the rupture of retina. Of course, we use laser coagulation here and gas tamponade in such cases. Laser coagulation, you can see. We have few such cases of local retina detachment. And because it's an urgent case, it's not a macular zone, so that's why a patient refers us because of increased IOP, and his vision was high. Next clinical case, flap rupture of retina, peripheral as well, but not on the edge periphery, drainage of subretinal liquid, laser coagulation of retina. And practically the same example as previous one, but with a big flap rupture. Here you can see unfolded of retina and gas tamponade. The next clinical case, wound of sclera. It's a minor explosive trauma of eye, severe trauma. We examined sclera. It was unsued trauma of sclera. It's a penetrating trauma. And we have the mixture of parts of eye. So we have to perform Luzon retinotomy to unfold retina and to use silicone tamponade, and combination of retinotherapy with a plastic surgery after the removal of all vitreoretinal attractions. The next clinical case, also the combination. It's the repeated retina detachment. Vitrectomy was performed earlier, but you see extrudes beneath the retina, so there was revitrectomy performed before this main surgery. We unfold the retina and perform silicone tamponade. In such severe cases, after such traumas, we prescribed medical therapy, antibacterial therapy, steroid medications, non-steroid gels, and antibiotics, of course, retinoprotective therapy. Floxal is very effective medication. Ofloxacin is a main agent. It's antibiotics of big sphere of action. Study was performed in Germany, and there was statistically significant decrease of microflora, especially to ofloxacin, from 11% to 7% in 2021. The main provokers of infections are sensitive to the main agent of this medication. It is produced in two forms, as drops and ointment. Floxal is very easy to use. There is no irritation in patients. One drop 4 times a day. Ointment has good adhesive effect. Maximum concentration of active agent is in 5 minutes after administration. Prescribed as a strip 3 times a day. And bromfenac, non-steroid anti-inflammation medication. And there was a study on the effectiveness of this preparation. The main sign, the main effect is inhibiting concentration, and it decreases the mediators of inflammation by 50%. So it increases the power of inhibition and the effectiveness of this medication. And also the cooperation of SOP1 and SOP2 is significant. It influences on the inflammatory action of this medication. You can see the effectiveness of bromfenac molecule in this medication, and it has the highest data in these highest points in this study. Sorry. It's the most effective anti-inflammatory medication among another non-steroid medications. Bromfenac helps us to absorb necessary concentration in all tissues of eye. And another one, medication, bromfenac molecule. Its name is Yelox. It's a very powerful anti-inflammatory medication. It is the medication of Bausch plus Lomb 5 milliliter flask. And coronary gel we use after our operations. Eye gel with a concentration of dexpanthenol, and it helps us to heal the wound, to reduce the time of reepithelialization, and gel basis helps us to heal the wounded surface of eye. Detachment is a serious complication after the trauma, and it influences not only on visual results but on anatomic results of treatment. In order to restore vision after detachment, it is necessary to establish timely diagnosis and to choose the proper type of surgery. Vitrectomy is the main method of surgical treatment.
Дякую, Оксані. Thank you, Oksana Stepanivna, and every lecturer who participated in the satellite symposium. I would like to thank the representatives of the company Bausch & Lomb, who I would like to see who is going to receive our certificate. The Institute of Eye Diseases, named after Filatov, expresses our gratitude to the representative of Bausch & Lomb company for your support in general and for the help in this conference. So we are moving further. The next section is trauma. Thank you.
І готово. Кліп, 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 і готово. Кліп.
Так, шановні колеги, всіх вітаю.
Dear colleagues, I'm greeting everyone. The satellite was indeed interesting, and I hope our section is nonetheless exciting. This is the development of the section because last year we had it already, diagnostics and treatment in ophthalmology, and today we are starting it. I'm glad to greet Professor Zborovska and Professor Drozhina, and the first report by Professor Galina Ivanivna Drozhina is about diagnostics of infectious keratitis. I named my lecture Mistakes in Diagnostics and Treatment because they are associated with each other, diagnostics and treatment. If we consider the factors that impact diagnostics and treatment of infectious keratitis, I have split them into two groups depending on patient and depending on physician. So what depends on the patient is late referral, self-treatment, financial difficulties, inability to afford preparations, difficult social conditions without being able to keep elementary hygiene rules, or if a patient disappears for some period, probably because of some improvement, and later decrease of successfulness and catastrophic situations when this patient might come back. What depends on the physician, it's the negative factors are little experience, inadequacy of first therapy, lack of ability to provide microbiological studies and tests, underestimation of infectious problems in those who wear contact lenses, and as well, I have not mentioned it on the slide, but I could say that self-confidence of some doctors who consider that they are almighty, but they don't try any other methods, but only those to which they're used. What are the basic requirements to ophthalmologists for diagnostics and treatment of infectious keratitis? This is the ability to collect anamnesis thoroughly, the ability to analyze the obtained data, to be aware of sensitivity of the main causes and the spectrum of action of modern antimicrobic preparations, ability to choose the term of therapy. What is required for that? One has to have a look at a number of patients, read a number of books and articles in order to understand not only which medications are helpful, but also which consequences may arise. As to laboratory diagnostics of infectious keratitis, the golden standard of diagnostics is the proof of presence of the cause of inflammation in the scrape. Different types of examinations are examining the chamber moist, the aspirate of the vitreous, biopsy of corneal tissues in some cases, scraping of conjunctiva. Additional methods of tests include PCR, which is a nice method, but pretty often our patients have co-infection. As you might see on the slide, from 25 to 52% cases, these might be fungal or viral infectious. So an experienced laboratory worker, tester, has to perform the analysis of the sample. It is necessary to scrape the edges of eyelids together with the corneal surface. The central part of the lesion as well as the edges of it have to be analyzed. And if our patient wears contact lenses, we ask him not to throw away the lenses, but test it in the lab. We also take test from the container for the lenses if possible. As far as concerned the confocal microscopy, especially on the early stages, we can say that it is a non-invasive or atraumatic method which allows to test the layers of cornea and epithelium from epithelium to endothelium. Its sensitivity reaches 94% for fungal and acanthamoebe keratitis, but on condition that it is tested by an experienced laboratory worker. This technique is low informative in diagnostics of bacterial keratitis, though. Speaking about treatment, we have to keep in mind that local antibacterial therapy in bacterial keratitis without manifestations of keratitis is of an important role. The therapy is quite a hard process, but we prescribe second-generation antibiotics. The patient receives pills, and it happens so that after improvement, a patient might leave the clinics and leave the doctor after some improvement, and then recurrency can take place. So primary topical therapy has to be highly dosed with preparations of third or fourth generation of fluoroquinolones or aminoglycosides. We also use foreign antibiotics without conservations. Their frequency of use depends on the course of the disease. Correction therapy is necessary. If the inflammatory process is severe, daily examination of patients is necessary. Our foreign colleagues give advice that in small, unintense and not deep infiltrations of cornea without signs of inflammation from the anterior chamber, it is possible to use local monotherapy by one antibacterial preparation, but not less than 8 times a day. What do we use? We use antiseptics, which enforced installation regime. First 30 minutes, the drops are used every hour, according to the scheme shown on the slide. If one prescribes antibiotics to which the flora is sensitive, then after 2 or 3 days you will see the result. In addition, we listed Medriatics, inhibitors of collagenase. If we have an inflammatory infiltration of deeper layers of the anterior chamber, spread to sclera, for example, then antibiotics usage is necessary. Fluoroquinolone of second or fourth generation, glycoproteins, intramuscular anti-inflammatory preparations, and so on. What do we supervise and monitor? We monitor the clinical picture, the decrease of size of stromal infiltration, the decrease of density of stromal infiltration, re-epithelialization of the focus, and we try to stop thinning of cornea. Even in such severe cases like these shown on the slide, if forced therapy was prescribed correctly, it is possible to treat such patient without surgery. So the lower photo shows topical therapy only drops because the patient was 31 weeks pregnant, and we could not offer anything else. And speaking about the most awful clinical pictures and pathologies which we face in our practice most often, this is hepatic keratitis. This is the zone. The total number of cases of hepatic keratitis has increased to 1.8 million patients per year. This keratitis has a number of trigger factors, the list of which you may see on the slide, and it is different from other types of keratitis because it has several clinical forms with which everyone has to be familiarized thoroughly. The most understandable classification, the most proper classification, was offered by Holland and Liesgang in 1999, and it is used by almost all our foreign colleagues. Includes infectious epithelial keratitis, stromal immune mediated keratitis, neurotrophic keratopathy, and vascularized opaqueness of cornea, as well as keratouveitis. What do we have to understand in treatment? In superficial forms, the epithelium of cornea takes place on condition of therapy. We use ointments or gels, Hansa Clavira gel, All the rest, all the other preparations are just additional means. In topical forms, in superficial forms, one has to treat them really quickly to avoid recurrences and to avoid complications. In cases of deep stromal forms, effective treatment is possible with combination of antihepatic system therapy and steroid therapy. So the two clinical forms which I would like to highlight are stromal immune-mediated keratitis and necrotizing keratitis. This is caused by sensitivity to antigen. Its course is fast, and the progressing almost does not differ from bacterial keratitis. The inflammatory component prevails over infectious one. So we are trying to monitor the inflammatory process in the cornea, and despite usage of systemic preparations and antivirus preparations, most often it happens so that treatment and transplantation procedures include transplantation of the membrane and keratoplastics, because we want to avoid perforation of cornea. Here on this slide there is some information about metahepatic keratitis, which is a late form of hepatic keratitis, which can also be described as a chronicle one. As a rule, we cannot diagnose a patient with metahepatic keratitis if such patient had not suffered other types of hepatic keratitis. So it implies that the structure of stroma has to be damaged, and only on this condition there can the metahepatic keratitis occur. That is why it is so important to collect the anamnesis. Hepatic ulcer of cornea can develop without any association with superficial keratitis. When at once for treatment corticosteroids are given, sometimes combined with antibiotics. Sometimes we can treat it with non-steroid anti-inflammatory preparations and inductors of interferons, as well as long-term usage of antibiotics. In recurrent hepatic keratitis, when systemic antivirus preparations are absent or inadequate dosages are prescribed. How to diagnose hepatic keratitis? It is mostly based on clinical anamnesis criteria. These criteria are important to diagnose, and we have to pay attention to the fact that hepatic infection is one of those most common. So if you meet a patient with the keratitis, your first thought should be if it is hepatic or not. The triggers, which I mentioned already in the previous slides, have to be kept in mind. But in case if we make a mistake and prescribe false kind of therapy, and we see the recurrent conditions in our patient, we have to keep in mind that hepatic keratitis is the infection which can cause recurrency. Which mistakes could be made in treatment? Installations of corticosteroids from the first day of the disease, local usage of non-steroid anti-inflammatory means, differential diagnostics of stromal hepatic keratitis. It takes place with the syphilitic keratitis, tuberculosis keratitis, granulomatous iridocyclitis, herpes zoster keratitis with a rash on skin, keratitis as a result of virus parotitis, inflammatory syndromes with the increase of intraocular pressure, probably having viral nature. These are iridocyclitis of Fox. In stromal keratitis, the most typical mistakes are lack or insufficiently intensive short-term use of anti-hepatic preparations systematically, use of corticosteroids, non-systematic anti-hepatic preparations, and lack of attention to the condition of intraocular pressure, because 25 or 30% patients may have increased intraocular pressure, which has to be treated parallelly. When should corticosteroids be prescribed? As a rule, after 2 or 3 days of start of active systemic anti-hepatic therapy, because early prescription of steroids in absence of systemic antiviral therapy can lead to more significant damage of the cornea by the virus. And if one postpones the use of steroids for too long, it can cause loss of endothelial cells. If we prepare a patient with hepatic keratitis in anamnesis or recurrent keratitis, we have to carry out prophylactics, which could include acyclovir in different dosages mentioned on the slide, anti-hepatic preparations systematically should be taken along with corticosteroids locally. This concerns cataract surgery and other types of surgery. Which conclusion can be made about treatment of hepatic keratitis? I can say that diagnostics of hepatic keratitis requires thorough studying of anamnesis and the knowledge, familiarization with the peculiarities of clinical picture of different forms of the condition. We have to carry out the treatment in accordance with the form of hepatic keratitis. We have to keep in mind the necessity to prevent recurrency. We've had already a lecture about fungal keratitis, which as a rule can be developed as a result of trauma by plants or animals, or misuse of contact lenses or some preparations, low immunity. The cornea as a rule contains infiltration of yellow or gray color. It may be epithelialized or not. The course is slow as a rule. Hypopyon is thick if it's present, usually of a pyramidal shape. And as I said, the mold damages the eye more dramatically. Speaking about treatment of fungal keratitis, here is a list of anti-fungal preparations. Only those preparations which have their molecular mass less than 500 could be more effective, and they may be used for epithelialized cornea, whereas other preparations with molecular weight over 500, they do not penetrate the epithelium, and one has to perform scarification of cornea. Speaking about acanthamoeb keratitis, in severe cases, it threatens with development of blindness. In Europe, there is from 1 to 9 cases of 100,000 cases. The risk factors are swimming in contact lenses, not following hygiene rules, staying under the rain. What should I say about this type of keratitis? It has a long-term development. This is not an instant infection. That is why it can have the course with different acute stages. But the first stage concerns only epithelium, which might be like dirty and cause the phenomenon of discomfort. The second stage is damage of the superficial layers of stroma. So in order for the infection to get inside the stroma, 3 weeks is required. So it takes 3 weeks for this penetration to the superficial layers of stroma. So that is why timely referral to confocal microscopy is of crucial importance. We cannot receive the information from which we could receive from confocal microscopy from any other source. The third stage is ring-shaped infiltration in stroma. It takes 6 weeks for it to develop. Fourth stage, it's the ulcer on cornea, condition of after 10 weeks. Differential diagnostics of hepatic keratitis as differed from acanthamoeb keratitis. It has multifocal nature of epitheliopathy, acute pain, which is non-characteristic for the clinical picture that you might see, and presence of risk factors, contact lens wearing, contaminated water use, even in case of washing face in the country house. Why am I focusing your attention on acanthamoeb keratitis? Because it is often not differentiated from pseudomonada 1. Both keratitis are occurring most often in patients with contact lenses. Both conditions may ruin the epithelium layer. So, but we have to differ them somehow, right? But the second condition is characterized, like the pseudomonade keratitis is characterized by urgent start and very speedy course, hypopyon may be formed on the 3rd or 5th day after the onset of the disease. This slide shows our patients on the left, acanthamope keratitis and pseudomonade keratitis on the right. So the lower pictures show 2 months immune ring, and abscess with hypopyon is seen on the last photo. The photos show 3rd, 4th, and 5th day. Treatment is different in acanthamope keratitis and pseudomonas keratitis. If we have opportunity, we use Brolan and voriconazole, additional therapy, analgetics, or nidazole. Pseudomonas keratitis should be treated by aminoglycosides of the 2nd or 3rd generation, fluoroquinolones in forced regime of instillations with additional systemic therapy. One has to remember that the goal of treatment is to destroy the bacteria or viruses or fungi. So everything has to be well thought in order to remove the threatening factors from the cornea. We have to avoid wrong decisions in treatment, which would increase pathogenicity. And the following question is, how long should we treat conservatively? In absence of positive dynamics, and in case of the corneal condition worsens, we have to take surgical measures. We have to use intrastromal injections. Usually it happens in fungal keratitis, surely avoiding perforation. And in case of speedy progressing course, we have to apply surgical treatment. Which are the indications for surgical treatment? It's superficial keratitis, which does not tend to decreasing the area of the ulcer of cornea, non-controlled progressing of purulent infiltration despite intensive medical therapy, deep stromal keratitis with progressive decrease of visual acuity, resistant to treatment for 2 or 4 weeks, destruction of stroma. Which types of keratoplasty are performed? Very different types, from the penetrative one to flap transplantation. If penetrative keratoplasty allows to remove the infection from the cornea completely and to wash the anterior chamber, in some cases we may perform layer by layer keratoplasty. Sometimes after sanation of the anterior chamber. But we don't have to address it either too early or too late when the disease spreads to the posterior chamber. I would like to focus on the use of biological coverage, which unfortunately is most oftenly used for perforations over 1.5 millimeters. Biological coverage does not hermetize in such large perforation, and the flow of the chamber moist continues, and secondary glaucoma may occur. So the basic indication is infiltration of flap wounds, burns, inflammatory diseases without obvious perforation exceeding 1.5 millimeters. What do we locally use in post-surgical period? We use antiseptics, antibiotics, artificial tears without conservatives. We use systemic medication treatment. So my program is for 30 minutes, but I'm finishing already. So the prognosis of treatment of acanthamoeb keratitis and pseudomonade keratitis depends on timely diagnosis and the terms when adequate antimicrobial therapy begins. Forced and long-term installations of antibiotics and anti-amoeb preparations which toxically impact the epithelium should have positive impact on the all over on the total process of treatment. So, general conclusion, I would like to say that treatment of patients with infectious keratitis has to take place taking account the etiology, the stage of the inflammatory process, and the severity of the disease. Surgical treatment has to be timely, high level of surgical specialty has to be present. Thank you for your attention.
Thank you very much. I hope that we will have questions at the end of our section. So our next report of Professor Zborovska, Alexandra Volodymyrovna, vascular impairments of retina, such similar and such different. So please, you're welcome. Good idea. Mike, please. Good day, dear colleagues. Today we will talk about vascular impairments of optic nerves and of retina. They are really very similar and very different. So let's talk with the simplest one, with ischemic neuropathies. Any human being can be affected, can suffer even if there is a discopathy. Hematologic diseases, amount of hematologic diseases increase right now. And now in scientific literature there is a term arterioid and non-arterioid ischemic neuropathy. Arterioid connected is associated with the temple arterioid. I want to pay your attention that there is an image of ocular nerve, optic nerve, and visual acuity is very high, but the image of impairment is like this, and also fields of vision are preserved. And optic disc has the same image when a human being has a brain tumor and diabetic neuropathy, especially with the diabetes mellitus of the second type, especially when a person doesn't know that he suffers diabetes. And you know that very often diabetes is the first person who establishes diagnosis of diabetes of the second degree, and very often the first sign is diabetic neuropathy, so please remember about it. Thrombosis of central vein of retina and its branches, we are well known. The reasons, it's a classic image, well known. I want to pay your attention. There is thrombosis of central vein of retina. It can be associated with the drusis of optic nerve. So if you have a possibility to investigate optic nerve after the treatment of hemorrhages in order to prevent rethrombosis and recurrent rethrombosis, please pay your attention to optic nerve or to bare eye, because very often drusis are the problem of both eyes. I want also to tell you about antiphospholipid syndrome. It's quite young pathology. Our predecessors have the possibility to investigate ocular fundus not so long ago. Compared to the surgeons, we had this possibility in the mid of 20th century. AFC is autoimmune thrombotic vasculopathy, and very often it is substituted and confused with a classical thrombosis. Different vessels of different sizes are impaired. Big vessels, small arteries. These thrombosis are non-one-time, they are repeated. Thromboembolia of small vessels, of pulmonary vessels. Repeated strokes and repeated heart attacks, so please be very attentive when you gather past history, neurological pathologies, and AFC can be manifested by, can have skin manifestation. It was described firstly in 1986, and now we try to collect the knowledge about this pathology, and scientists don't understand whether it is a primary manifestation of systematic lupus erythematosus or it's a separate disease. So you can see the picture, and it looks like the thrombosis of central vein of retina. The secondary can be primary and secondary. When people have been established systemic lupus erythematosus, then Sjogren disease, rheumatoid arthritis. It can be a secondary impairment when a person suffers malignant neoplasms, infectious mononucleosis, HIV. Here you can see the image of patient with AFC. It was our first patient. We established this diagnosis. This patient got treatment not against AFC, but against ischemic neuropathy. We enrolled him with such white spot on optic disc. So I want to highlight that there is no diagnosis chronic thrombosis, because thrombosis is an acute condition. There is no chronic thrombosis in any cases, in any dispositions. So there is no such a diagnosis, but it was established and it was noted in such. At that time, there was information in literature that the sign of posterior neuropathy is a negative rejection on dexamethasone injection. So if you inject dexamethasone and his condition worsens, he has neuropathy. And the thing was that he had this severe reaction on dexamethasone. He was administered pelabulbary. We stopped treatment, and he didn't get any treatment. At the beginning, he had increase in visual acuity, and then it was recurrency. Then he made tests, and we got such test results. They are positive for AFC, and he got treatment against AFC with a rheumatologist. Now, only rheumatologists are involved in treatment of AFC. Here you can see the scraping analysis for systemic lupus syndrome and in other systemic syndromes. That is why they are usually connected. Another one interesting pathology is thrombophilia. We have such a patients, and their number is growing with the impairment of retina associated with the thrombophilia. It's a heritage disease. In previous years, this disease was a problem of pregnant women, of pregnancy, but now the influence of thrombophilia is studied very precisely. It's recurrent venous thromboembolia, then venous thrombosis up to 40 years, venous thromboembolia in relatives, and thrombosis in non-usual locations, cerebral thrombosis, kidney thrombosis, and liver thrombosis. You can see that it can be provoked by the lack of proteins C and S. Our task is to refer the patients to a rheumatologist, and rheumatologists should decide the type of this thrombosis disease. Also, it's our patient with thrombophilia. First diagnosis was chronic thrombosis at his local polyclinics. When he was referred to our polyclinics, and here you can see hemorrhagic retinopathy with ischemia. We are forming now tactics of treatment because we have only few such patients, but there is some tendencies that unite those patients. What about vascular impairments caused by uveitis? It's not an inflammation by choroid. It's the term of perivasculitis. These are periphalbitis, and we can see them when people suffer multiple sclerosis, sarcoidosis, Behçet disease, sparse planitis, and shotgun. Perivasculitis, it's a proper name, but retina is also involved in this process. It also causes the edema of retina and decrease visual acuity and vision in general. And the severest impairment is impairment of iris. Arthritis are characterized for systemic vasculitis and acute necrosis of retina as Irvan syndrome and multiple sclerosis with impairment of cerebral veins. So we change our point of view as to the pathomorphosis. There is a very rare pathology, Irvan syndrome. Predominantly young women suffer it. It's a type of arthritis. So you have to investigate fundus of those patients. And practically in all cases, the location is periphery and then center. I want to pay your attention that we have patients with malignant tumors, with lymphomas, leukemia, with viral infections, and they have acute retinal arrhythmia, and you can see the picture. You can confuse it with TB because TB retinal vasculitis looks like lymphoblast leukemia. You can also confuse TB with ILSA disease. There are publications that have an information that ILSA disease is the manifestation of allergic response and TB. So there is no new diseases. We have new manifestations of all diseases. And all at the beginning of 20th century, TB was the most severe infections and it provoked a lot of manifestations and complications. Here in this table, you can see the vessels that are impaired. So, colleagues, please pay attention on past history and on systemic diseases. I understand that it is very difficult. I understand that you have to gain new knowledges, but you may be the first people, for the first responders who will save the life of people. You may establish the diagnosis not only of diabetes by leukemia, HIV. Of course, you have no right to establish, but you may refer this person to the proper specialist who will be involved in it. And of course, please pay attention on iris dilation because a lot of vascular impairments begins on periphery, and of course we have a question of treatment. Of course, treatment differs depending on the etiology, but our main task is to support and to preserve our vision. All these processes causes neurodegeneration and ischemia. They all causes thrombosis of the central vein of retina. It's a type of stroke. If you have ischemic impairment, we are talking about stroke because it is understandable for our patients. That's why we have to preserve the vision and preserve the functioning of retina and on vessels. Of course, those patients are chronic. These are chronic patients who have to administer treatment on a constant basis. And in our country, we have such a situation that ophthalmologists are involved in the process of treatment, because in other countries, if a patient has a ischemic disease, he goes to the cardiologist, but our patients come to us, to ophthalmologists. So we have to support people in general, and we have to use complex medications. I am involved in treatment of chronic patients, and they don't want to take a big part, a big amount of medicines, and we have also evidence-based medicine. So the combination of erythritol with IRIS formula have anti-inflammation and anti-ischemic effect, and plus omega-3. And if you have listened to my lecture on pigmentous retinitis, now it is treated with omega-3. It was really a crucial opening for me. So pigment retinitis is also treated in our department, so that is why I want to highlight one more time resveratrol, then vascular action, vascular effect, anti-inflammation effect together with IRIS-2 and omega-3. It was an opening for me. It's retin, daxantine. And what about problems in treatment? Janus effect. You can see the statue of Janus. Why we can see this image? The main problems, main mistakes. All these medications that we use in the treatment of vascular impairments, corticosteroids, they have Janus effect. If we use them timely and they are prescribed to patients in a proper manner, we use them in a proper combination and urinated at first, then corticosteroid, and then for expansion of vessels. I'm talking now about the consequences of usage. If you use them prescribed in timely manner, you will have a positive effect. If it is done not in timely manner, these medications can have a bad impact on the condition of our patients, and unfortunately we all of us have this negative experience, and that's why we form our own tactics of treatments. For example, corticosteroids at AFC. If we don't remember about this AFC, we will make a harm to a person. And then we should use neuroprotectors, antioxidants, and medication prescribed by rheumatologists and cardiologists. We have to refer patients also to hematologists and rheumatologists, and to control people if they take prescribed medications because if there is no control of thrombosis of this blood component, you won't be able to reach an effect. The same situation with neuroprotectors, anti-ischemic and other medications. And the main problem is the absence of treatment in general. We have also such a situation. I have such a rule in order to save both my time and my patient's time, as well as my colleague. Previously, I ask patients to make tests because due to my clinical experience, I know what they should make because I can know in advance the pathology. Unfortunately, there are some tests in Ukraine that are not performed. Some people can do it abroad. Thank you for your attention. We will have another one report.
We're going to have another report now, and then we'll listen to questions and answers. The next report is by Korol AR, and the name of it is Mistakes in Panretinal Laser Coagulation for Diabetic Retinopathy. Why does it fail? Dear colleagues, greetings to you. So before discuss where the mistake is when performing laser coagulation for patients of diabetic retinopathy, a couple of words about the mechanism of its action. When we coagulate the retina, we decrease the area of retina which requires blood supply and decrease the ischemia of this part of retina. We improve the diffusion of oxygen through coagulates, and we decrease the ischemized retina area, decreasing the neovascularization. At present, even with development of antifreeze therapy, laser coagulation in diabetic retinopathy is the gold standard for treatment. Nobody has cancelled it, and I'm sure nobody will. What are the indications for laser treatment? We know that pre-proliferative stage and proliferative stage of first, second stage, anterior panretinal treatment, laser treatment, rubeosis of iris or in the angle of the anterior chamber, which are signs of big scale damages of the retina. In third, fourth stage of severity of proliferative retinopathy and recurring hemophthalm, laser treatment is indicated. This is our scheme of laser coagulation, step by step. Definitely you may have your own methodology, but it's the main point. You have to have your own methodology. Each patient has to be treated according to yours. As we know from the scientific literature papers, the laser coagulation depends on the stage of diabetic retinopathy and the type of the diabetes. For example, in pre-proliferative stage, beginning laser coagulation, it is the most effective. with both insulin-dependent and insulin-independent case. If we start our treatment in proliferative stage, the effectiveness of treatment decreases to 42%, and such patients undergo vitrectomy. Another reason of failure of laser coagulation is that insufficient area for coagulation is chosen. We always choose a proper diameter for coagulant. The mistakes in calculation of coagulants, in choice of contact lenses. I'm sure that you know that every lens has its own optical parameters to increase or decrease the parameters of coagulant, which can impact the area of the performed laser coagulation. Thus, we know that classical panretinal laser coagulation requires to be performed at about 264 square millimeters in light stage. And if you are able to perform laser treatment on more modern and advanced technique like Novelas, then such laser coagulation requires twice more coagulates, 2,200 as minimum, and up to 7,000 in severe stage. These data were obtained during Manchester Pascal study. Also, one of the failures, sometimes failures may be caused by improper beginning of coagulation. If it doesn't start in pre-proliferative stage, but in the proliferative stage. Improper choice of tactics, improper assessment of severity. If physician has not found neovascularization, for example, or rubeosis of iris, then his patient might have secondary glaucoma and impairment of visual functions. So generally accepted shots, the interval between them has to be about a month. Taking into account fast and speedy development of anti-freeze therapy, it is used in modern ophthalmology. We have to know that, first of all, any anti-freeze preparation of any generation produced by any manufacturer, these means remove proliferation. They move the proliferation component of retinopathy. As to the effect of preparation proliptonate, if you remember, we used to have it in Ukraine in 2009, 2010. A study showed that in regular use, this preparation causes closure in 62% eyes, whereas 37% eyes do not achieve closure. 37% have recurrent neovascularization. So you have to understand that anti-frizz preparations do not secure 100% effect. Another exciting study was about the outcomes of eyes lost to follow up with proliferative diabetic retinopathy that received panretinal photocoagulation versus intravitreal antivascular endothelial growth factor. You can see the table on the slide, which shows neovascularization of iris and tractional detachment. The number of cases in the group of anti-frizz preparations, there weren't any specific preparations, but there were just those available at the time. So you can see the number of successful stages. What do we see from the result? As to visual acuity of patients, it was the lower graph shows the visual acuity. So if a patient after laser coagulation just disappeared from the clinics and failed to come back, this means that 5 injections were enough for him to support and increase his visual acuity level. Another study, Protocol S, studied the impact of ranibizumab on patients with the loss of follow-up. So the group of patients who disappeared from follow-up, 40% of them had neovascularization with the optical nerve disc and tractional detachment, 33%, which was significantly higher than that in the group of ranibizumab with the loss of follow-up than in the group of patients with laser coagulation. Meaning that it is proper to combine laser coagulation with anti-frizz preparations when recurring hemophthalm, for example, partial hemophthalm with fresh, newly formed hemophthalm, in case if it is impossible to perform laser coagulation. During laser coagulation, in presence of diffuse or complicated diabetical macular edema, the use of these preparations is also advisable. In combination with laser coagulation, after complete performance of it, we observe fully newly vascularized vessels which grew, and we decided to administer inhibitor of the preparations. So as a result, I would like to say that laser coagulation of retina is pathogenic, standard, and first choice means to fight neovascularization in proliferative diabetic retinopathy. To achieve the effect from the laser coagulation, a certain number of laser coagulants has to be used at a certain stage of diabetic retinopathy. Thank you kindly for your attention. Dear colleagues, I have a couple of minutes We have 15 minutes for questions, if you have any. Will you perform laser coagulation in case of ischemia with the significant zones of ischemia without soft exudates? Is it an indication for laser coagulation? No, this is not an indication for laser coagulation. More severe proliferative form is, but there are different classifications. We use the one where pre-proliferative one, but at the same time it is called highly severe retinopathy. As what concerns OCT, OCT is an exciting method of examination. Tomorrow we are going to have a seminar and I will perform OCT. What you are saying is a high disadvantage because if you follow up the same patient on different devices, you are going to obtain completely different data on blood circulation in the retina. That is why for now there is no standardization of such indexes and such devices because each device has a different algorithm of calculation and the results are completely different. So we are grounding on clinical classification. Thank you. There are pretty many data that, namely, absence of perfusion is more prognostically correct that perforation is going to take place more than FAC. Yes, I agree with you, but for present, perfusion may be assessed by different methods like fluorescent angiography, method of OCT angiography, but it is highly significant to assess the area of the lesion along with the stage of the lesion. If you have, for example, in thrombosis of the central vein, there is the area which exceeds 10 times the norm, exceeds the norm 10 times, then it bears higher risk. So we are going to examine the fundus in full and the eye in full. Another question to Alexandra Vladimirovna, maybe? Or can I ask a question from Galina Ivanivna? Galina Ivanivna, please, don't stand up. Tell me, please, do you deal with mycobacteria? What do you do if you suspect mycobacteria? Do you deem it necessary to perform scraping in patients' primary referral? And when do you add insulin in order to initiate epithelialization when it is required in order to add corticosteroids? In which conditions? As to mycobacteria, we have not had these cases, but in some cases we cooperate with specialized laboratories, but never have we faced this mycobacteria. What was the second question? Yes, insulin. As a rule, we begin the scraping every time in order to obtain the qualitative and quantitative analysis of flora. If required, we conduct antiseptic and antibacterial therapy. If we see that there is no healing, the indicators of the infection are destroyed, then are not destroyed, then we use insulin. Probably we are more confident about it than if we used blood serum. Unfortunately, the speaker is without the mic. Yes, the antibiotic therapy in viral keratitis. When should we start? And how long should it take place? If we don't see inflammatory infiltration, we do not prescribe antibiotics at all, because if it is superficial antiseptic, antiviral therapy, local antiviral therapy is enough. If it is stromal keratitis, antibiotics is not indicated at all. If we have clinical symptoms that make us suspect this case, then yes, then we do use it. But I was speaking about clinical picture.
Тому що там неможливо відрізнити, і вона також швидко перебігає, як і бактеріальні інфекції.
Unfortunately, the speaker is speaking without the microphone.
Було підтверджено антимебами вже з тканини, яку ми брали на працьовність.
Once we had the patient with confirmed acanthamoeba from the sample taken in the operational theater. Any method has a certain percentage of mistake risk, and there are researchers who study these cases, and every expert has to be experienced. So I would like to protect, so to say, the doctor who referred the patient to you with diagnosis chronic thrombosis. I am really respectful, but none of the ICDs contains this diagnosis, because chronic thrombosis, from the clinical point of view, a doctor sees thrombosis, but there is blood leakage, and such doctor knows the main thing, that there is something wrong on the fundus. That is why this doctor should refer such patient to you, to Professor Zborovska. I would do the same. Yes, we are all working in the medical system of Ukraine, and we have to establish the diagnosis according to ICD. That is fair. Fine. Any other questions? If not, we are going to finish our section. We are grateful to all the reporters. Thank you for your questions as well, and let us switch to the next session.
Кліп, і готово. Кліп, і готово. Кліп.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини. Не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут – інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня створення. І ще перший завідуючий відділом професор Скрипніченко Зінаїда Михайлівна і послідуючі її послідовники виховують в усіх співробітниках непереможне стремління до досягнення найкращих результатів, навіть в самих безнадійних випадків.
Відділ запальних захворювань ока є унікальним відділом в інституті, який існує більше 50 років. Його історія розпочалася з дослідження туберкульозу очей, що було дуже актуальним в післявоєнні роки, після Другої світової війни, звичайно. Наразі ми продовжуємо роботу наших попередників, і ми займаємось такою складною.
Офтальмологічні захворювання. Інститут в своїй структурі нараховує 475 ліжко-місць, 9 хірургічних стаціонарних відділень, консультативну поліклініку, 10 наукових лабораторій, а також інші клінічні підрозділи.
Особисто я пишаюсь тим, що декілька методик, розроблених в нашому інституті, в Європі називають по прізвищам наших фахівців.
Одна з головних місій нашого інституту полягає в тому, щоб зробити доступною сьогодні високоспеціалізовану офтальмологічну допомогу для кожного українця.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології. Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини. Не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут – інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня створення. І ще перший завідуючий відділом професор Скрипніченко Зінаїда Михайлівна і послідуючі її послідовники виховують в усіх співробітниках непереможне стремління до досягнення найкращих результатів, навіть в самих безнадійних випадків.
Відділ запальних захворювань ока є унікальним відділом в інституті, який існує більше 50 років. Його історія розпочалася з дослідження туберкульозу очей, що було дуже актуальним в післявоєнні роки, після Другої світової війни, звичайно. Наразі ми продовжуємо роботу наших попередників і ми займаємось такою складною патологією, як увеїти. Це орфанні захворювання, які є однією з основних причин сліпоти у молодих людей, у дітей, яку неможливо вилікувати хірургічно.
Сьогодні інститут надає як консультативну, діагностичну і лікувальну допомогу нашим пацієнтам. Ми лікуємо абсолютно всі, без виключень, офтальмологічні захворювання. Інститут в своїй структурі нараховує 475 ліжко-місць, 9 хірургічних стаціонарних відділень, консультативну поліклініку, 10 наукових лабораторій, а також інші клінічні підрозділи.
Особисто я пишаюсь тим, що декілька методик, розроблених в нашому інституті, в Європі називають по прізвищам наших фахівців.
Одна з головних місій нашого інституту полягає в тому, щоб зробити доступною сьогодні високоспеціалізовану офтальмологічну допомогу для кожного українця.
Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології. Цього року ми святкуємо 150-річчя з дня народження видатного офтальмолога Володимира Петровича Філатова, який є засновник Української школи офтальмології. Він народився у лютому 1875 року у сім'ї земських лікарів і все своє життя присвятив офтальмології.
Ім'я Володимира Філатова назавжди вписано в історію медицини. Не тільки медицини взагалі, але й, зокрема, в історію офтальмології. Академік Філатов створив абсолютно унікальний інститут – інститут світла. І сьогодні інститут займає одне з головних місць серед наукових закладів, серед закладів охорони здоров'я України. Інститут Філатова є, мабуть, одним з найбільших і найпотужніших закладів офтальмологічних центрів Європи і всього світу.
Ми, філатовці, представники Філатовської офтальмологічної школи, постійно згадуємо гасла, які нам залишив академік. І одним з них є те, що майбутнє медицини за тими людьми, хто вірить і робить неможливе і діє. І це насправді стало гаслом для відділу посттравматичної патології ока Інституту Філатова. Наш відділ цього року буде святкувати 60-річний ювілей з дня створення. І ще перший завідуючий відділом професор Скрипніченко Зінаїда Михайлівна і послідуючі її послідовники виховують в усіх співробітниках непереможне стремління до досягнення найкращих результатів, навіть в самих безнадійних випадків.
Відділ запальних захворювань ока є унікальним відділом в інституті, який існує більше 50 років. Його історія розпочалася з дослідження туберкульозу очей, що було дуже актуальним в післявоєнні роки, після Другої світової війни, звичайно. Наразі ми...
Hello, dear colleagues. Start our international section, Innovations in Ophthalmology. We have some shifts in our schedule, but I think it will be much better. So the first presentation from Professor Linda Zangwill, presentation about artificial intelligence in treatment of glaucoma challenges and opportunities. Hello?
Hello, can everyone hear me?
Yes, yes, thank you very much. And you may start your presentation.
Thank you. Thank you for inviting me here today. I wish I could be there in person. My husband was in Odessa last month. He's returning from Moldova, where he's a Fulbright scholar and was teaching in Moldova with lots of Ukrainian students from all over the country joining in. My talk today is integrating artificial intelligence into glaucoma management, challenges and opportunities. Now, do you see my slideshow or my...
Yes, everything good.
Everything good. Oh, okay. I want to acknowledge my faculty disclosures. So AI is transforming healthcare, and ophthalmology is really leading the way. In the United States, the first autonomous AI system approved by the FDA was for the detection of diabetic retinopathy in primary care. And it provides tremendous opportunities. AI tools have the potential to improve the accuracy and consistency of glaucoma management, to automate glaucoma detection, underserved areas, putting cameras in primary care, telehealth, ophthalmology and optometry, for clinical decision support, provide visual assistance to clinicians, and provide personalized medicine or predictive analytics to predict who is at the highest risk of progressing. We can move from one size fits all to personalized glaucoma management, so we can identify the right diagnosis, identify which of the numerous tests we use in glaucoma is the right test for that patient, and at the right frequency. So what is artificial intelligence? Artificial intelligence are programs with the ability to learn and reason like humans. They're algorithms, machine learning algorithms, do not need to be explicitly programmed. And now we're mostly talking about deep learning, which is a subset where the algorithms learn with vast amounts of data. We're also talking now about data science, big data, and informatics. And there's been an explosion of data science. At my institution alone, in 2018, we have a new data science institute. We have our first non-clinical division. We have divisions for glaucoma, retina. Now we have ophthalmology, informatics, and data science as a division. We have a school of medicine, a school of pharmacy, a school of public health. Now we have a school of computing, information, and data science just a few months ago. Who would have thought 5 years ago that we would have a school of computing, computer science, a school of engineering, and a school of data science? We also have a chief health AI officer at UC San Diego. Now, AI and machine learning for glaucoma has been around for decades. A close colleague of mine, Michael Goldbaum, a retina specialist, concluded in 1994 that a neural network can be taught to be as proficient as a trained reader in interpreting visual fields for glaucoma. So what took so long? 1994. Well, now we have the computational power, the large data sets, the public data sets, and software to make deep learning possible. And what the next challenge is, implementation into clinical science. It's easy to make these models. It's more difficult to put them into clinic. And there's numerous possible models, inputs that we can use for these deep learning models. And because of time limitations, I'm going to be focusing on fundus photographs and OCT and starting with fundus photographs. Now, whenever we're looking at the models, we need a way to evaluate how well they're doing. And we use the area under the ROC curve, receiver operator characteristic curve. In my slides, it'll be ROC or AUC. And 1.0 is perfect classification, and 0.5 is random, not doing well. We also use the precision recall curve. Now, if you have a data set, 90% glaucoma, 10% healthy, the model can identify everyone as glaucoma. That would be an accuracy of 90%. Your data set is unbalanced. So the model isn't good, but the accuracy is high just because you have 90% of glaucoma in your data set. So precision recall is another statistic that takes that into account. So let's move to photos. Google concluded early on that a deep learning algorithm trained on fundus images alone can detect referable glaucoma with higher sensitivity than and comparable specificity to eye care providers. And here's the ROC curve here. And here are the different clinicians. So it did better, or at least as well as clinicians. And there's a lot of literature there. And my limited amount of talk, I can't really do justice. So I'm going to share some of our work and the journey we made doing AI and some of the lessons we learned in the process. So one of our first studies was also looking at disc photos. We had about 4,300 eyes. We had lots of images because we followed them up over time. And any glaucoma, the AUC was pretty good, 0.191. In mild and moderate to severe, mild glaucoma was okay. Moderate to severe glaucoma was very good. Obviously, if you have more severe glaucoma, the model can find it more easily. Colleagues in Tokyo published in the same journal the same year and did very well with high myopic eyes, with a AUC of 0.96, and non-hylacric eyes, 0.97. They had a little bit smaller data set. Now, one of the challenges of AI is that deep learning algorithms can be biased. Early on, many of the best commercial algorithms identified Michelle Obama, Oprah Winfrey, and Serena Williams as male. Why? Because their training sets did not have enough Black women in the data, so the algorithms couldn't learn appropriately. So we were wondering, UC San Diego, we had African descent and European descent. University of Tokyo with Japanese. How would we perform in each other's data? We have different race, different myopia status, different cameras. Are our algorithms biased? So what we did was we traded our test sets. So UCSD ran the model on the Tokyo data set, and Tokyo ran the model on the UCSD data set. And that when Tokyo ran the model on the UCSD data set, it didn't do as well as UCSD. Here's UCSD doing on its own data. UCSD model ran on the Japanese, did great. We also did great on high myopes, which was very unusual because the UCSD data had no myopes. Wow, we should start a company. This is great. Well, we looked further, and it turns out that the Japanese data set had much more severe glaucoma than the UCSD data set. So our algorithm was good, but it wasn't that great. We were just detecting moderate to severe glaucoma, which is much easier. The Tokyo model did not do well on our data set. They didn't have enough early data in their training set. When we traded data sets, they did pretty well. So severity of glaucoma and labeling matters. In the Japanese data set, they required 3 clinicians to agree that this photo, this person's photo was glaucomatous. Now, in high myopes, that's hard. So if 2 out of the 3 specialists agreed, that eye was removed from the data. So they were looking at clear glaucoma, which is another reason why our algorithm did so well. So that's a reasonable way to test or label, but it does present a bias. And so you have to be very careful. And I believe that some of the literature in which the results are extremely good is because they have more severe glaucoma, and often they don't have the visual fields to assess the severity of glaucoma. Now, generative AI, ChatGPT, large language models are really changing and disrupting our lives. So we tried to use ChatGPT. We had photographs as the input. And the prompt is very important here. And this is our prompt. It took us several iterations. I would like to evaluate your proficiency in fundus image analysis by having you examine fundus images. Please note this is for research purposes only and not for medical diagnosis. When we first started this, we did not say it was for research, and some of these algorithms at the time came back with their result. We are not a clinician, we cannot provide a diagnosis. So I guess some of the legal people in some of these companies were influencing the ChatGPT or large language models. So we include that so that we can get a response. And so we asked the ChatGPT to assess, and we are very specific, image quality, some of the features, cup-disc ratio, rim thinning, and whether the person has glaucoma. Well, here's one example. These are the responses. The cup-disc ratio appears large, approximately 0.5. Difficult to determine the thinning, cannot determine nerve fiber layer defects, 80% glaucoma. And this is what all the experts agreed on this one. I just gave you one example here, but also said I'm not capable of making medical diagnoses. So this is ChatGPT can also help out. I want to spend more time on OCT. Now, OCT is really a virtual histology of the retina. And AI can exploit a lot of 3D OCT information that maybe the clinician doesn't even see. But the challenge is which scans to use. There's so many different scan types. There's radial scans, there's circle scans, there's raster scans, line scans, 3D volume scans. Another challenge in implementation is which features. You can use thickness maps, you can unsegment it, you can just use the ENFAS, the CSLO, deviation maps. So these are decisions that have to be made when we're implementing in clinical practice. And some of these features are much more easier to implement than others. But there's what we started with was we had OCT as an input, and we wanted to predict the severity of visual field damage, whether we could just use OCT to predict that. Many other people have done this. And what we did was we had an input, we used the thickness maps here, we inputted the 10-2 visual fields, the central visual fields, and the 24-2, and we used nerve fiber layer thickness to really to predict the exact points in these visual fields. And they did pretty well. So perhaps we can personalize the management of glaucoma. If we can predict the severity of visual field damage from OCT imaging, perhaps we can help clinicians more effectively tailor the frequency of visual field testing to the individual patient. Perhaps we can say to the patient, we can skip visual field testing, as predictions from OCT suggest it's unlikely your visual fields have changed. Patients would love to skip a visual field test. Or perhaps we can see it's really, the OCT is showing some progression. Maybe we want to see how that's affecting your function. We should move up that visual field test. Well, clinicians don't just use visual fields or OCTs alone. We use a combination. So we can use multimodal models where we input lots of different features. And we did that. We predicted who might need surgery in 1 year, 2 years, and 3 years. And we use electronic health data, OCT thickness data, visual fields, and we had a couple different algorithms, and we predicted surgery in 1 year, 2 years, and 3 years. And here are some of my team who helped complete this analysis. And we did very well. We predicted at 1 year, 2 years, and 3 years, the AUC was 0.93, precision was 0.8, and we had very high sensitivity and specificity. And here are the ROC and precision recall curves that show that it was quite good. Now, because AI can be biased, we always want to look at the generalizability. So when we did severity of glaucoma with early and moderate, and early was the dashed lines, we found that they did well both in early and in late. Age didn't matter, and also race didn't matter. White, the dotted lines versus the non-dotted lines at 1 year and 2 years and 3 years. So we're very satisfied that it was not biased. But there are several challenges to using AI in glaucoma management. There's been a lot of discussion again about bias, but in the medical field, there was a very famous commercial sepsis algorithm that was implemented in hospitals, at least in the States, and it didn't work. Now that's life-threatening if the sepsis model, if the clinicians are relying on it and it isn't working. So really, we need to have rigorous testing on real-world data before clinical implementation. Here's another example. These are 6 commercially available algorithms for detecting diabetic retinopathy, and they tested it on one standardized data set, and they did very differently. So we really need one standardized testing on the same data set. And that's really a move that's happening a lot now, that we're making public data sets available. And the UK has the UK Biobank, is a very famous public data set. We have the All of Us. I want to bring your attention to something I'm working on, NIH funded, the AI Ready and Explorable Atlas for Diabetes Insights. We have 4 different OCTs. We have diabetes status, we have EKGs, neurofilament testing, glucose monitoring, and this is public and anyone can download it. So you have students or people in your group that are interested, please check out aiready.org. Another challenge is opening the black box. What is that deep learning algorithm doing? Well, here's the heat map. It shows the healthy eyes and glaucoma eyes, and these red areas are where the model is looking to make its decision. It looks great because we know these are the areas in glaucoma, superior and inferior region, where clinicians look. However, there needs to be a lot more work in explainable AI with these. Depending on what kind of activation map you're using to produce these heat maps, you can provide very, very different regions on the same photo. So we need a lot of more work in this area. Another challenge is how to implement these into clinical practice. What clinical data to include? Where to put it? Where should they be located for fast access? We have electronic health records. If a patient or a clinician needs to click on a bunch of different screens, they're not going to look. And how should we present them? How to make it simple and clear. And that's a whole implementation science. And we tried to do some of this. We had user-centered interface design where we asked the clinicians how best to provide this information. It was really not easy to try to make it easily understandable and quick for them. So to summarize, there's numerous challenges for clinical implementation. The training, the data set matters. Opening the black box, how do we explain what's happening? And how to integrate into clinical workflow. And there's numerous other challenges that I really haven't touched on in this short talk. Regulatory issues, privacy, medical malpractice, reimbursement. But there's tremendous opportunities for detection of glaucoma and any other eye disease, detection of systemic disease, oculomics, detecting cardiovascular disease and Alzheimer's and Parkinson's by looking at the retina. Clinical trial, we can help with clinical trials and new insights into glaucoma pathophysiology. So perhaps the future of glaucoma management will have take-home devices and AI will help the clinician integrate it. I want to thank my computational ophthalmology team. This is historic. I don't have such a big team right now, but these are people who've helped me over the years. And I want to thank you. We have a new Viterbi Family Vision Research Center in San Diego. If any of you are visiting, please stop by. Thank you so much.
Thank you, Linda. I was very surprised about ChatGPT is possible to diagnose glaucoma. It's not so usable in our country, but I think it's will be big future of AI. But I also have some business with AI, but I didn't expect it about ChatGPT. May use it. Okay.
We didn't either.
Yeah. Yes. Yeah. Thank you. Thank you very much. And some questions? No questions. Thank you very much for
thank
your.
you so much.
Yeah. See you later.
Bye-bye.
Next presentation, assessment of the feasibility of using portable and stationary non-mediatic fundus cameras for screening diabetic retinopathy with artificial intelligence. Speaker, Carol Andrei.
Dear colleagues, so there are several ways to perform the mass screening of diabetic retinopathy in primary healthcare units. First of all, we may use, of course, ophthalmologists, which may perform direct ophthalmoscopy or other types of biomicroscopy of the eye fundus. We may use reading centers with fundus cameras, mydriatic or non-mydriatic cameras, and we may perform also acquiring of fundus images by portable fundus cameras, non-mydriatic portable cameras, and also we may use automated screening systems with AI. So purpose of our study was to assess the possibility of using portable and stationary non-mydriatic fundus cameras for diabetic retinopathy screening assisted by artificial intelligence Retina AI HKI software platform in primary care. So we used two cameras, one of the cheapest non-mydriatic stationary camera, Crystal View Medical Corporation, with viewing angle 45 degrees and minimum pupil size 4 millimeters, and portable non-mydriatic fundus camera Aurora with minimum pupil size for photographing 3.1 millimeter and viewing angle 50 degrees. The stationary fundus camera performed images of eye fundus in 290 patients, and portable fundus camera performed fundus images in 319 patients. All patients were investigated in primary healthcare units. There were patients with diabetic mellitus and patients with risk factors of diabetic mellitus, like obesity, high body mass index, so on. We performed one field eye fundus photo with macula in the center and a non-mydriatic pupil. This is example how we performed eye fundus imaging with portable non-mydriatic camera. We used the classification for AI algorithm from diabetic retinopathy is not detected to proliferative stage, and also we added invalid photo for improving our classification. So the main of our results was that when we use stationary camera, we achieved very low % of invalid images. Totally, we found just 5.5% of eyes with invalid images, which AI couldn't grade. And if we calculate patients, it was just 8% of patients. So some patients had both eyes with invalid images, but some patients had only one eye with invalid image. But also we surprised that there were some patients when medical staff didn't upload images in the cloud network. But in another group, which were photographed by portable camera, results was very different, because totally we found more than 300 images were ungradable, invalid images. And if we calculate for patients, it was 69%, 220 patients out of 319 subjects were photographed by portable camera. And also we found some percentage of images which were not uploaded to neural network. And of course, other patients, other images, when they were with good quality, AI system was able to analyze, and we found diabetic retinopathy not only in diabetic patients, but also we found some signs of diabetic retinopathy in patients with risk factors of diabetic mellitus, but without diagnosis of diabetes mellitus. Both results in stationary camera and in portable camera. In the discussion, I may say that there are several studies in the literature, included this Aurora portable camera, but it's very difficult to compare clinical studies design, because in a study of Cubin 2024, they used 21 different AI algorithms to analyze digital images, and ungradable photos differs from 0% to almost 30% of images. Another study of Professor Eduardo Medina was published in 2023, also with Aurora camera, but we can't compare with our study because all patients underwent fundus photography in mydriasis. So this portable camera is non-mydriatic, but they use it with mydriasis. But also, even in these conditions, they achieved 1.3 ungradable eyes with diabetic retinopathy. And third one, LUPD 2023 study, also with Aurora camera. They used this camera in non-mydriatic mode, one macular center photograph like in our study, but in this article is not published information about ungradable images of eyes with diabetic retinopathy, so it's difficult to compare. Of course, our study has some limitations because we have two different groups of patients. So one group was observed, examined by stationary fundus camera, and another group was observed by portable camera. Of course, better to have one group of patients and use both cameras to compare more precisely. But I think we have a very interesting result that, first of all, our system, neural network Chikai, may perform detection of diabetic retinopathy and grading of the diabetic retinopathy stages among individuals with diagnosed diabetic mellitus and risk factors of diabetic mellitus. And this portable camera has a lot of issues utilizing with non-dilated pupil for mass screening of diabetic retinopathy, involving an experienced operator adhering to the protocol of uploading fundus images to a cloud database, are ways to reduce the percentage of poor quality images and increase the efficiency of diabetic retinopathy screening using a non-mydriatic portable camera. So my personal opinion, we can't use such cameras, portable cameras, for mass diabetic retinopathy screening. Thank you for attention. This is our publication in Ophthalmology Journal of Ukraine. Thank you for attention. So I think we will continue our program, and if you have some questions, we may discuss it after this session.
Thank you very much. Next presentation, there was a multi-center study on RVD, real-world data of Vabismo in treatment-naive patient in Germany. Albert Augustin.
Thank you very much. Do you hear me?
Yes, we hear you.
Okay. If you agree, because I have 3 presentations in a row, I would like to start with the photobiomodulation talk. Is that okay for you?
Yes, of course. Yeah, please.
Okay. Then, because we have some new data which have been published on ARVO, just let me, yeah, okay. Okay. Can you see the full screen? Yes.
Yes, we see. Please, you may start.
So, photobiomodulation for the treatment of AMD. This is just a short clinical update I would like to share with you. So, a few words on the LightSight 3 trial, but the most interesting slide is just one slide. I will discuss that in detail. These are my disclosures. So the PBM approach, we all know about that, is using a low-level light to stimulate cells. It restores the energy of the cells by mitochondria reactivation, and it uses different wavelengths as shown on this slide. So I don't go into detail. This is the study design of the so-called Light 3 trial, which finally led to an approval of this approach in dry AMD, randomization 2-to-1, photobiomodulation versus sham. These are the baseline characteristics of the population. And as you can see here, 32% low risk 1 to 3 risk factors, and moderate to high risk 3 to 4 risk factors. All other baseline characteristics are not very remarkable. 99% of the patients, of course, Caucasian. I skipped that slide. This is just a trial profile, and I would like to share with you the best corrected visual acuity results, as shown here. You can nicely appreciate that the photobiomodulation approach leads to a significant increase in visual acuity as compared to sham. This is the best corrected visual acuity letter gain distributed over the second part of the trial, months 13, months 21, and months 24. Again, a nice visual acuity increase, significant increase as compared to sham. If you stratify the patients according to the baseline visual acuity, you can again nicely appreciate that there seems to be a ceiling effect, which is at about, let's say, 70 to 72 letters. Over this visual acuity, or in visual acuity higher than 72 letters, there seems to be a ceiling which then has which leads to the fact that PBM has no significant additional effect, as you can see here. This is the risk reduction calculation for visual acuity, Kaplan-Meier-like curve, and again, you can nicely appreciate that the risk is significantly lower in PBM patient as compared to sham, and I would like to encourage you to keep this slide in mind. And this is just a case here. You see that not only visual acuity increases, but also drusen are influenced by this approach. The drusen disappeared nearly completely, and this goes along with a visual acuity increase. This is the incidence of geographic atrophy. Again, a much higher significant incidence in sham patient as compared to the photobiomodulation group. And if you calculate this, if you calculate the risk, again, a kind of Kaplan-Meier curve, you can again see that the risk is significantly reduced by photobiomodulation as compared to sham. So now I would like to share with you, and this is the reason for the talk, I would like to share with you the LightSight 3B results, which have been presented on ARVO just a week ago. And let me explain you the results. What you have seen on the left side was one of the first slides I showed. This shows a significant increase in visual acuity during the trial, which ended at month 24. Then the patient had not been followed. There was a 20 months gap, and then all patients, so sham and the PBM patient, received again the photobiomodulation therapy. And as you can see here, the PBM patient recovered nicely to the visual acuity, which was shown at month 24, whereas the patients in the sham group showed no recovery, and the decline in visual acuity was much higher as compared to the PBM group, as you can see on this slide here, in the middle, in the 20 months gap period. And if we go back to the Kaplan-Meier curve, I think this is a confirmation of this mathematical calculation. So visual acuity risk reduction is much lower, significantly lower in PBM patients, even after stop of the therapy as compared to sham. So this is a final confirmation of the Kaplan-Meier calculation. So in summary, the LightSight 3 met the primary efficacy endpoint. We all know that. But in addition to this, the visual acuity reduction was significantly lower after end of the therapy as compared to sham. And now we have results which are longer than 54 months, showing quite nicely that photobiomodulation seems to be a good approach for the dry AMD patients. Thank you very much.
Thank you very much. Very interesting presentation. How, in your opinion, is most effective regimen of photobiomodulation for treatment geographic AMD?
I think this is an interesting approach. I would say that we are still in a kind of, let's say, selection phase of finding the ideal patient. What we know now is there is a ceiling effect, of course. So visual acuity, if the visual acuity is still too high, there is no effect to be expected. However, if we look at these 20 months gap, PBM could also be, we don't know that yet, could also be a kind of prevention for the further decline of visual acuity. So there are a lot of questions still out which need to be answered, and hopefully in the future, maybe next year or in 2 years, we will know more. At least we have an approach which seems to help the patients, the dry AMD patients, as we have no other therapy for those patients so far.
Thank you. Thank you very much.
So, of course, you may present your next presentation.
Okay. Should I start with the German faricimab trial now?
Yes, that's good.
Okay. Then I start with the faricimab trial. So this is, let me see, just one moment. I still need to wait until the window disappears that I can show you the full screen. Okay, now.
Excellent, yeah.
Okay, You see the full screen now?
Yes.
Okay, thank you. So what we did in this trial, we analyzed the clinical care and therapeutic practice of treatment-naive patients with neovascular AMD and diabetic macular edema, which have been treated with faricimab in a real-world setting. So in general, this shows an overview of the current treatment situation in our country, focusing on treatment regimen, on the upload phase, and also on the imaging which is used in those patients. We looked at the proportion of faricimab naive patients. We looked at the effectiveness of the therapy, at the reasons for therapeutic decision, baseline characteristics, development of fluid during the upload phase, and development of vision during the upload. So this is a healthcare research project, multicentric retrospective involving 24 ophthalmological practices and clinics in Germany. We have included 189 treatment-naive neovascular AMD patients, 205 eyes and 38 DME patients, 39 eyes who initiated treatment with faricimab. And please keep in mind that this was in the very early phase of the approval of the drug. That's why we don't have so many patients. We did an anonymous aggregated data collection. The collection of parameters was done in categories, not at an individual patient level, which was due to ethics restrictions. And the time frame was from October 22 to October 24, and we documented all patients within 2 months, as you can see here. The inclusion criteria are shown here. Of course, diagnosis of neovascular or DME, no previous injection because naive patients were selected. They had to receive at least one faricimab injection, and we collected all data on CRT, SRF, IRF, and PAD status, of course, only in AMD, as well as visual acuity. The exclusion criteria are shown here: participation in other studies of Roche, any type of eye opacity that could affect visual acuity, and any type of intraocular surgery on the affected eye during the data collection period. Here you see the treatment regimen and upload in clinical practice in Germany. Treat and extend was the highest rate, PRN 7, IVAN 1 patient, and other or own treatment regimen also 1 patient. In addition to this, you see the injection pattern for upload. A few do only 1 injection, some do 2 injections, and 3 injections and 4 injections are the higher rate, as you can see here. These are the baseline characteristics of our population. Nothing really remarkable, as you can see here. Everything as expected. 74% suffering from diabetes type 2, and only 25% suffered from diabetes type 1. The main reasons we evaluated on a request. As you can see here, change of injection intervals was one of the major reasons, and the possibility to reach best effectiveness was also a major reason in both populations, neovascular AMD and DME. The baseline characteristics of the eyes are shown here. I think this is a distribution as we can expect if you look at such a population, so I don't go into detail. What is quite interesting, we had 2 DME patients with a rupture of the external limiting membrane and a quite high rate with drill, as you can see here, 45%. So the visual acuity expectation is reduced in this population, as you all know. Here you see the CRT and fluid reduction, and again, you can nicely appreciate that the fluid reduction could be achieved in more than 50% of the patients, and this reduction was, the reduction was was much more than 50%, and the highest rate of the patients experience a reduction of about 50%. And the rate of showing an absence of intraretinal and or subretinal fluid in the eyes during the upload phase is shown on the right side of the slide. And again, you can nicely appreciate that those patients, that the rate is quite high. And this is not only true for neovascular AMD, but also for diabetic macular edema. Here you see the development of vision. And again, you can nicely appreciate that there is an improvement of decimal vision above more than 0.1 in more than half of the eyes during the upload. 1/3 of the eyes had a vision improvement between 0.2 and 0.4. And again, there is also a possible ceiling effect since the patient, since some of the patients already started with a high best corrected visual acuity level. In addition to this, we have a kind of negative ceiling effect because there was a quite high rate of trill in the DME patients. The limitations are, of course, the fact that the study was retrospective and descriptive. The study center participation based on the inclusion of treatment-naive faricimab patients. A different number of injections were used for upload depending on the center, and the collection of parameters in predefined categories is also a kind of limitation. So we were not able to look at individual cases according to ethics regulations, and the follow-up period is still limited. So we are planning to continue this trial in the future, and maybe next year I can tell you more details about our results. Thank you very much.
Thank you very much. And we also have some limited experience in faricimab, in age-related macular degeneration, in diabetic retinopathy, and sometimes off-label, even in chronic central cirrhosis with choroidal neovascularization. So yeah, it's good. It works. But of course,
it works. It's a quite interesting drug, and it works in patients where we have no success with other drugs.
Yeah.
So far.
Yeah. Any questions additional?
Okay.
No? Okay. So could you present your presentation about chronic pain?
Yes. So this is actually a presentation for us surgeons. It's not a presentation which looks at patients' results. What we did a single center, one surgeon trial, looked at chronic back pain, postural imbalance in high volume ophthalmic surgeon, in a high volume ophthalmic surgeon, and we wanted to know if there is an impact of three-dimensional display systems. I have nothing to disclose for this presentation. And let me start with some facts from the recent literature. In this trial, more than 300 cases have been evaluated, and the colleagues have looked at heads-up three-dimensional viewing systems in vitreoretinal surgery and wanted to know if there is any benefit coming from this new viewing systems. So we are talking about three-dimensional viewing systems plus heads-up. There was no difference in anatomic success, no difference in duration of surgery, no difference in postoperative complications, and no difference in visual prognosis. This is for our patients and patients' convenience. The peel time, if you do macular peeling surgery, is longer in the three-dimensional group. There seems to be a learning curve. the endo-illumination power needed because its digital system is less in the 3D group, and the surgeon satisfaction is higher in the 3D group. And if you look at the age of the surgeons, it seems to be that younger patients like the three-dimensional surgery more than younger surgeons as compared to older surgeons. However, the advantages, most of the advantages can be also reached without heads-up surgery. You just need a digital system to have these advantages shown in this presentation or study published just recently in 1993 in Clinical Ophthalmology. So there is an impact on medical education, which comes from digital systems, but no heads-up surgery needed. There is an impact on telementoring, digital systems, no heads-up surgery needed. We are able to reduce phototoxicity, good for the patients, if you use a digital system, but there is no heads-up surgery needed. The removal of the of epiretinal membranes seems to be more complete and less recurrence. Maybe also higher resolution digital systems, but no heads-up surgery needed. And I would at least speculate that intraoperative OCT is of a higher advantage than the digital system. However, we as surgeons, when we become older, we develop musculoskeletal problems. We have neck pain, we have lower back pain. There is in total a higher prevalence of neck, wrist, and lower back discomfort. There are contributing factors, of course, repeated work, extended and awkward positions, and bending of the joints. The time spent, this is quite interesting, the time spent in surgery was significantly associated with these symptoms, and 14% of the participants in the trials I present here stated that they intended to retire early due to those symptoms. So we are losing high experienced surgeons because of lower back discomfort and musculoskeletal symptoms. This means that improving the work settings makes really sense. And according to a survey of ophthalmic surgeons, heads-up displays improved posture and increased general comfort. And third, surgeons who use heads-up displays for over half of their cases had a 5 times higher likelihood of pain reduction. So we know that, and we can believe that, and maybe switch to heads-up display because of this data, which makes sense. However, what we do not know is if a surgeon who is older, let's say over 50 years, up to 60 years, if their positioning-related musculoskeletal malformations, which have already developed, can be in any way influenced by heads-up display. What we know is conventional binocular microscope enforce prolonged neck and back strain. The results in musculoskeletal discomfort are chronic back pain, postural imbalance, kyphotic deformity, and we know that up to 70% of ophthalmologists in surgery are affected. And this is why we looked at this heads-up display, which completely changes our way to do surgery. The hypothesis was, is a transition to heads-up surgery reducing musculoskeletal discomfort and postural imbalance? And is there any way to anatomically prove that? We know that physical fatigue back pain and postural imbalance seems to be reduced, but what is the reason for this? The aims and questions are shown here. We looked at thoracic kyphosis and cervical hyperlordosis. We looked at cervical range of motion, and we looked at back pain and disability. This was, of course, an observational trial. Again, this is the study design, binocular microscope for more than 6 months, maybe 20 years or even longer. And then a switch to 3D display systems was done for at least 6 months. Now we are in our observation trial at more than 12 months. We are doing further follow-up. We did X-ray, ROM, NRS, ODI. You will see that just in a second. This is the postural balance, and you can I don't go into detail of the values. This is for orthopedic patients. However, you can already on this slide appreciate that the thoracal kyphosis has changed a little bit already after 6 months, and we measure that. The norm is at 40.6, as you can see here. Kyphosis is defined at an angle of 50.6 or larger. And on the left side, look at the right side of the image. On the left side, you see the TK value at baseline, which is 51.8. So according to the international classification, this is a thoracal kyphosis. And the TK value after 6 months, even after 6 months, was reduced to 45.7 degrees. So a great success after 6 months of heads-up display surgery and not sitting at the microscope in a conventional fashion. Now, a more significant value, which is very important, especially if the people become older, the kyphosis, the lordosis of the cervix. The norm is at about 5 degrees, and we speak about a hyperlordosis if we have more than 7 degrees. Cervical hyperlordosis is needed to maintain gaze in patients with a TK of greater than 50%. So the TK, the thoracal kyphosis, and the hyperlordosis are closely correlated, as you can see here. And again, look at baseline. The cervical lordosis value is at 32.4. So this is a clear hyperlordosis. If you look at the norm values, 5 degrees plus minus 12, or minus 5, minus 12, let's say a maximum of 17 degrees are allowed. And if we are over that, we have a hyperlordosis. And the CR value here was at baseline at 32.4. And look at the cervix cervical spine on the right side. After 6 months, it is at minus 12.8. So we are already in a norm value, even after 6 months of heads-up display. Furthermore, we looked at the mobility, and again on this slide, you can nicely appreciate that after 6 months, the range of motion was much higher in the cervical spine as compared to baseline, and this is true for different modes of mobility, as you can see here. Extension flexion is shown on the left, a little bit higher. The rotation has significantly increased. This is shown in the middle, and the lateral flexion also has significantly increased, a little bit more to the right side, as compared to the left side, as you can see here. And this is also true, by the way, for extension and flexion. Here you see pain and disability, also a significant reduction. As you can see here, we used a disability index with the ODI, which is usually used by specialists in orthopedics. And again, the NRS and also the ODI were significantly reduced after 6 months. So in conclusion, of course, this is only a single surgeon, one center observation, but the switch to three-dimensional display systems seems to improve postural balance, thoracic and kyphosis and cervical hyperlordosis. There is also an improvement in cervical rotation, flexion and extension, and also lateral flexion. The pain and disability was significantly reduced according to an internationally accepted questionnaire. So keep your head up, and I think this will be the future, at least if we want to keep our surgeons longer in the boat, and we don't want to send them to retirement too early. Thank you very much.
Thank you very much. Interesting to study laser surgeons, not only vitreoretinal surgeons, but
yeah. This is for any kind of surgery. Yes.
Yeah. Okay. Thank you very much. I am so glad you take part in our conference every year. So, of course, we invite you to the next year to Filatov Readings 2026.
Okay.
Maybe we hope you may be here in personal on site.
Yes. You know, before COVID, I have bought the tickets, and I still have a voucher for this. So as soon as it is possible, I will come.
Excellent. Thank you very much, and we will move on. And next presentation, we have some shift in our schedule. It's a presentation of Matteo Piovella, wider refractive cataract surgery adoption to improve safety, efficiency, and efficacy, and better vision in eye surgery. Please.
Cataract surgery is totally changed, and today we need to refer to this surgery as refractive cataract surgery. Today, modern cataract surgery is the most common and efficient way to correct refractive defect, myopia, hyperopia, and astigmatism, and naturally presbyopia. We need to upgrade our experience, and we have to organize a new model to obtain this result. But just in 2012, during the opening ceremony at PSRS meeting in Milan, I expressed some simple concept that the best available care is not dependent on cost efficiency. Best available care is not dependent on national regulatory approval, but is based on the best care. And my surprise is that my experience is that patients don't have the capacity to judge the best possible eye care as normally is done today, because the responsibility to choose the lens is put on the shoulder of a patient that has not this capacity and experience. But the thing now we have understood that is based on a new advanced biometry precise refractive outcomes, and the concept that we need to support at all is to eliminate anisometropia. We need to face with two equal eyes, eyes that are the same possible. We have learned this by refractive surgery, and that is the rules that everybody needs to allow. Quality of vision is really a complex situation. We understand what does it mean loss of contrast sensitivity, and that is a natural penalization of all the people over 60 years of age. But we need to remember that this is based on the pupil size, because to read by near, we need a small pupil, and if the pupil is enlarged too much, that penalizes the quality of our far vision. And that is a concept that penalizes every single IOL implanted. Loss of contrast sensitivity is so important as astigmatism complete correction. This graphic is very simple. Determine that if you have an IOL that corrects only 2 diopter of astigmatism, and you have a rotation of only 8 degrees, not perfectly corrected, your quality of vision, not your vision, your quality of vision dropped down by 100% to 0, only for 8 degree correction. Naturally, with a pupil size of 5 millimeters. Remember, pupil size is determining the quality of vision in all patients. And that is the story of modern multifocal IOL. That is a simple meaning that the company made a lot of attempts without getting what they want, because only one technology is really superior to the other and permit a perfect quality of vision after the surgery. And this to summarize, trifocal IOL is the best technology to correct refractive defect and presbyopia, submitted and approved for distance, intermediate, and near vision. The standard depth of focal is a different technology, but doesn't work by near, and for that they are submitted for distance and intermediate vision. And the pinhole IOL are submitted for the characteristic of pinhole that everybody know, and the main characteristic is to correct up 1.5 diopter astigmatism, only implanting the pinhole system and nothing else. This is, and to stress the concept that the pupil size is depending by ELOS, glare, and unsatisfaction result. This is overnight, when there is no light, the pupil enlarges over the size of the optic disc, and that is detected by the patient, and the patient are complaining about that. But if you change this situation, because it's enough that you put on the courtesy light back of the driver, and the light within the car is able to restrict a little bit the pupil size, and that avoid the kilos glare and all the side effects of night eye. Well, this is important that technology help us to be precise for the toric correction. The Callisto is one. I don't think that is necessary or good to have a manual switch. The key point in summary are these. Different, now for the eye doctor, different eye technology are perceived as responsible of post-operative quality of vision. On the contrary, quality of vision after cataract surgery with trifocal IOL depend by obtained post-operative small refractive defect within half diopter of equivalent. And advanced biometry new organizing model is required, because what we are supporting now is not enough. And then diameter of evaporative dry eye and deep subdermal blepharitis is crucial to support the good result. So we need to apply biometry more than one time. Immediately after the care with the BlephEx, LipiFlow, and iLose treatment that needed to be applied on the normal basis to all the patients that submit refractive cataract surgery. This is to show that same patient, same day, few minutes after, we have a different result because you can see that the quality of your film is not enough. This is another example. 2 diopter of astigmatism differently because we have no control of the quality of dry eye, and that is what could happen with multiple shot. And this is to spread what is deep subdermal blepharitis that is associated anytime on evaporative dry eye. So we have to perform a microblepharoexfoliation of the margin lid, and step 2, perform heating and of the gland and expression. Then we know that there are by the bacteria they produce lipase and esterase, and that create inflammation, and that inflammation destroy little by little the meibomian gland. And we need to now we have understood that to scrub and express in the perfect way, we need to vaporize this material first. And that is a show of a dropout of the glands. These are volcanocyte, red line sign, signal vessel, and target sign that is very easy to determine as BlephEx is the first treatment that we apply consequently that eliminate biofilm, demodex, and debris, and to unblocking excretory ducts of meibomian. This is to show demodex. Demodex is present in more than 80% of the people over 50 years old. And next, this is a video that I showed to the patient to make them understood what does it mean demodex in the meibomian glands, and that is very effective. This is to detect the demodex. It's very clear in very simple maneuver at the slit lamp, and this is to determine within the eyelash the biofilm also before BlephEx treatment. And this, everybody knows, this is LipiFlow treatment that increase the temperature by 5.5 degrees for 12 minutes to change by solid state to liquid state. And that is the MAPRI-Clear protocol. I look that we apply it because we have found that after the 2 first treatment, some part of the material still inside the gland, and so we increase the MAPRI-Clear protocol. I look that we apply it because we have found that after the 2 first treatment, some part of the material still inside the gland, and so we bacteria. This is to determine how is important the correction of astigmatism, and that 43% of my cases are correcting 1 diopter of astigmatism. This is very important to get the best result because many surgeons think that up to 1 diopter of astigmatism is not necessary to correct 1. This is some number that I have done with this multifocal only to, but the number is not important now. And this is to show that when I do not apply any eyelid treatment for evaporative dry eye and deep blepharitis, with no treatment, 8% of the eye didn't match the right post-operative refractive outcome. With only LipiFlow 10 years ago, 6%. With BlephEx and LipiFlow, reduced at 3%, and with BlephEx, LipiFlow, and iLose treatment, only 2% of my eye are outside of the half diopter of that. This is what the final practical result. I started to implant trifocal IOL, the Zeiss trifocal IOL at Elisa 3 in 2012. And since then, now are 5 years that I am implanting about 100% 100% of my cataract patient this typology of lens with nice and very outstanding result. Thank you very much for your attention.
Hello, Dr. Piavella. Hello. May I ask you one question?
Absolutely.
Yeah, you said that state of TEA film may lead to some refractive errors when we calculate IOL. Is it okay to use some lubricants during the calculation of IOL?
Well, yeah, this is the normal feeling about that. In my opinion, we have to improve the quality of a tear film because with improving the quality of a tear film, the surface of the cornea provide the better measurement K1, K2 for biometry, and now we have analysis for images that provide us precision of 1 micron, and that is something absolutely effective. Normally, we do not consider the biometry a key point. We have to apply biometry more than 1 time and treat the evaporative dry eye or deep blepharitis, and that allow us to get the refractive goal. This is a change. It's not that every different technology of the optic disc could be well supported if you get the plano result after the surgery or within half diopter. We think that the different technology, we follow the indication of the company, but the company has not enough experience in all the product. And last thing, trifocal technology is the only technology that provides perfect far, intermediate, and near vision.
Yeah, thank you very much also for your interesting presentation. And we hope also to see you next year in Odessa, also in Philadelphia.
Absolutely.
Okay,
To be my honor. Thank you very much for inviting me.
Thank you very much. Yeah, bye-bye. Okay, we will move on, yeah. Presentation of Dr. Nasinnik from the Filatov Institute, and presentation about adaptive optics and calculation of density of photoreceptors in primary and secondary school children after a retinopathy of prematurity. Please.
We have nothing to disclosure. Retinopathy of prematurity is a condition that can occur in babies born too early. It can change the structure of the retina, affect vision, and lead to invalidation. To examine the retina, we used the new technology, adaptive optic. It's a super camera that takes very detailed images of the retina, allowing us to see the photoreceptor clearly. The aim of study, they measure the density of the photoreceptors in the macula of school-aged children with the self-regression of retinopathy of prematurity in anamnesis. Study design, pilot observational diagnostic case report study of school-aged children with a self-regression of retinopathy of prematurity. inclusion criteria: informed consent, aged from 9 to 15 years, visual acuity with the best correction by decimal 1.0, anterior posterior axial eye light 22-24 millimeters. We examined 20 children aged 9 to 15 years with a self-regression of retinopathy of prematurity in anamnesis and 10 healthy children as a control group. All children were examined for visual acuity, axial eye, and examination with adaptive optics. We divided children into two groups based on how early they were born and their weight at birth. The first group had 10 children born very early, at 26 to 28 weeks with low weight. The second group had 10 children born a bit later, at 29 to 32 weeks. This presents the main characteristic of the subjects. For ophthalmoscopy with adaptive optics, we used Imagine Eye RTX1. Photoreceptor density was analyzed using Imagine Eye software. We checked the density of photoreceptor at a distance of 4 degrees from the fovea in 4 sectors: superior, inferior, nasal, and temporal. Due to the big data variation, for statistical analysis, we calculated the median. We found that the first group had about 25,063 photoreceptors. The second group had about 22,308, and the healthy children had about 21,222. However, when we checked the statistical validity, the differences were not significant. There is evidence in publications the photoreceptor density can change with age, with the axis of the eye, and with the various ocular disease. However, there is no date on photoreceptor density in children with the retinopathy of prematurity, and it needs to be studied. Limitation: number of patients, more number of criteria for evaluation, long-term follow-up, impossibility to comparison with other studies. In conclusion, children with a self-regression of retinopathy of prematurity in anamnesis have statistically insignificant difference in photoreceptor density in comparison with the healthy children. However, the data are preliminary and require increasing in study group and clarification. Thank you for attention.
Thank you very much. Some questions? Okay, thank you. And we have 2 presentations in video recorded. Please, could you start Professor Anat Löwenstein, a cross-sectional pivotal home OCT trial, compare performance of AI-enabled algorithms with human graders in neovascular AMD. Please.
Good morning. Following Jeff's talk, I'm happy to present a cross-sectional pivotal trial to compare the performance of AI algorithms with human graders in neovascular macular degeneration. I am pleased to be able to present the second pivotal study design and results, which have led to the FDA approval of the first ever home OCT device. This is the first time an AI algorithm is cleared for an OCT imaging system, and we will discuss how such an algorithm can obtain regulatory clearance. In addition, we will discuss what is the meaning of performance of such AI algorithms on our clinical management of our patients. In the first presentation, we looked at the results of the study demonstrating that the in-office OCT and home OCT indeed provide similar images demonstrated by equivalence of grading of the key biomarkers by expert graders, and also that patient can acquire images on a regular basis. The challenge, however, remains that large volume of data acquired at home can't be reviewed by the physicians, hence the use of AI is essential. In this presentation, we will discuss results from the study that demonstrate the performance of AI, and we will see how the performance impacts practical clinical management. Before moving further, I wanted to take a moment to highlight some important OCT biomarkers definitions that take us from the physical interpretation to image interpretation and will be relevant for the discussion. HRS, hyperreflective spaces, are low reflectance abnormal voids, while IRO and SRO represent HRS in the intra or subretinal space respectively, and TRO, or total retina hyperreflective spaces, represents the sum of IRO and SRO. Volume units will be the units we will use. One volume unit is numerically equivalent to 1 nanoliter. Moving forward, this is what we will use. Subretinal and intraretinal fluid are commonly used to refer to hyperreflective spaces observed on B scans, termed TRO, SRO, and IRO. However, not all hyperreflective spaces on macular OCT imaging are actually fluid, and not all exudative fluid will necessarily be hyperreflective. The key question that was first time addressed in this study, and is very important for the future growth in our field, is how does one evaluate the performance of an AI system in retinal imaging, particularly from the perspective of regulatory clearance. Here are two important things that we need to demonstrate, particularly when it comes to AI-based estimation or quantification tools. Firstly, the tool should be repeatable on images acquired by the device. That is, when the same eye is imaged multiple times, we get similar results. The second is agreement. This refers to the relative agreement between the graders and the AI. It should be noted that such an evaluation should account for intra-grader variability itself. Let us now look at the details of the AI study. The patient acquires 4 images on 2 different OCT devices each. The scans are processed using AI-based algorithm for SRO and IRO segmentation. 10% of the B scans from the home OCT were annotated independently by 3 expert graders. The patient also acquired a single in-office OCT scan. This scan was again graded by 3 expert graders. Inclusion and exclusion criteria were identical to the visualization study, with patients having neovascular macular degeneration in the study eye, no prior home OCT experience, and confounding pathologies were included. There were 2 key outcomes in this study. The first was repeatability, a measure of precision, which, for the purpose of this study, was defined as the similarity of quantitative estimates for the same eye with repeated scans or grading, and was assessed using coefficient of variation. In this way, comparisons of repeatability could be determined for repeated home OCT scans and NOAA grading, and in-office OCT scans with reading center grading. The second key outcome in the AI study was agreement, which for the purpose of this study was defined as the similarity in segmentation as determined by AI and expert graders. This was assessed using the dissimilarity score, which measures the overlap between the area segmented by the AI and that segmented by the grader. Baseline characteristics of the 336 enrolled patients are listed here, and demographic data was similar to the visualization study. However, HRS was present at much higher rate at baseline, with 89.4% of patients having IRO, SRO, or... If we look at the repeatability results, we see a coefficient of variation of 11.1% for home OCT and 16.4% for in-office OCT when examining eyes with at least 10 volume units of TRO, which was felt to be a clinically relevant amount of TRO. These results demonstrate good precision for both device-graded combinations on the and the home OCT plus AI is more repeatable than the in-office OCT and grader, with less variation for the combination of home OCT with AI grading, and certainly at a level that should allow for identification of clinically meaningful trends in TRO. In terms of agreement, we see excellent agreement in terms of volume estimation, with AI dice scores on par with those seen between 2 human graders. So combined with AI, the HOMO-CT gives physician unprecedented insights into disease dynamic, looking at the AI estimation of hyperreflective spaces, providing a projection map, a longitudinal TRO volume trajectory, and an ability to set the threshold to get notifications. In order to understand the impact of the AI performance seen in the pivotal studies, we performed Monte Carlo simulations that, creating a large number of simulated data points to get statistics on performance. We used the 5-week data from the visualization study. The variability observed in the AI study was superimposed on the trajectories. In this manner, we created 1,000 simulated trajectories which carried the potential variations for each original measured trajectory. We wanted to see statistics of potential change in time when the trajectory crosses a given threshold. This is basically variability in the time for notification that patients receive when their TRO levels increase. Here is an example of simulated trajectories created from an original one. The trajectories effectively show potential variability in the measurement. The blue horizontal line shows threshold for receiving a notification. What we want to see is the potential of receiving a notification either sooner or later when this variability is applied to different time points. On the left side, the chances for notification being generated early, and the right, the chances for notification to being created late. So the change of notification date will be small. We performed the statistics on the simulated trajectory to see close to worst case scenario in variation of timing notification. We look at 5 to 95 percentile interval that we see extend from receiving the alert notifications 4 days earlier to 2 days later from the actual day. This shows there is limited impact on potential time for notification because of any variability in measurement and subsequent AI quantification. To sum up, we discussed the pivotal study leading to the approval of the first AI-enabled HOMO-CT. The HOMO-CT imaging and AI algorithm do show good repeatability over multiple measurements, and the AI-based estimation of hyperreflective spaces volume shows good agreement with expert grader at the same level as those seen between graders. The AI accuracy in estimation of TRO is deemed sufficient for clinical management as shown by Monte Carlo simulation. Thank you for your attention.
Thank you. And we have the last video from after another section, TAC and MEC for Fuchs endothelial dystrophy with simultaneous cataract surgery, results from a randomized controlled study. Jesper Hjordal.
Hello, thank you for inviting me to give my presentation on DSEC or DMEC for Fuchs endothelial dystrophy, results from a randomized study. My name is Jesper Hjordal. I come from Denmark, which is located here in Northern Europe, and I come from an institution where we have done corneal and ocular surface disease treatments for many years. We are doing a lot of corneal transplantations, approximately 350 per year, and we are doing also corneal cross-linking. We're doing corneal refractive surgery and also intraocular refractive surgery. I come from a public hospital, and I will show you a picture here of the hospital where I work. We are located a little outside the city of Aarhus, which is nicely located at the coast here. And this is Aarhus University Hospital. It's a very big hospital, one of the largest in Northern Europe. And the eye department is located in the area here. We also have the Danish Cornea Bank located in the hospital, where we provide donor corneas to the other clinic in Copenhagen in Denmark, which also performs corneal transplantations. And here in Aarhus, we take care of patients living in the western part of Denmark, and that's a population of approximately 3 million. The indications for corneal transplantation has changed a bit over the years. We are participants in a Swedish corneal transplant registry consisting of all clinics in Sweden and Denmark, also some from Norway, and the small clinic on Iceland. Today, approximately 75% of all our corneal transplant patients, they have Fuchs endothelial dystrophy. A little part has pseudophakic bullous keratopathy, 5% are regrafts, and over here you can see the distribution between the different indications. Keratoconus is quite small, only a few percent, and the number is probably slightly decreasing. Maybe it is because we are doing cross-linking early on to make sure that patients don't need a corneal graft later on in their life. Maybe it's because our optometrists are better to fit contact lenses today than previously. So the big one here, the red is from the whole registry, Sweden, Denmark. The green, that's from our clinic. The second one is here, that's regrafts, which is number 2, course. And then we have a few down here with acute corneal ulceration, bacterial, fungal, or sterile with corneal perforation. Fuchs endothelial dystrophy, as I said, is quite common in Europe, and I think it is even more common in Northern Europe. So at a first glance, it's difficult actually to see what's the problem here, but you can see on the inner side of the cornea, the endothelium here, you have a sort of a slightly irregular reflex caused by the confluence of corneal guttata on the inner side of the cornea. I think the guttata themselves, they can cause a blurring of the vision, decreased contrast sensitivity, and later on the corneal endothelial cells will be destroyed or decrease their function. Patients will develop corneal edema and even further poor vision. And what do we do today? Well, in the past we did, of course, penetrating keratoplasty, but approximately 20 years ago we started doing DSEC, where we could cut with a microkeratome a piece of the donor cornea mounted in an anterior chamber, and then the posterior part of the donor with endothelial cells, Descemet's membrane, and a little part of the stroma was used for transplantation. And for the last probably 10 years, the grafts have been cut in our cornea bank locally on the hospital. So it makes the surgery easier or shorten the time used in the operating theater. For the last 5 to 10 years, we have increased use of MEC grafts, where you peel off Descemet's membrane with endothelial cells from the posterior side of donor corneas, and also for the last more than 5 years, the technicians in the bank have been doing the peeling, and we just had to put in the DMAC graft. So if we look a little into the history of posterior lamellar keratoplasty, which is a common word for DSEC and DMEC. Some early attempts were done here in 1998, but it was not until DSEC was introduced in 2006, and in the US and actually Melis in the Netherlands started doing DMEC in 2006 as well, that penetrating keratoplasty actually was deemed a bad solution for treatment of Fuchs endothelial dystrophy. So over the years, it was learned that DSEC grafts, if you make them thinner, ultra thin DSEC grafts, then the patients will get better visual acuity. And there have been some randomized controlled trials in 2019-2020, and another one also from the UK, and that made us think that we will do another randomized control trial. So I will just tell you about the previous randomized control trials very briefly. We have one here from 2019, that was the first from the US, a randomized trial comparing ultra-thin DSMS stripping, also made in endothelial keratoplasty, with DSMS membrane endothelial keratoplasty. In 2020, there came out a multi-center randomized controlled clinical trial from the Netherlands. And then recently in 2021, this one from the UK came out. If we look a little more into the details of these previous randomized controlled trials of DSEC versus DMEC, then the thickness of the ultra-thin DSEC graft is shown here. They were below 100 microns and down to 63 microns, so fairly thin. The number of patients included in the randomized trials are listed here, a little more than 50. But if you look upon the status of the lens in the patients that was included, so in the US study, some had pseudophakic bullous keratopathy, some had cataract surgery at the same time, but it was not clear from the paper how many. In the Dutch study, all patients were pseudophakic before they underwent DSEC or DMEC. And in the UK study, simultaneous phagoemulsification and transplantation was performed. And the main outcome in these studies was to look upon what is the best corrected visual outcome after 1 year. In the US study, they found that the DMEC patients had approximately 0.1 log-MAR units, better visual acuity than those treated with DSEC, and that was significant. It corresponds to 1 line on the Snellen unit graph visual chart. In Holland and in the UK, they could not find a significant difference in visual acuity after 12 months. So it's not clear whether DMEC was superior or ultra-thin DSEC, and that's why we designed this study. So it is randomized, single-blinded. The patient did not know what type of graft the patient received. We had parallel groups, and then we had a control group because we chose to include patients that needed also cataract surgery. So they underwent cataract surgery and either ultra-thin DSEC or DMEC. And then we had a control group with a healthy cornea that just underwent cataract extraction by phagoemulsification. And the surgeries here were simultaneous. So during the same surgery, cataract extraction and corneal transplantation. And then we looked on the primary outcome, that was best corrected visual acuity at 12 months. And we also looked on some secondary outcomes, contrast sensitivity and endothelial cell density after 12 months. We included a lot of patients here. Inclusion criteria: patients should have endothelial dystrophy or cataract, and the exclusion criteria was AMD, diabetes, glaucoma, etc. So they had to be otherwise healthy in their eyes and in general health. All the grafts were prepared in the corneal bank. Here in Denmark, we use enucleation from the donor, and then it was prepared. The corneal scleral disc was incubated in organ culture medium and for up to some weeks, and we store the corneas at 30 degrees, and we can make sterility tests, etc. on the organ culture medium. Then the grafts were prepared in the cornea bank, pre-cut ultrathin DSEK with endothelium, a little Descemet's membrane, and a part of the stroma, aiming for below 100 microns. And they also, in the bank, pre-peel the DMAC grafts. Just to illustrate how this is going on, this is DSEK preparation, where we have the microkeratome down here, and we have OCT, so we can measure the thickness of the DSEK graft. And this is how DSEK is done, where we simply, just in a few pictures here, I'll show you, we remove Descemet's membrane on the top here from the recipient, and then we load the pre-cut DSEK grafts into a Busenglide, and we can pull that into the anterior chamber, put in an air bubble, and then in our clinic we leave the air bubble for 2 hours, and then we remove partly the air bubble to prevent increase in IOP. We do not do iridotomy in our patients. And what about DMEC grafts? How are they prepared? Again, it's done in the bank, where they simply peel Descemet's membrane with endothelial cells off, and they load it actually into a tan endoglide, meaning that, and fold it with the endothelial cell side inwards. So we simply get the preloaded graft to the operating theater. Here you see what's going on when we do DMAC in the patient that had already been operated for cataracts. So we are scraping here on the inner side of the cornea to remove Descemet's membrane, and after membrane removal, we have the preloaded DMAC graft in here. We put the endoglide into the anterior chamber, pull in the DMAC graft, which will unfold automatically because it's folded with endothelial cells inwards. And here you can help it a little with a small air bubble, and then we use a full air fill to make the DMAC graft attach. The patients were treated with, in the same way, the ultra-thin DSEK and DMAC patients with Voltaren, it's a diclofenac used for 3 weeks to prevent cystoid macular edema, and then they got tobramycin and dexamethasone for some weeks, and after that only dexamethasone. And the control group here, cataract patients, we don't use antibiotics after cataract surgery. So, but this is how it went. Patients were investigated, randomized, surgery. We looked after 2 hours, 1 day, 3 months, 6 months, and 12 months. Visual function was measured with standardized ETDRS charts. We measured contrast sensitivity as well, and we did specular microscopy in the patients. Here, counted the endothelial cells, and now come the results of this big work where we had 30 to 40 patients in each group. So the top line here, after 1 year, that is the control group. We can follow it here. This one, they dotted, that's DMAC patients, and this is the DSEK patients. And if you do a statistical analysis, you find that ultra-thin DSEK and DMAC grafts perform different. DMAC have approximately 1 line better visual acuity, and if you compare actually the cataract surgery in patients with healthy corneas, there was also a little significant difference. So those with a healthy cornea, they had better visual acuity than those with Fuchs that had received a DMAC graft. Contrast sensitivity shown here, same tendency, but it was not significant. We probably needed more corneas. But again, the control patients with healthy corneas had a bit better visual acuity than those that had Fuchs endothelial dystrophy. This is endothelial cell density. There's a well-known decrease here in the beginning. It was interesting to observe that, okay, the DMEC had a bit higher endothelial cell counts than the DSEC, but it was not significant. But those with a normal cornea, of course, had higher endothelial cell counts. So if we look on the summary now, and I have entered our study. Morten here is the PhD student that ran the study. My colleague and I did all the surgeries. So we had quite thin DSEC contours also, and we had 72, we had more patients included. They all had simultaneous phacoemulsification, and we did find that patients saw better after DMEC compared with DSEC. So in conclusion, DMEC provided one line better best corrected visual acuity than ultra-thin DSEC at 12 months after surgery, and not surprisingly, cataract surgery in healthy corneas provided better best corrected visual acuity and contrast sensitivity than DMEC 12 months after, while contrast sensitivity and endothelial cell density was comparable between DSEC and DMEC. Here you can read more about this study. The main article is published in British Journal of Ophthalmology, and then we have also a paper on intraocular pressure-related side effects after endothelial keratoplasty, and a paper on macular thickness after DSEC and DMEC. We are going to do some further analysis because it's interesting to search for what explains the difference in best corrected visual acuity at 12 months between cataract-operated eyes with normal corneas and those that underwent DSEC or DMEC. We have data from the pentacam, and we will look into previous corneal edema, posterior aberrations, individual thickness of ultra-thin DSEC grafts, corneal densitometry, whether this has an influence. And we have also measurements with the HG analyzer for each patient. So with these few words, I thank you very much for inviting me, and we have a congress in Prague in EU Cornea, and hope it will be possible for some of you to go there. Thank you very much.
Thank you very much thank you for all presenters, for all very interesting presentations. And now we may conclude today's day and prepare to the next day of tomorrow conference. Thank you for your attention. Thank you for your participation, and see you tomorrow.